Good morning, everybody. I'm going to start the meeting because we're running a little late. I'm Holly Stallworth. I'm the designated federal officer for this panel, the BenMap and Benefits Methods panel. And I'd like to convene the meeting with a reminder that we're operating under the Federal Advisory Committee Act, and that means this meeting was noticed in the Federal Register. There's opportunities for public comment. I'll be writing the minutes that are approved by the chair and posted on our website. Today, we don't have any requests for public comment, nor do we have any written comments. So it's kind of a quiet meeting. We do have an audience on YouTube, and I would ask those who are watching on YouTube, please send me an email so I can record your watching the meeting as an audience member in the meeting minutes. I would appreciate that. stallworth.holly@epa.gov. And if you're watching us on YouTube, you probably found your way around our website, but if not, go to epa.gov/SAB, click on meetings and events, and then click on today's date. And that's where you'll find the meeting agenda, the charge questions, which will be the basis of our discussion today and tomorrow. The panelists here at the table have hard copies of these. You'll find a link to request access to BenMap, and you'll find a link to the technical support document, which is also the basis of our discussion here today and tomorrow. epa.gov/SAB, click on meetings, click on today's date. That's how you find all the documents that we have. I think that's it for my opening statement. We're going to have a brief welcome from the director of the SAB staff office, Tom Brennan.
Hey, everybody. Welcome to the meeting of the BenMap and Benefits Methods peer review panel. I mean, this is an exciting day because this is the first time in 3 years or so since we've met. It was actually in this hotel in December of 2019 where we had our last meeting. So it's kind of poetic or ironic there, or whatever the right word is, but we're back here in this place to kick it off again. And just so you know, the SAB and the CASAC as a whole has a very busy agenda for this year, and we're moving to panel meetings face-to-face. And this is the first of probably 10 or so face-to-face meetings that we'll have this year. And I want to thank Drew for his leadership and helping me make this decision and moving forward. So thank you, Drew, for that. I'd like to thank Holly for being the DFO of this group. It's always a lot of work being a DFO. And I mentioned the entire SABSO team who helps put together the travel and the Federal Register notice and all the mechanical parts that make these meetings happen. A special thanks to our contractor and Dinah. They're helping us set up this meeting and also a hybrid approach because several panel members are online today for various reasons weren't able to travel. I'd like to thank the Office of Air. Peter Maniloff is here now, and Neil Fan is coming. Peter and Neil both, I mean, without your hard work, this meeting wouldn't be happening today. So thank you to your team for all the efforts you put into this BenMap model and how to calculate benefits and how to put that information into play. So thank you, Peter. I'm looking forward to a great meeting, and I'm going to hand it off now to Dr. Drew Schindel, our chair. Thank you, Drew.
If I could just say one thing, that for the mics, just like with Zoom, we want to keep them muted when you're not talking. Red means on, contrary to what intuition might suggest, but red is on, gray or whatever that color is off. Anyway, we can only have a couple of mics on at any one time.
We don't want to demonstrate positive feedback for anybody watching online, which I try to do in my classes. So thanks everybody for coming. I'm also really excited to see people in person. I understand that some people couldn't make it, and thanks for joining virtually. But this is a really impactful panel because BenMap is such an important tool in federal regulation. So I think we're doing something that is obviously taking time out of our regular schedule and all the other tasks we have, but I think we're doing something quite important. And I think it's going to be important that we tell EPA when the science supports exactly what they're doing, right? And that's a fine answer. If we're just saying everything you're doing is great, is also fine when we have suggestions for them. Either way, I think they've given us quite an important task to do and also a long task to do, right? If you look at the charge questions, there are 10 charge questions, but many of them have a great number of subparts. So there's really, maybe on the order of 40 questions. So I think one thing that's going to be very important for today and tomorrow is that we try to keep to our agenda, which, as you'll have seen, is a pretty sparse agenda and just says, go through the questions one after the other. But essentially, we have on the order of an hour for each question. And so for a question that has, 6 subparts, we've got on the order of 10 minutes, which means we can discuss the high level issues related to answering each charge question. But we don't want to delve down into the issue of, specific words or very specific details that will prevent us from getting through the entire thing. All right, so let's try to take good advantage of having everybody in the same room. I'm like Tom and haven't been to too many in-person meetings recently. So I think this will be both impactful and kind of fun to have people all together. And I'm looking forward to hearing from the EPA about, how we can best provide useful information to them. And then we'll leave here tomorrow, at least that's our goal, with a much clearer picture in all of the panel members' minds of exactly where we're going on every subpart. And in addition to where we're going, who is helping to lead each individual part. So I hope everybody will be willing and able to volunteer to help shepherd this large group forward on each different topic. And with that, I think we can go to, I guess, to Peter. Yeah?
Yes.
Where we might even have made up for my traffic delay, and I think are maybe back on time now. Perfect. All right. So back over to Peter Maniloff.
Thank you. Hi, I'm Pete Maniloff from the U.S. EPA Office of Air Quality Planning and Standards. I'd like to provide a few comments for framing, really. What are we here, and what is the EPA hoping to get from you? So the role of this part of the EPA, of the Office of Air Quality Planning and Standards, is that we produce estimates of the benefits of or the effects of air quality changes for the analysis of potential or actual regulations, right? So there's an internal slogan of we produce reliable estimates of important things. And both of those adjectives are important. And that's our goal. So can we have the next slide, please? So we produce tables like this, right? Ultimately, we're going to have a table that describes the change in air quality from some potential proposed policy. And there may be a variety of options. So this was from the proposed reconsiderations of the PMNACs issued a few months ago. I should note that these numbers are all subject to change if there are changes in the final. And there are a variety of scenarios in each column, and we have estimates of the benefits of these and estimates of the costs of these potential changes. The way we do this is typically we have two scenarios that we compare. This will typically be a new rule. It could be any of these 4 options, and typically a baseline, which might be a no policy change scenario. Other groups within the EPA will take those 2 possibilities, those 2 scenarios, and produce maps of emission changes, often over time, across the country. Other groups still will use those projections of emissions changes to produce projections of air quality across the country. And then BenMap comes in. We use BenMap, currently the legacy desktop version. We anticipate shifting to the cloud version. We use BenMap to calculate the change in health outcomes between the 2 scenarios, typically a baseline and proposed policy. And this could be, mortality, asthma cases, any number of health outcomes. And then we use BenMap to put a dollar figure on these and add them up. Next slide, please. That's why this group exists. We have quite a number of different health outcomes that we value. So the TSD is, and that's enough for this. Next slide, please. The TSD is the documentation for BenMap, the technical support document that we've given you. It's a guide to the details of all the calculations that BenMap does. In particular, it documents the epidemiologic data and information that we use, the concentration response functions, the valuation estimates, and input data, such as population data and incidence data. We have not asked for, and we don't intend to ask you for feedback on the specific choices that we've in the past in the TSD, the specific valuation estimates and the specific concentration response parameters chosen. The TSD also describes how we update those over time, right? Particular criteria that we use when there's new science published to use newer epidemiology studies or newer estimates of the betas of the concentration response parameters, new valuation estimates. We would like your feedback on these criteria or guidance on appropriate criteria. I see a comment. Yeah, the blank screen, that is the last slide. So there's no more slides. So we can shift off that for the audience. Thank you. Our hope is at the end of this process, we will have a set of criteria that we are comfortable with and that the SAB is endorsed that we can use to update in the future, so that in the future, as science progresses, we can continue to bring in new epidemiologic evidence and new economics evidence to always have the science embedded in BenMap be up to date. I want to comment a little on the environment that we work in, and sort of we can think of this as constraints that we face in a binding way, but really it's the professional setting that we're working in. And we follow guidelines, agency guidelines and federal government guidelines on how to conduct benefit cost analyses. Right? So this includes Executive Order 12866, Circular A4, the EPA's guidelines for preparing benefit cost analyses. There are others. So whatever counsel the board provides, we will need to interpret and respond to in that light. Many of y'all know these documents well. We're happy to discuss that in detail as needed. I also want to note that the agency faces resource constraints. This organization faces resource constraints. And there's sort of three that I have in mind. The first are the typical sort of staff time and funding. And the third is the data and scientific constraints. So time and financial constraints mean that we focus on outcomes that we think will be particularly quantitatively important to the decisions that the agency needs to make, to the regulatory and legal decisions. For example, mortality, right? Mortality has a large effect on ultimate impacts. And just as an allocation of effort, we tend to allocate effort more towards the factors that we believe will be more important. The data needs include spatially detailed population, demographic, and income characteristics. We have questions about these. To some extent, we are constrained to the extent that those data are limited, that limits the analyses we can do. And then the scientific evidence includes models and papers and parameters, linking exposures to outcomes and then valuations of those outcomes. And of course, we're able only to estimate and value changes in outcomes for which we have sufficient scientific evidence. I want to note also that those last issues, the data and scientific evidence, there's often more data and scientific evidence in the context of air exposures than in the other environmental settings that the EPA considers. Here, we're only concerned with the air exposures, so good for us. But when you're drafting text in the future, I urge you to just keep that in the back of your head, that standards which may be appropriate for air may be inappropriately restrictive or suboptimal in other settings. And we are here to consider how to do air, not to move to other settings that the agency works on. And then I want to close with a couple comments of scope. So from our staff perspective, we have not asked any questions about, in particular, the value of a statistical life's base value. And we consider that to be out of the scope of this study. Questions on how to update it, absolutely, we consider to be in scope. Also, and that's because in part there are other agency processes to decide upon the value of a statistical life that the agency uses. Similarly, there are other agency processes ongoing that are considering how the agency will analyze distributional characteristics of populations and exposures and distributional concerns. And so we have intentionally not asked how we should do that because we will be following the guidelines that have come from those other agency processes. So we ask you to keep that in mind as you're discussing. And with that, I will close. Dr. Schindel.
Thank you, Dr. Maloff. Can I ask actually just a very quick follow-up question, which I think might help us going into the health endpoints is, can you just say a few words about how the selection of health endpoints relates to the separate process of the ISA? Doesn't the ISA already make a determination about which things? So how much are we free to discuss health endpoints that may not have already been declared? I'm not sure if I remember the exact language, but something about indicative of being causal in the ISA.
Yes, thank you. So currently we use the ISA is a separate process that regularly reviews the scientific evidence and assesses the strength of linkages between environmental exposures and a number of health outcomes, and assesses these as being, for example, causal or likely causal or a variety of other standards. We estimate and the impacts of studies if the ISA indicates that they are causal or likely causal. That is a choice that this organization has made. That is a analytic judgment that we've made. We have a question, I forget the number, asking how we should consider studies for two different sorts of uncertainty. One based around the uncertainty in the scientific linkage between exposure and outcomes, and another based on uncertainty between outcomes and the valuation of those outcomes. So we would absolutely appreciate the board's guidance with those questions.
Thank you. That's very helpful. Wonderful. Before we get into then the routine of most of the rest of the day and tomorrow morning, which is going through the questions in order, are there any additional questions from the panel, either about our procedure over the next day and a half or for Dr. Maniloff?
I have a question for Pete.
Great.
This is Steve. Just to clarify what you said about the VSL, you said the base value is out of scope, but updating the value is in scope. Do you mean specifically updating for real income changes over time? That's certainly in the charge questions, or do you mean something broader than that?
I specifically meant updating for income over time.
Wonderful. Okay. Any other questions? If not, then I would suggest we, keeping in mind our very limited time per charge question, we just delve right in and we begin with charge question 1, which is related to health endpoints. And we work out like
We don't have
okay.
we don't have a separate lead, but we're going to hope to develop
Right.
that as we go along.
Super. Okay. So yes, we had talked about identifying leads in advance, and then I think we decided that that was a useful outcome of this meeting. And so we have Dr. Adams, Dr. Tiki, Dr. Kleeman is on video.
Yes.
Yes. Okay. Wonderful. Dr. McConnell, Dr. Needell, Dr. Newbolder, we just saw also on video. Dr. Pats, And Ms. Robinson right here. Wonderful. So we have the entire group who are nominally assigned to health endpoints. Why don't we, if that's amenable to everybody, perhaps we could just go around through the group of 8
Yes.
and get, what we had asked everybody to do was to think about some of the key issues that you thought would be important within the discussion of your particular endpoint. So we could just go straight through that. I don't see any harm in going in alphabetical order. If you don't object, Peter, as being, that puts you on the spot for being number one. But I mean, the other thing is we'll hopefully, we'll have everybody go and then we'll have a discussion, which is open to the entire panel, including the original, leads who are assigned to this point to make additional comments and everybody else to chime in. So if that's all right, over to you, Peter.
Sure. Last name Adams, I'm used to going first. It's the story of my life.
I'm not surprised.
Did you want to say something?
Yeah, I'm assuming that you want us to comment on all the subparts of the question. We're not going subpart by subpart on the questions. Is that?
I think that might be a useful way to start, just for in the interest of getting a lot of people's input, and then we can go through in order the subparts after. But
Yeah.
thank you for raising that.
Thank you.
I meant to ask that and then forgot, so thanks. So yeah, maybe I do air quality modeling, so I think other people on the list will have more insightful, more expert comments, but I'll just make a few of things that stood out to me. There was quite a bit of discussion about sort of what was the difference between a minimum acceptable and then a preferred study. And I came away from that with a lot of questions about how the preferred study part was operationalized. The stated preferences, for larger cohorts, et cetera, longer time periods, all made sense, but it just wasn't really clear how that was operationalized. There's parts about, I think this overlaps a lot with some of the parts later on uncertainty, so I'll save some of those comments for later. I noted a specific thing. There seemed to be some differences about short and long-term impacts on mortality for PM. It was chosen to not include both because of concerns about double counting, but for ozone that was done. Maybe someone who knows the ozone literature better can explain if that makes sense or not. There's a sub question about the range of potential benefits. So again, I think that overlaps a lot with the later question on uncertainty. And so I think we will talk a lot about sort of picking the beta values or the relative risk values. I think this is also in the later question about uncertainty about pooling or meta-analysis. So I don't know how much we want to talk about that here. Looking at some of the ranges, I noted, for example, that the range of beta values for ozone is sort of relatively lower than for PM. And so someone might naively take that to mean that we understand ozone mortality better than PM. I don't know if people would agree with that. I'm not an ozone person. My sense is that's not the case. And the last part was about the ISA. I think being strongly linked to the ISA makes a lot of sense. That's a Herculean effort that's very comprehensive. So I think those were my starting comments.
Wonderful. And thank you for, I should have mentioned, of course, that while we have organized the agenda as one question at a time, as we just heard from Dr. Adams, some of the questions overlap with others, and we will return to the broader topic of uncertainty when in a later question. So thanks for raising that. Okay, thanks very much. Why don't we go on to Dr. Dickey?
All right, good morning. I'll I think others on this question may have better insights on it than I do, but I'll tackle a few of these questions. I think in the nature of the endpoints considered, it's worth bearing in mind that hospital visits, hospital admissions, and emergency department visits are indicators of health effects. They're not themselves health effects. And in a related vein, the preference, I think, for broad versus narrow definitions of health effects, I think that's sensible for the reasons explained in the TSD. But again, I think it's worth bearing in mind that there could be significant differences in willingness to pay for different components or different causes of cardiovascular or emergency room visits. And granted, we don't know what those are or have any studies to support them. So there's no sense in disaggregating on the basis of thinking the willingness to pay might differ. But I think it's useful to bear in mind that that's a limitation rather than I would not characterize it as a unconstrained optimal choice. Yeah, in the selection of studies and the criteria for the selection of studies, I think others would have more insight on this than I do, but as I read it, there's a mix of concerns with what might be called internal validity, like confounding and other sources of bias, and a concern with external validity, like to what population might this, and then there's a concern for double counting. And all of those three are, of course, necessary to consider, but it might be helpful organizationally to sort of delineate between those to make it clear what's being considered where. And one question I had, I believe EPA will do its own meta-analysis or its own synthesis of studies when that seems to be appropriate, but all the criteria seem to be geared around primary studies. And I didn't know if a meta-analysis would be considered as one of the studies to support an externally done meta-analysis. Would that be considered as one of the studies to support the health effects estimation? So that's it. That's it for me on that one.
That's great. Thank you very much. And already seeing a little overlap between some of these. And great to have Dr. Maloff here in the room, because I think we'll end up at the end with some questions for you. Super. So we're going to go to Dr. Kleeman, who's on video.
Hi, can you guys hear me?
Yes, we can. Thanks.
Great. As I read through the TSD and thought about this question one, I guess I was struck a little bit by the objective versus subjective nature of the studies that would be included to estimate health effects. And I think to the degree possible, the document tries to lay out criteria and make it as objective as possible, but it still seemed to me to be a little bit strange to sort of be picking preferred studies. I maybe would have binned them into flawed studies and then studies that are good, and maybe just let the statistics sort of bring out the, through a meta-analysis or some other pooling of the estimates, rather than trying to pick the winners ahead of time. So it seemed more like a top-down approach rather than a bottom-up approach of just combining all the information in those good studies, maybe not the best studies. And so that kind of struck me as I read through the document about how the information is being used. And maybe we can have some more conversation around that. The other thing that struck me was one of the criteria in particular that Canadian and US studies are preferred. And that, again, I think was justified in the document on the basis of having representative pollution concentrations. Maybe we have very different characteristics in other parts of the world. But then later in the document, it also goes on to comment that there's no evidence that composition matters, that all PM seems to have the same impact on health. And so that seemed to be a little bit of a disconnect for me as I read through the document. Either, you have it one way or the other. I mean, if composition does matter potentially, as it sort of justifies early in the document when it says that US and Canadian studies are preferred, then I could certainly make the argument that the Southeast US has very different PM than California does. So it does Southern California. And so, if we're knocking out other parts of the world based on composition, then there's an argument for, maybe we should treat other parts of the US differently as well, because the composition is quite different. Or conversely, if we think that it's all PM's all equal, then why are we knocking out studies from other parts of the world? Seems like you can't have it both ways. So that seemed to be a little bit of an inconsistency in the document, for me at least, as I was reading through it. Then other comments, I guess, I'll just say something about the formal, cycle through the ISA of including studies. That certainly seems appropriate for, EPA's regulatory purpose here. But I think we should keep in mind that BenMap is a tool that's used for research as well. It's used in research studies, maybe more cutting edge, maybe a little bit more nimble than the regulatory, which is, sort of wanting to avoid mistakes. Research, I think, moves a little faster and can tolerate some mistakes in the interest of going quickly. So it'd be nice if it was easy to continue to adopt the latest, health impact functions that easily be incorporated in the model. And hopefully that's something that researchers could add nimbly to the model, not have to wait for 5 years for it to show up, but rather be able to introduce it quickly on their own. So that they can test something that came out last year, perhaps. So I wanted to make a plug for that. So hopefully that sparks some conversation, and we'll return to these topics and others as we move forward.
Thank you. I think that will definitely spawn some conversation. The points about usability of BenMap might be something for tomorrow morning, but let's keep that in the back of our heads. And I would also, just before we go on to the next person, say welcome to Dr. Neil Pham from the EPA, who's joined us at the front and will be able to direct questions to both of our EPA colleagues as we go forward. But let's stick with our plan, I think, even though I already have some questions and comments, and go on to through the list of people who have thought hard about health endpoints. So the next would be Dr. McConnell, please.
So I'm going to be brief. This is a global question, and I think this is a standard approach. It gets updated through the ISA revisions, and as sort of, as a generality, I'm not sure there's any clear alternative to the way that the agency is doing it. I think this is, this is right on target. And then when you get down into the details, there are a lot of questions and a lot of places where potentially there could be some improvement. And I'd second in particular Mike Kleeman's comments, and we'll get back to that.
Thank you. Dr. Needell.
All right. So I want to start first by saying I think BenMaps is an amazing tool. I've heard about it over the years, and to actually sit down and read through the documentation, I was kind of blown away at how amazing it is, just thinking how thorough, rigorous, and principally sound it is. So I'm really happy to be here, and I hope that, and any comments I have can hopefully help to and be part of this process to make it even stronger. I have a few thoughts jumping in. This is a bit related to Mark's point about thinking about hospitalizations as an outcome. And I think when we think about health endpoints, there's a lot of, kind of subclinical and transient impacts that are worth thinking about too. And I think there are ways, and some of this will bleed into other charge questions, like we think about productivity and human capital as ways of measuring some of those subclinical outcomes. But also there's a lot of work on like pharmaceutical use that I think is a good way to capture some of those outcomes. So I think that's another important range of health endpoints to try to capture, because those could be what I've been finding in some of the work I've been doing is that a lot of those subclinical impacts are happening at a much wider scale and not just happening for more susceptible populations. Like a lot of the mortality effects tend to be more susceptible populations, but these subclinical impacts are happening to almost everyone, right? Very few people are escaping them. So I think that's really important to think about capturing that. Another thing is thinking about the review criteria. I have to confess, I'm not familiar enough with the ISA process. But one of the things that I'm wondering about is that, a lot of this work on air pollution effects has gone out of sort of the traditional epidemiological field and has been done in a lot of other fields. I certainly see it a lot more in social sciences. So my question is how much of that work outside of epidemiology, traditional epidemiology roots, are being captured by these studies? So I can say, like, I know a lot of work is being done in economics, sociology, psychology, areas like that. And the question is, how much of those is that work being captured in these documents? I didn't see a whole lot of reference to it. It could be other reasons that they're not in there. Another thing is thinking about this was a comment that Michael had made about Canada versus the US. And I actually thought that one of the reasons you had said you didn't include Europe was because of really different, not just about PM composition, but about different healthcare systems and other things that may make how we respond to somebody's health insult being very different. But then I started thinking, but Canada has really different healthcare than the US too. I kind of thought either we exclude Canada, but if we include Canada, we include Europe, right? It seems like, it's kind of neither or both was kind of my sense there. Another thought was thinking about, and I wonder if this is where some studies don't come in, is you have this thought of needing a study where it has a unit change in pollution. And I think there are a lot of great studies out there that don't explicitly capture a unit change in pollution. They might get kind of a reduced form effect, or they might be getting a pollutant that we're no longer regulating, like something. And my question is, are there a way, we still want to utilize those studies because a lot of those studies have really good causal designs. My question is there a way of using those studies and trying to convert them into a unit change in pollution so we can kind of bring in some of that quality information there? I'll stop with that.
Great. I really appreciate all of the clear advanced work that people did in getting prepared for this meeting. This is terrific. Okay, we're going to switch to another of our video participants. Dr. Newbold, please.
Hi, I think I have I'll just mention two big picture issues that jumped out at me for this question. And the first one is about how the categorical determinations related to causal, likely causal, and then not quite causal, I forget what the other ones are. There's a few lower categories that are made, I think, in the ISA process, get carried through to the valuation at the end. So this is going to be relevant later, but I think talking about this part of it is in scope here. And in particular, I have in mind, my question is whether there is any way to put some quantitative estimates of uncertainty on those categories, or for specific health endpoint and pollutant pairs to facilitate, evaluation of some of these uncertain endpoints later on. So my impression is there's a lot of discussion about why certain health effects were put in these different categories. I'm wondering if it's not possible to take another step to quantify those uncertainties in probabilistic terms, at least it could be as, maybe the simplest version of this is to put probabilistic bounds on those categories. So at least we know what range we're talking about, and that could facilitate some kind of bounding analysis and evaluation step. Or if the agency could go all the way to sort of point estimates of probabilities of causality for these causal determinations. So that's one big picture question. The other one is about kind of reinforces what a couple of folks have already said in the discussion of preferred minimal and preferred criteria for selecting studies. I think almost all of those criteria that were identified and discussed make sense. I also have some questions on the margins about Canada versus US, or if some of these criteria could be relaxed if, you know, based on more basic primary criteria like similarity between the populations and other things that might be relevant. Once you pin those down, maybe that would allow other countries to be brought in if they meet those similarity thresholds. But I guess not the second part of this issue is it's not clear how specific determinations are made on a study by study basis. There's a lot of things that matter. And I think for the most part makes sense how the agency described why they matter, but how all of that gets weighed and translated into a determination of whether a study is in or out becomes, I guess, necessarily vague. So I just wonder if there isn't a more transparent and systematic and replicable way to do this while still maintaining enough flexibility for the agency analysts to use their expert judgments when it's important to do so. So those are my two big picture issues. I'll refrain from going further into the weeds for now.
Thank you, Steve. That's very helpful. Two more, please. Dr. Pat's next, please.
Yeah, first, I'll start that it seems like a lifetime ago that I can remember consulting with Neil Fan. So I don't know how long you've been working on this, but it's come a long way. It's amazing. And so my comment, number one, is I think it's extremely useful and detailed. And the only suggestions, for number one, really follow along Mike, what Mike's comment was, and also Matt reinforced regarding the minimum and preferred selection criteria. Mike talked about differences in exposure in California. My group was wondering about, why, like the global exposure mortality model, the GEM model, Burnett et al. 2018. That's, I know it's, you've got US and Canada, but that's something that we were wondering, if there could be flexibility as far as using, bending those minimum and preferred criteria to be a little bit more expansive in which exposure models you use. And that's.
Could you try again?
Thank you, Siri. So anyway, I'm just sort of ditto on what Mike already said. Then the only other issue is about the periodicity of review, and I know you're now set at every 5 years. It would be nice if that could be more frequent. I don't know. I know that you mentioned there's amount of staff going around that can do these things, but just that 5 years is a long time. A lot of science happens quicker than every 5 years. So those are my two comments regarding question one.
Wonderful. Always hard to get a bunch of scientists and not come away with a long to-do list after we make our comments. And Ms. Robinson, please.
I guess my job is then to make the to-do list even longer, which I think I'm going to do. So I wanted to build on Mark's point because I work in a group who, unlike me, does a lot of disease modeling. And it seems to me that there is a whole literature out there that we could use that goes from these from the endpoints looked at in the epi studies to actually get at disease incidence and at the different, the different ways in which they may manifest severe effects, all that sort of stuff. And I think to me, that's really important because for the benefits values for these non-fatal effects, we are only getting at a very tiny portion of the values if we look at medical costs. And in the cost effectiveness literature and in the disease modeling literature, I think there's a lot that we could use to try and get at the full health effects, which would give us a basis for doing a much better job on the valuation. And I'm not an expert in those models. I just hang out with a bunch of people who are. So I can't tell you what endpoints we'd be able to address or how far they could take us, although I could find out, I guess. There's a huge difference between thinking about how much it would cost us for somebody to have a day in the hospital versus saying how much that same person would be willing to pay to avoid or reduce the likelihood that they would incur the disease. I guess the other point, which I may have sort of said or at least hinted at, is that if we do the sort of disease modeling, we might be able to get a better sense of the extent to which there are better and worse outcomes among the affected population, and also things like distribution by age, maybe income level, or other measures of advantage and disadvantage. That's it. Sorry, this is not my area of expertise, so I'm going to stop.
Terrific. Thanks to all 8 of you for your thoughts and initial raising of several, many actually very important issues, but several that I noted that multiple people brought up. So I think we're in a good position to focus in on some key topics. Before we go over a little bit more about the issues just raised by these 8, I want to see if anybody else on the panel, even if you weren't assigned to charge question 1, when you were looking through the technical support document and thinking about your own question, since many of them overlap, did anybody else have thoughts related to charge question 1 that they would like to raise?
So first, should we just put our, I guess, put it up like that, or sideways? Just to say, this sort of gets on one of the some of the other questions, is that in terms of the endpoints to consider, I just think back, and maybe Neil, you might remember more on the history of this, is that at times actually the PA did discuss some of the suggestive. They may not have quantified it, but I also look at the way that BenMap is used in some of the uncertainty analysis, but you might actually further want to consider quantifying the endpoints that are suggestive, just because one, different endpoints move in and out of being likely and such. So just for that reason, as well as for being able to do a more comprehensive uncertainty analysis, it might be good to the degree that they can include other, the suggestive endpoints.
Thanks, Ted. How about Christopher?
So I just said one thing, kind of building on what Jonathan, I think Mike said, is that, and I think this is the right question, that in the US, looking at the US data, it says that, there's no evidence that it's not a different relationship from linear. But if you look at global data, it's pretty clear that you could not use the same linear relationship for the entire global concentration response curve. And so it seems like even though we're just really interested in US situation here, that you could use the information about the shape of the response curve that you get from the global data sets to perhaps yield information about what the shape would be in the United States.
Yeah, great point. Thank you. Any other input from panelists or online?
Just a quick
Neil,
clarifying
you
question.
said you had a follow-on question?
Sure. Thanks, Holly. I was surreptitiously texting her. I wanted to ask Ted a follow-up question about your suggestion. So when we think about suggestive endpoints, would you recommend we only quantify those that we can also monetize, or would you just suggest quantifying those that we had sufficient, for example, epidemiologic studies for, and that were also classified as suggestive?
The ones that are, I mean, again, you have so many more in the suggestive category, at least historically. So you might have to sort of decide which of the ones that are potentially going to have the larger monetary value, just so you can carry it through in terms of prioritizing. I mean, again, I hate to say it, I'm sort of the more the merrier, but there are ones that are going to have a bigger effect. And if I recall historically, that was the case, is that there was a suggestive that would have had significant impacts on a policy assessment. So they did talk about it at least down the road. So my answer would be, you're going to have to use some professional judgment as to which ones are potentially going to be game changers.
Can I jump in on that point? Because there's two issues here. And one is that when we do benefit cost analysis, the things that we can't quantify or monetize still should be, we still want the decision maker to think about them, right? So I think that to drop things just because we can't monetize them is not, I suspect none of the economists here would think that that's a great way to go. The issue though is that, like I guess Peter was saying at the beginning, the agency has limited time and resources. The question is, how do you get to a manageable set of endpoints? And it seems to me that for non-fatal effects, there's two issues. And one is how severe is the effect? Because the more severe the effect is, the more people are going to be willing to pay or care about the effect. But the other is how prevalent, because there's a lot of minor effects that are very prevalent. So you get a large number, which not only scales it up in terms of its impact on the benefit cost analysis, so you could quantify it, but it also means when the agency's out there answering questions and from stakeholders, they're going to get a lot of questions on things like asthma, because a lot of people have asthma. It's familiar. It's much less nebulous than knowing that you have a 1 in 10,000 greater, lesser chance of dying if they do whatever it is they're planning to do.
And I'll actually bring up, I mean, this again is historical. It was probably in about the 2000X reconsider of ozone. It was actually the number of asthma cases, they didn't quantify it. We weren't looking at the quantized benefits because that's not part of the Case Act discussions, but it was just the raw number.
Sure, numbers had some impact, sure.
I think that fits nicely with a point Dr. Nindell brought up too, about some of these effects that we might not be able to quantify so precisely, either the impact or the monetization, but they affect a lot of people, right? And they might still be quite important, like the pharmaceutical use might tell us something about how many people have asthma.
Could I ask just a
McConnell.
point of clarification from the folks at this end of the table, and that's this minimum criteria that they have to be US or Canadian studies. Is that, anticipating the next question we're going to discuss, is that a regulatory mandate? Is that subject to reconsideration? There's not something legislative about that.
No, it's reflective of, I think, what you could call best professional judgment on our part.
Maybe related to that, could you just clarify in response to some of the questions that came up, is the professional judgment that it makes the most sense to use North American studies because of the amount of exposure to total PM5, or is it related to the composition of the PM5, 2.5?
I would say not necessarily either of those. Historically, when we've selected among epidemiologic studies, we've preferentially chosen those published in North America and then the US in particular. partly because we're trying to find studies that are focused on populations similar to the ones affected by the policy in question. And it seemed a little bit of a stretch for us to be using studies conducted in Europe, because partly of the differences in healthcare system that have been mentioned, but there are other factors, including time activity patterns, for example, indoor-outdoor exposure, commuting. And so the sort of the macro level question we've always asked is like, how good of a fit is this particular epidemiologic study for this particular rule? And the further we go away from the US, the more tenuous it seems. Having said that, if we can develop a strong rationale for selecting non-US studies, non-Canadian studies, then we would certainly be interested in looking at that.
Thank you. Steve, okay, Steve Newbold online, please.
Yeah, just had a quick follow-up question for Christopher Tessum, who mentioned possibly using evidence from international studies about the shape of the dose response curve. Is what you said there true just about higher concentrations or also lower concentrations that are found typically in the US?
Well, I guess, I mean, I was when I was saying it, I was mainly thinking about the higher concentrations, just because if you extrapolate your linear dose response relationship to the level in China or India or something like that, it gives you a completely nonsensical answer, right? But I think also the lower concentration studies have usually been done in Canada, right? So if you want to only, restrict it to the US. And also, I think a lot of the studies that have done the lower concentrations have assumed some sort of nonlinear dose response relationship.
Thanks, Dr. Tessum. Dr. Needell, please.
Is this the place to give a justification for including Europe to keep that? No, okay. I wasn't sure how detailed we want to get at this point. So my feeling for justification for including Europe is that we have different healthcare systems in terms of how we access care, but we have the same healthcare technology. They use the same ways to treat asthma as we treat asthma. I don't know enough about how they would treat asthma or other conditions in China or India, or treating somebody on the verge of death. I'm sure that's very different. But in Europe, in Canada, in the US, you could throw Australia in the mix. We're treating, once the patient is there, we're treating them the same way. We might have different ways of getting the patient there. That's where the US is very different. And then the other thing is, you say, our lifestyles could be different in how we're exposed, but we know something like PM 2.5, it's everywhere, right? It works its way inside. So even if people have different commuting patterns, different lifestyles, that could affect the amount of time they spend outside. But I wouldn't imagine it has a big effect on the amount of PM exposure that they face. I think maybe the bigger concern, and I'm not even sure how much this matters, is that in a lot of European countries, we see much higher levels of PM exposure. I know sort of Nordic countries, it's much lower and closer to US levels, but France, Italy, Spain, their PM levels are higher than the US. It's probably like what we were like 20 years ago. But I don't know that that's a reason to exclude, because I think that's still kind of within that dose response that is pretty relevant for us. So that's my quick justification for including Europe.
So it looks like we're getting very close to getting some more specific sub-questions within the charge question, which I think we're going to be very good, including, the justification for different regions, and also this idea that was just raised, I think, by Jonathan about studies like GEM, which include both low exposure and high exposure regions. And, there's a bunch of data that is being excluded because it's either US, but not only US, or North America, but not only North America, or elsewhere. So that seems like one clear topic, which I'm glad we're making progress on. Ms. Robbins.
Matt's comment is an interesting one, and I have a question. So I was involved many years ago in the dark ages that I don't remember very well. and some of the work that led to developing these criteria. And I'm trying to remember, Neil, because it seems to me what you would want to do is have people who understand this literature come up with a list of the characteristics that most drive these dose response functions, age distribution, level of exposure, pre-existing health status, which may actually be as important or more important than the healthcare system, and actually compare the demographics of these countries against those features that you think are most important in terms of making the data transferable between countries. And I can't, was that done? Did somebody systematically go through and come up with a list of these things and decide that US and Canada were most similar?
So I'm not familiar with any studies that have done that, but what you're talking about sounds a lot like a meta regression, where you're trying to characterize the influence of specific attributes, particle composition,
Well, it could be
population
a,
characteristics.
yeah, it could be a meta regression, or it could just be a bunch of smart people who work in this area. I mean, not necessarily a formal expert elicitation, but just sort of saying, you know, of the 500 things that could possibly influence dose response functions, here are the, you know, the 5 or 10 that we think are most important and that we have data on, because it doesn't help to say that there's, you know, some characteristic of people that we can't observe. Because that seems fairly straightforward, I think. Maybe I'm naive because I don't know this literature that well. And your list, you could start with Matt's list and move on.
So Lisa, what you're describing sounds a little bit like the expert elicitation that was conducted in 2005, 2006, but maybe something
It's
slightly
not what
less
I
formal
intended,
than that. Okay. Okay.
But no, I was actually thinking, you know, I was thinking sort of more just it's almost like your criteria list. You would have, you know, how similar is the population? What percentage of the people have underlying, I don't know, cardiac or respiratory disease? What are the PM or ozone levels? I'm sure there's others that people know more about this than I do could come up with, and those are all, that's all data that we could pull and just compare, and then somebody's got to make a judgment about, yes, these two countries are similar in this dimension, or no, this number's too different.
Drew, could I ask for a clarification? Are we supposed to be covering all the subparts of question 1 at the same?
Yes.
Oh, I have some more comments. I thought we were just starting with A. So I want to weigh in on this, you know, this question of, you know, what's a, you know, the question of using studies from outside the US. I mean, I would really encourage you to rethink that. I think, you know, if you know, going and even studies from countries that might be quite different from the US. You know, somebody raised the question of China, where, you know, PM's very high and the dose response at high levels is going to be quite different from what it is at lower levels. But I think looking even data from an extreme place like really polluted countries, I think gives you a sense of what that dose response relationship is. And I think they, you know, if you know, there've been some papers, you know, there's a literature on this, you know, you wouldn't want to use really polluted places because the dose response is so different than at low levels. And I think it you know, the takeaway message is that the dose response is a lot steeper at low levels. And I think that's important for us. I think that's useful to have, to be thinking about in the background, you know, might not fit into sort of formally into your calculations, but at some point it might. And the other thing is the use of, you know, by not including studies from the US, there are key studies increasingly now, you know, maybe 40 years ago, all the research was done in the US, or most of the research, but, you know, increasingly now key studies for causal inference are done elsewhere. And there's not a lot of discussion in the TSD about, you know, using, you know, when you think about the criteria for better studies, I think those criteria might be different for causal assessment and for what studies you use for BenMaps. And, for a causal assessment, there might be one small study that really would nail down causality. It's got some biological characteristics to it. You've got a gene environment interaction. You've got an experimental study where, there's a natural experiment where, thinking about the Utah Valley studies where, the smelter went on and off and you could see what happened to the time series. I think that's a reason for using studies from other countries in terms of trying to assess causality. And then, in response to the issue of other countries are different from the US, I think there's, echoing Mike's point, there's as much heterogeneity within the US as what you see in other studies. You think about time activity, you go around this room, there'll be a huge range of people's time activity, probably as much diversity as you get on average between countries. So I think that's an important point, but I think it doesn't negate the importance of thinking about other countries. Sources, a lot of heterogeneity, as Mike pointed out, within the US. I think a useful thing for the future might be to think about whether there are different dose response relationships for different sources. That's a big task, but I think it's a reason to go out, think about using places outside the US. Anyway, that's sort of, I think that's a key point. I had a few other thoughts as well. I didn't see, when you talked about causality, I didn't see any discussion of, I mentioned gene environment interactions. I think of those as particularly strong studies, and maybe you get that from the ISA. It just comes as it is, but I think that's an important thing to be thinking about. And, again, maybe more to the ISA process, this notion of how to deal with the new literature around mixtures, effects of mixtures. I don't know how that gets translated into BenMaps, but I think for the future, it's an important consideration, that goes beyond co-adjusting ozone for effects of PM. So I did have something to say after all.
Great, thank you very much. Dr. Neptune, please.
I had a couple of comments. One is relevant to some of these respiratory endpoints. And there's going to be a major kind of revisiting of respiratory endpoints over the next several years because of the removal of race norming equations for lung function. And what the kind of downstream race norming equations for lung function. And so historically, there have been separate equations based on ethnicity. And the presumed downstream effects of that will be, there will be more persons of color that will judge to have subnormal or lower lung function by what some consider a neutral criteria, but that's a debatable point. So I think that the incidence of asthma in different communities will likely change. And the whole concept of a susceptible population will probably evolve, because what we know is that persons who have kind of pre-existing lower lung function are much more susceptible to second hits or secondary insults. So I'm not sure how that can be integrated into kind of the studies that we should be encouraged to bring in. But I definitely think that that type of data will be incredibly informative as to how we see these kind of health effects of exposure. The second issue I wanted to bring up, and I think Lisa kind of nudged up to this issue, is that as we think about the countries and the populations, whose data we want to include. I think the demographic profile is going to be critically important, and Europe is not as diverse as the United States. And I would suggest that there are countries outside of Europe, outside of Australia, if you don't consider all of the racial complexity of Australia and New Zealand, that are probably much more kind of similar to what we see in the Southeast, what we see kind of in the Southwest. And I think that consideration is going to be incredibly important as we start kind of conceiving of what the kind of health effects are and what the healthcare costs are that are attributable to some of these exposures. So just a couple of things.
Thank you. So I want to raise one issue then, since I don't see any hands at the moment, which is, it sounds to me like we are making good progress, especially on A and B of this charge question, which are the points of the question related to study selection, something we've been talking about quite a lot, on the difference between the minimum criteria, the preferred criteria, you know, how these are weighted, which things are included, where the study, the boundary of what meets minimum would be related to this question of countries. And are we using the US only or North America only? We have a couple of really interesting things, which to my mind, and I'm very willing to be corrected, sound like they are useful recommendations for ways forward for the EPA, things to keep in mind, like the influence of different components of PM, which will likely be something we learn more about, but I think most of the ISA and WHO and others have all concluded we're not quite there yet. Perhaps what we just heard as well from Dr. Neptune about upcoming changes in race normalized risk functions is something, again, that's just down the road. I think those then will help us advance, well, make a useful contribution. There are some things that I think we'll do our best to resolve with this, but that we might return to when we talk about the BenMap user experience, like maybe some of these issues of endpoints that the ISA characterizes as suggestive, but not convincingly causal. That's not quite the language, but you know what I mean. And this idea that BenMap should be easy for researchers to use, right? So there's a possibility of making the regulatory BenMap, and then there's additional things that might not go into the regulations, but researchers might want, or they might come with a different uncertainty, as some people talked about. I think maybe it was this idea of something is suggestive that it be included, but maybe have a different uncertainty than the things that are more clearly related. So I think we're making very good progress there, and I appreciate everybody's inputs. I haven't heard as much about subpoint C and D, and C was about whether a specific question about whether there should be multiple estimates of mortalities, and whether and a question about pooled versus single estimate. And I don't know if, okay, good, I'm seeing hands there. And then the D is this 5-year frequency, which I think, if I'm remembering right, maybe it was you, Jonathan, that mentioned that was pretty, that was not that frequent compared to the pace of science, but we know that there are resource limitations. So maybe if we could also just have a couple more comments on C and D, and then we can try to finish up this section by choosing leads for the different components of charge question 1. So I saw Matthew, Peter, and Jonathan, and Lisa on this side. Why don't we go in that order, and then we'll add, okay, Ted.
In terms of pooling estimates versus using the preferred, I think there's a bit of a tension here, and I kind of never know the right answer to this, but you can think of, like, you have multiple estimates, and then you want to do some kind of a meta-analysis to weight the different estimates, and you weight them by the standard errors to get kind of some central measure there. the problem I always have with that approach is that weighting by standard errors can be problematic if, you know, what you really want to weight by is how causal the study is, right? You really want to say, I want to put the most weight on what we think is the most credible causal estimate here. And often there's this trade-off between kind of efficiency and bias. So you can get a more efficient study with lower standard errors, better confidence intervals, but you may have less confidence that it's causal. So that's, you know, if you're weighting by standard errors to group estimates together, you might be putting disproportionate weight on studies that are in fact less causal, and they just have tighter standard errors. And unfortunately, I don't have a great suggestion, but it makes me lean toward thinking about, well, what's the most preferred estimate? You know, you would want to weight if the ISA gave an even longer list of criteria, more numbers than just a 1 through 5 scale on like how credibly causal something is. You'd almost want to weight by that. Say the more causal studies get a higher weight than the less causal studies. But if you're only using studies that are very likely and likely, it's only 2 categories. So I don't think the weights will quite work in that case. But it seems like that's the weight that you want to think about getting to. But I realize that weight doesn't exist. That's my thought on that point.
Thank you. We're not resolving everything today. So those kind of comments are still useful too. Peter, please.
Yeah, I mean, I'm thinking mostly about PM mortality, which is of course a big part of the benefits. And you know, you look at the top epi studies and the beta coefficients are different by about a factor of 2. And I don't care how great your criteria for selecting a preferred study, I don't think landing on any one of those beta coefficients is an acceptable outcome. So I think there's really only 2 things that you know are viable paths forward, and I think it's really important for this group to weigh in. Is either, you know, you go with kind of the 2 extremes as endpoints, is just sort of sensitivity, you know, relative risk of 1.06 and 1.12, something like that. Or you do some sort of central estimate as a best guess in a range. And I don't know if I have a strong opinion between those 2, but it has to be more than just, you know, let's pick one of those numbers because we feel better about it.
Thank you. I think Jonathan next.
Yeah, this is for component C about considering the guidelines on, well, whatever, C. Can't read it without my reading glasses. And it gets to your question about PM species, different toxicity, and this is section 6.5.5, differential toxicity of PM according to chemical composition. That science continues to accelerate, and I wonder where we are and anticipating getting to speciation of PM. And also, especially right now, as we're thinking about an energy transition and sources are going to be changing, hopefully rapidly. And so I just wonder if where we are in anticipating and incorporating the speciations of PM better. Because right now it says we realize this issue, but we just treat PM the same. We're not there yet.
Well, that's my understanding as well, but maybe there's a comment from our EPA colleagues here on thoughts behind that lack of speciation.
Sure. Actually, and let me respond to another comment from Dr. Nidell about causality specific to individual studies. So it's worth keeping in mind that the TSD essentially inherits the causality determination from the ISA. And the integrated science assessment doesn't assign causality on a study by study basis, but rather on an endpoint by endpoint basis. So within a given endpoint, it's up to us to choose among epidemiologic studies that are the best match for whatever policy question we're trying to answer. So that's the first thought. Second is with respect to toxicity, my read of the ISA is that Yeah, there's a lot of evidence that PM effects can differ by species and by sector, maybe even by season or by presence or absence of co-pollutant. The next question then is, do we have enough information to actually operationalize that process of estimating differential impacts within BenMap or any risk assessment? That second question is a lot more difficult to answer given the available data. I would look forward to advice on how to do that. But this question of how and whether the agency quantifies effects that are specific to individual species or sectors is one that we've been grappling with for quite a while.
Thanks, Neil. That's useful to know too, where the agency would specifically like some of this advice. Why don't we do the other side of the room, and then we'll see if we can get some closure on question one, please. So Lisa.
Oh, man. When I had to actually turn it on. That was the key. I don't know that anybody said this, but I think on D, I have no problems with the idea of 5 years. I don't know that there's any, any numbers can be arbitrary. 10 seems too long, 1 seems too short, so 5 is fine. And I'm sorry, that was pretty flip, but I think that's the best you can do. Feel free to argue with that though. I was a little bit puzzled by the reference to the OMB and EPA guidance in C, because there are some specific things that OMB or EPA tell you to do, which are routinely ignored. I often tell people to think of that as more aspirational. I feel like both guidance documents, what they're really telling you to do is think hard about what you're doing. It seems to me that we want to present the best evidence on what these relationships are, including the uncertainty. And I'm, as a non-expert in this particular area, I don't know what the right way to do that is, but it seems to me that focusing on a point estimate without doing some sort of work on uncertainty, whether it's pooling estimates or sensitivity analysis or something else, is misleading. What we want, whether they, a lot of decision makers want a single number, but we want them to do is to think carefully about the fact that there is no single number. There is some uncertainty around these values, and you need to take that into account in your decision making.
Thank you. Jonathan, please.
Thank you. Yeah, I was realizing this comment kind of fits as well with part B as it does with part C, but one of the advantages of going with the some kind of pooled or meta analytical approach is you can kind of explicitly evaluate the effect of different aspects of the studies on the risk estimate itself. I think that the best example of that kind of leads to what might be a nice criteria to add, which is there's a meta-analysis looking at the effect of the distance between members of a given cohort and the monitor that they were assigned to. And it showed that basically the closer the participants were to the monitors, the higher the risk estimate was, which indicates that there was a exposure misclassification bias. So I guess that's kind of both an advantage of going with the meta-analysis. You can look at these effects in the literature, and it might lead to additional criteria for what's a preferred study or not.
Thank you. Great points. Online, Matthew, please. All right. Michael, right? It's too small to read, and I remember.
Hi.
Yes, now I got confused there. Michael.
Thanks. So I guess I wanted to add my vote to the folks that are advocating for maybe a more formal way to treat multiple studies rather than trying to pick a few of the best studies. Sort of repeat something I said earlier, just let's create a pool of good studies that includes a broader range of estimates, and then come up with a formal way to pool that information. I think I would vote for that along with others that have already advocated for that. And then again, just repeating a comment I made earlier about the 5-year versus a faster cycle. It would be fantastic if BenMap could somehow do both. I mean, I recognize that for EPA's purpose, we have to be very careful and methodical, and a 5-year review cycle is probably right. But again, researchers would like to do things a little faster. And so if BenMap had a mechanism by which it was easy and obvious for researchers how to sort of take a study that they see and sort of add the health function and sort of be able to use it in that way quickly, then it would be great if the research community could have access to that. Perhaps that already exists in different forms of BenMap. There may already be instructions for how to do that. But I guess I just would make a plug to maintain that capability then as we transfer to the online version. This will come up later in the discussion, but I want to make sure that we don't lose any features before we fully drop support for the older version of BenMap in favor of the new version. Let's make sure that we don't lose any features moving forward.
Thanks, Michael. Ted, and then Rob.
And I think I have the same thing to say, but since we were specifically asked, in terms of how often EPA formally goes through the estimates and assessing causality, et cetera, for the health studies, I think tying it to the ISA makes perfect sense. For one, you don't really have the bandwidth probably to do it any faster. It's the same staff, et cetera. But again, that doesn't mean that updating BenMap. So, and I think that's the discussion tomorrow. But for your TSD type analysis, I think, yeah, doing it with an ISA makes perfect sense.
Thanks, Rob.
So just another comment on updating BenMaps. And I think that having more flexibility to BenMaps means that the research community can do your work for you. So, yeah, I mean, BenMaps could also, it's a tool that could drive policy. And, doing a meta-analysis, that's a big scope of work to ask you guys to do. I don't think, if there's something in the literature, you can use it. But I think if BenMaps had that flexibility, then you'd get people in this room and elsewhere doing some of that work for you. And I think that, it addresses this sub-question about how you come up with the best estimate. And I think, I think seems like there's an emerging consensus that it's a big part of the uncertainty, and, risk assessment is all about acknowledging uncertainty. So, some compromise might be to come up with what you think is the best estimate, and then to give some other estimates as part of the uncertainty. And the other thing about sub-question D, it seemed like, 5 years, 10 years, 1 year, it seemed like maybe from reading about, there's like a supplemental procedure that maybe you might do an update of something where, the ISA has, they don't characterize something as causal or even suggestive, but it's close. And it's a rapidly, you think about Alzheimer's disease or Parkinson's, sort of a rapidly advancing field. There's like a supplement mechanism to come up with an estimate. You could update it at 2 years or something for a rapidly, and just focus on that. Is that a tool that's available for you? I guess that's a suggestion and a question, maybe,
So if it would be helpful, let me see if I can answer that question. And there are two other points that I was going to make. So yeah, historically, we've not incorporated new health endpoints or new epidemiologic studies in between ISA publications. I mean, we might update, for example, estimates of population projections or income growth, for example, but altering either the endpoints that we quantify or the studies we use is not traditionally something we've done. We've largely for consistency, we prefer to remain tethered to the ISA. So it's the first thought. The second is, to the extent that it would be helpful, to give you a really brief bit of historical context around pooling. So when BenMap as a tool was first developed all the way back in 2003, there were very few, if any, multi-city epidemiologic studies. There were a large number of single city studies. And so those studies were often not sufficiently powered. And so you would end up getting risk estimates that had wide confidence intervals, sometimes that crossed the null. And the way around that was to pool across those single city studies. And the reasons, the second point I wanted to make, the reason we didn't do that with mortality was for a long time, there were only 2 long-term exposure cohort studies, or well, really only 2 cohorts. One was American Cancer Society and the other was Harbor 6 Cities. And it wasn't obvious to us how and whether it would be appropriate to pool across those studies, given really important differences in the demographic composition, the PM composition, the spatial distribution of those individuals. And so that's one reason we've reverted to reporting 2 estimates of PM related mortality. Finally, let me just ask a question. If the panel thinks it would be wise for the agency to pool across 2 or more hazard ratios from long-term exposure cohort studies, it would be helpful to know how we would deal with issues like differences in the age distribution of those studies. So how, for example, would we pool a Medicare study with, say, a study that's using the NHIS cohort if those age ranges are not overlapping, for example? Is it okay for us to be using a study, for example, that has an entirely different demographic profile than another study? So those are the sorts of questions that we would want to be able to answer before we began pooling across literature.
Thank you. That's also very helpful. Well, it seems to me we have a lot of input on many of these. The one other comment that comes to my mind, since I managed to not assign myself to any of these, I'm kind of free of generally making inputs, but there's this question of in 1C2, it says the mortality, whether the mortality estimates described capture the range of potential benefits. And when I think about some of these studies or some of the health endpoints that are suggestive but don't quite get there, effectively those are assigned 0. So you almost by definition don't fully cover the range because it might not be 0, right? Ozone cardiovascular, right? It might be just as big as ozone respiratory, and that range is not at all captured. But right, you can't include everything that you might not at all be related. So there is a tension there. And I think some of these suggestions which came up about examining at least some of the less convincing endpoints from the ISA are pretty intriguing. So I'm not sure if, okay, no, we can see you online now, which we couldn't before, which is nice. Okay, good. Now I've figured out why we can see you, because there's a hand up in the corner. Perfect. Okay, so let's have two more comments online, and then I'd like to get some names by charge questions. So how about Steve and then Michael?
Thanks. A quick follow-up question for Neil on the last point about how to pool when there's differences between the studies. Do you currently account for those differences in any way? Well, do you account for those factors of those studies when you apply them individually, one at a time, to the general US population? I think that's a complete question.
Yeah, so to briefly, for example, when we're estimating long-term PM mortality using a hazard ratio from a study that's examining the Medicare cohort, we would apply that hazard ratio to individuals age 65 and older. And then the baseline rates of death that we use to quantify impacts are stratified by age as well.
Did that answer your question, Steve?
I think so. Yes. Thank you.
Great. So Michael, please.
I guess I was going in the same direction as Steve on my line of reasoning, but then maybe Neil leads me to another question, which is if they really are targeting different populations, then it seems like they should be cumulative. That you should be, you know, if one study is dealing with older patients and one study is dealing with younger patients, then it seems like you would add the effects. You wouldn't necessarily consider them to be different estimates of the same thing. And recognizing that some of these populations may overlap in age, maybe that's hard to untangle. But I mean, maybe it just raises this other question about complexity and how to combine studies, I guess. So I don't have the answers to that yet, but just Neil's response immediately made me think, well, then these things are not different estimates of the same effects. They're actually cumulative effects on the population. Yeah, I'll leave it at that.
I mean, I think reasonable people could disagree about this, but in the specific example of long-term mortality, you know, we're drawing hazard ratios from cost proportional hazards models. So they are proportional to the baseline hazard. And the way that we're applying them is proportional to a baseline death rate in the population. And so you could argue actually that that they're not cumulative, but they're actually, I mean, the way that we're using them is as though these studies are two or more estimates of essentially the same thing, which is what is the incremental risk of mortality from a unit change in air pollution. And what I find remarkable actually is not how different hazard ratios are across these studies, but actually how similar they are. As an example, Medicare study that we use, the hazard ratio is 1.07. The American Cancer Society study that we used for many years, the hazard ratio was 1.06, which is an entirely different population. And so I guess we need to consider when we're applying these studies, and if we end up pooling them, does it matter, or how can we account for the fact that these populations, the demographic profile can be quite different among them, and you know, what does it actually look like when we parameterize those functions and put them into BenMap and run them and characterize the results?
So I think we will be able to delve further into our thoughts about recommendations and comments in response to the selection of studies in this pooling issue and such over the course of the next, what, about 4 to 6 weeks as we try to put together our response. We can certainly convene groups via, you know, online meetings and such. Don't have to travel every time, but it sounds like we're not, and nobody expected that we would answer these questions right here this morning. But it sounds like we do have, at least to my mind, a kind of clearer picture on where we want to go. And so what I think we might be constructive now is to try to get somebody, we have this group of 8 who are assigned to question 1. And if we had somebody who was the lead, who could collect the opinions of that group, plus we've had lots of useful comments from people outside the group, and those should be incorporated as well, of course. I wonder if people, especially people within this group, think that some of these overlap so much that maybe they should be kind of treated together. I mean, it seems to me, for example, that A and B are very much tied to one another. D might be sort of on its own. C, I'm less sure about, but if other people have an opinion there. Yeah. So maybe we could find, you know, we've had a lot of useful comments, essentially everybody on this Charge Question 1 team. Thank you again, has contributed to this discussion. And if somebody would be interested in leading this discussion about the selection criteria, which will include the issue of, you know, how to weight preferred studies relative to studies that kind of make it in there minimally acceptable, but they're not preferred, and how to incorporate values from different countries, all of these interesting things that have come up. I would say that's kind of 1A and B put together, which is describing how the approach for selecting studies is put together, and then what's done with that approach. You know. And-
You're asking for all.
Okay,
If somebody else wants to, I don't-
Matthew, thank you. No, I mean, I think one of the things to keep in mind, of course, is we need, it's hopefully not more work to really lead than to contribute, but we need somebody to kind of just be the point person for each of these discussions. And of course, since we're all assigned to, 4 or 5 charge questions, whenever you volunteer, then you're out off the hook for a few others. So thank you. We'll have Dr. Nudell for 1A and B together. That sound reasonable? Okay, and then C is, I don't know, do you think that's sort of falling in the same basket or distinct? That might be a slightly distinct.
Yeah, it struck me as sufficiently distinct.
Okay,
So I liked your grouping, they being like A and B together makes a lot of sense. C seemed sufficiently different.
great. Okay, that seems sensible to me too then. So the question 1C is the one we just had a bit of a discussion about this pooling issue and how to incorporate multiple studies of the same thing versus, single best characterization, and this issue of whether actually captures the range when either one or multiple values is given. So it is a pretty distinct question, but one that we didn't necessarily settle. And we heard from our EPA colleagues that they would actually welcome some discussion of if we recommend that you don't just use one study, how do you get the value and range that you should use, which maybe I'm misremembering, but I think that a fair number of meta-analyses have addressed this question in a more general sense, right? Not necessarily for the US specific ones that might meet the EPA's criteria, but this idea of pooling multiple studies. So do we have somebody who would be willing to be the point person for the discussion involved in 1C?
We have Steve Newbold has his hand up.
Super.
Which means, yes, I'm willing to.
Means you want to make a comment, right? Not volunteer.
Yeah.
No, go ahead.
No, it did mean I am willing to volunteer for that. That's my comment.
Super. Okay, thank you. And then the last one is this idea of the frequency at which we revisit. And it sounded to me like there we had only a few people really opined on that particular topic. But it seemed that several of us thought that either 5 was adequate, or that whether it was adequate or not, that's what the ISA did, and therefore we should just tie in with the ISA. Anybody, Jonathan, you had said that that was maybe not frequent enough.
Okay.
All right, thank you very much. So we and we will try to keep in mind, I think that's one of the things that Holly and I will spend our April on, is trying to harmonize all these things, and included in that, we will of course recognize that the EPA has limits on person power and time and such. So the more we recommend they do things, the more we try to balance that with recommending in other areas, maybe they don't take on extra. That is super. We are just, I think, at the point where we are ready for a first morning break with a comment before.
No, I was just going to ask a question on how the leads are going to work, and maybe you're going to talk about that more later. We can wait. I don't know if Holly's taking diligent notes here. I hear the keyboard going.
Holly is the keeper of everything organized, because.
So do we get those notes? Do we collate from that, or do we create meetings, or, if we're going to talk about the process?
I would say all of the above. Yes,
Okay.
I think you will get
All right.
all of the notes related to the entire meeting. And from those, you can of course pick out the ones related to your topic. And then you would have the liberty to arrange meetings amongst the charge question subgroup and Holly will facilitate that. Do you want to add anything?
It'll probably be a week before I have minutes, but I actually listened to the whole YouTube tape, the whole 12 hours of tape. And then I write the minutes. So they're very accurate with attributions. So that would be accurate, but it's going to take me a week to 10 days to do that. A lot. I drink a lot of coffee. Yeah.
That's actually wonderful. As I'm constantly looking back at my notes and thinking, now, who was it that actually said that? I remember that comment. Interesting. Wonderful. Okay, we are very privileged to have such wonderful support, both from our EPA science colleagues over there, our DFO, Tom, et cetera. And our EPA colleagues have provided us with coffee. So I would suggest we are pretty much right on time. We take our first break unless there are any other, Holly, any other comments? Okay, so we will return to this room and begin question 2 at 10:45. And we'll hear from the people involved there. And thanks everybody for a great start.
What university?
This is the list.
I found out during the break that this hotel no longer serves lunch due to low occupancy. So that's why you're looking at a list of restaurants in front of you. The shopping center right across the street is the closest. I think I'm going to check out the salad cafe, Terra Bonham Salad Cafe. But so you're on your own for lunch. In fact, for that matter, we're on our own for dinner. Some of us are going to La Victoria. But this is your best options for lunch is right across the street. And you have that list in front of you.
It's not, all right.
I don't know, Jonathan. You could probably go online and order online. Yeah, there's DoorDash.
Okay, we have, yes, we can ponder our, hopefully some interesting choices there. So let's go back to our agenda, please. And we would be on charge question 2, which is related to baseline rates of death and disease. And there are, as with charge question 1, several subpoints, but the overall topic, yes, is this baseline vulnerability. So we had 4 assigned to this question, and let's see, I know that 3 are here in the room. Do you know where is Christy?
Christy Pullen-Fednick was going to join us by, there she is.
Oh, wonderful.
Zoom.
Okay. Hi, Christy. Great. We've got all 4 then present. So we will go if that's people with early in the alphabet last names don't get too tired of this. We'll go in alphabetical order. We can reverse later on or something for variety. So why don't we start please with Dr. Bonocore.
Thanks. I guess wait, sorry, I'm on the wrong question here. For background health, I just had a recommendation that it's sort of, I can't read into like what goes on under the hood here, but it kind of seems like the concentration response functions get the most attention when going through one of these review processes. And I had a whole bunch of ideas for kind of, well, I guess first just saying that there should be some kind of just generic assessment of the quality and the coverage of the background health data, and then kind of updates where necessary. I guess first just asking like whether all the health outcomes there is in fact a nationwide coverage, then going through and examining the core geographical resolution of everything. Playing around with some of these data sets, have realized like you could have county level reporting, but every single county in a given state suspiciously might have the same background rate, which indicates that it's derived from something reported by the state. And I think similarly, there's a few health outcomes where there's still nationwide averages applied. And, you know, we know that there's a little more variability than that. I guess this was specific to looking at, I think it was the TSD. There's CDC mortality data from 2012 to 2014. It seems like more than that is available. I guess there's kind of a relevant question and balance between sort of how much time do you want to cover in order to get a robust mortality estimate over the course of years that's stable, versus trying to keep it as recent as possible. That said, I have no idea what to do with the COVID years. And I guess in general, the goal should be to be kind of as high resolution by age high resolution geographically as possible. And then there really should be a goal to kind of break things out by age, race, ethnicity, and cause would be nice. I know specifically there's zip code level data available from Medicare, which would cover folks over 65. And also there's a number of where kind of surveillance data isn't available. There are a number of synthetic population approaches that have been used to kind of combine census data with other things to kind of downscale existing low resolution health outcomes. And it might be useful to use those when you don't have other reported data available. And I'll stop there.
Thank you. That's a great start for our charge question 2 discussion. We will hear next from Dr. McConnell, please.
I mean, I think there's some challenges to the data that are available. And yeah, having these, having population on these sort of broad scales and then assigning an average pollution exposure to it, I think it's not optimal. I can't remember whether it pertains specifically to this charge question or to one of the others, but you can imagine where the fine scale pollution exposure that's now available across the country for all the criteria pollutants on a 1 kilometer squared or maybe even better resolution, you could have an average exposure to a population that is concentrated somewhere within that county or within that area where there's not much pollution or vice versa. So I don't know what the answer to that is. Maybe there's some, Jonathan mentioned some, possibilities for alternatives to it. But I think it's the right question. And I don't know what the answer is to it, but there may be people out there who know. And I think that's a real source of uncertainty to the estimates of benefits that you get. There's a question about race and mortality. I guess what about mixed race? What do you do with increasingly in Southern California where I live, there's a lot of mixtures of different races and ethnicities. I don't know exactly what you do with that. And then finally, in terms of projecting morbidity data, that's challenging. And I think as an example, 10 years ago, you would have thought that rates of hypertension would just continue decreasing for the next 20 years. You could make an assumption like that, and that would fit well into your projections of benefits. And it was a figure in the TSD showed, well, that's actually not true, and it varies by important characteristics. So I'd be selective about how you do that. You might be able to do it for some outcomes, but not for others. I'm not sure that's very helpful, but they're good questions.
It does start to answer the final question. Should they consider projecting all or some? Sounds like some, maybe, perhaps not all, but yes. Okay, good questions. Let's continue around the kind of virtual room, and next would be Dr. Pullen-Fednick, please, from online.
Yeah, thanks so much. Sorry not to be there with all of you today. I similarly had more questions than I think I had answers when it came to these questions. I think that they're really good. On the, part A, whether or not the ICD-9 and ICD-10 codes were reasonably or appropriately matched, it didn't, seemed like it to me, but it wasn't, particularly easy to be able to evaluate something like that. For question B, I also thought that the county level felt rather crude. I think that downscaling would be something that would be beneficial, but again, I didn't have specific ways in which to do that or how you could do that consistently or take into account, the inconsistency that will arise, because of that potential downscaling. But there's also, as was already noted, some inconsistency in the ways that counties are even reporting, some of the mortality estimates that the agency is using. For part C of the question, are the assumptions about projecting death rates reasonable? Similarly, again, this was also brought up. I didn't understand the use of the 2012 to 2014 CDC Wonder data. So I was curious as to where this came from. Did it come from that 1999 to 2020 data set? And these dates were pulled out specifically? And if so, was there sensitivity testing to determine, how much a baseline may have changed within different time frames, or just to understand, was it a resource constraint, in terms of time or other things? I was just curious as to where that came from. So I don't think that it necessarily absolutely needs to change, but understanding it. And again, I also don't know what to do about COVID. And so I think that's a really challenging problem that lots of groups and agencies are going to have to face. For the estimated, race and ethnicity stratified mortality, I also wasn't sure why the dates that were used for the race stratification was different than the overall baseline. So for race, the dates that were used were 2007 to 2016, but then for the overall baseline, it was 2012 to 2014. So it just wasn't clear to me from the documentation why there were those differences in dates. And, similarly, is it coming from that same, kind of macro data set from CDC Wonder? And if so, just giving some explanation as to why those dates were chosen, I think would also be helpful. And then on the morbidity rates, it again similarly seems like it would be helpful, right? So the morbidity rates can be, or costs can be quite high and impactful, particularly from a social standpoint. But even, if you say looked at asthma rates, for example, you could have a bimodal distribution in the ways in which those costs and benefits could be conferred. Both, folks that are in those middle age ranges, you may not see as much, impact, but in the younger ages and in the older ages, you will see more benefit from, say, preventing that asthma, or more costs associated with, exacerbating that asthma as well. And so, I'm not sure exactly how the agency could think about what those projections would be like. And, also, again, not really knowing how one would take into account COVID in this situation. If we're thinking, and we had some discussion earlier about pre-existing conditions, like if you're really thinking about projecting out what may happen from a respiratory or cardiovascular standpoint, knowing what to project, given that the entire world has been exposed to this agent that, increases potential susceptibility, to the effects that the agency is looking at, I think that could be difficult in terms of really trying to figure out and calculate those morbidity costs associated with it too. But again, it seems like it'd be helpful to do. I just don't have suggestions as to how to do it.
Wonderful, thank you. And nice to see you virtually. And the last one for charge question 2 here is Dr. Tessum, please.
Thanks. Yeah, to start out, I'd just probably like to reiterate what Christy just said, is that it seems like COVID kind of affects a lot of these things, not just for this charge question, but all of them. And so I don't have suggestions, but looking at the studies that are coming out that are after COVID maybe showing different things than the ones before. But other than that, it seems to me like a lot of these questions, there's like the EPA just doesn't have a lot of leverage in terms of, asking for more data. And it seems where you do have leverage, you're already using it, like getting the hospital counts or whatever. It seems like, so and so it was, at least from my reading, there are some things that weren't quite clear about the details about how it was being done, but I think one thing is that it would be important to use, so we have like stratified data by race, ethnicity. I think it's important to use that, even if we're calculating the total, the total outcomes for the population, because you want to use the incidence rate for different racial ethnic groups and different ages, and then add them up. You're probably already doing that, but I don't know. And then beside that, so there's some questions about projecting death rates. And so I guess one question is like, does it actually matter? So I know that like there's a lot of reasons why it's kind of imperative to give this dollar amount of benefits, and it's like, this is the amount of benefits, and we're rounding it to the nearest dollar, right? But at the same time, it was probably useful to, from a scientific standpoint, it's useful to like think about, which of these assumptions are actually like the ones that are critical. And so I know in the past I've done this type of analysis, and it kind of turns out that sometimes like the discount rate and the rate that income is being assumed to increase kind of equal each other out, and like you have the population growth, which kind of equals out with something else, I think. So like in the end, it doesn't actually matter what method, if you do any projection, or if you do no projection. And so, but I would say like that's kind of an empirical question. Any case, like, does this projection matter? And then I would say if it does matter, I don't think it's defensible to only use one projection, right? Because just, the future is very difficult, impossible to predict on the level of like where, what counties is a certain number of people going to be living in. Like, we just don't have a great track record of being able to predict that type of thing. So if we are doing projections, I think it would make sense to use like, the one is that's being used here is the census projection, I think, but there's another one that is more common in among academia, I think, which is like the shared socioeconomic pathways, which I think provides multiple different projections to account for this idea that we actually don't know. So we're just going to do several scenarios. And that's what
Thank you. I wonder if before we get additional input, if we might ask, there were at least a couple very specific questions that I'm thinking, especially of what we heard from Dr. Pullen-Fedenick, that I wonder if our EPA colleagues might have the answer to some of these, about like why the current setup uses those specific years that are used, and why they are not more recent, and why there is a mismatch between the race stratification and the other data.
Sure, I can answer those questions in general terms. It's probably fair to say that we lag by some number of years in BenMap. The mortality rates, the most recent mortality rates that are available. So if you went on CDC Wonder today, you would find reasonably recent death rates. And the rates that we're using in BenMap are older, partly because it takes us a little bit of time to update them, and partly because we're looking for a multi-year average to ensure that we can get a more stable set of county level rates. So that was the first thought. There's also, I don't know if it was your question or there's someone else asked this or made this observation that possibly it would be preferable for the agency to be quantifying mortality using race-specific death rates, which certainly makes sense. The question is whether you can still get stable race-specific death rates by age in each county, because you end up running into data suppression in certain counties. So there's a trade-off between using the most specific rates available versus rates that are stable and that haven't been suppressed. I feel like I might be missing another question though.
As far as I remember, there was just one question of why there was a difference in the years used from CDC Wonder for race stratified.
Yeah,
results.
and that was the reason. It's just a lag. I think at least a couple of people noted that COVID is clearly going to influence death rates, but probably the absolute death rate as well as the rate of death by cause. It's reasonable to infer that the respiratory death rate might be increasing due to COVID. Maybe just suffice to say the agency is aware of that as a source of uncertainty. And we have an effort underway determine how best to incorporate COVID-related death rates into our future projections of mortality. And Chris, I think you might have asked whether it actually matters, or what influence projected death rates have on total benefits. And at least pre-COVID, you could actually see pretty clearly that as the longevity of the US population increased or improved, other things being equal, benefits would decline. And that is because, of course, we're quantifying mortality relative to a baseline rate. And as that rate reflects improvements in health and increased longevity, again, other things being equal, you're going to see smaller benefits, smaller mortality benefits.
Thank you. Yeah, that's very useful. Just as an aside, I do imagine that you mentioned the different SSPs, and in some of those, the population ages quite substantially, which then, they might live longer, but still might have more impacts from PM reductions with an aging population. So that might depend on the scenario. Super. We've had, hopefully, Christy, that answered at least part of your specific question. Do you have?
I was just going to follow
Okay,
up really
great.
quickly. I think that the COVID pieces, and again, maybe it doesn't need to be, within this particular TSD because you're using dates that are before it, but even, as the agency is thinking about, some of these issues or even flagging, for future iterations of BenMap, that this is something that the agency will have to grapple with, I think could be helpful, because even just in reading it, COVID kept screaming out to me, to say how is the agency going to be, thinking about the integration of this kind of information, and then thinking about the directionality of that uncertainty, right? So if you have a respiratory illness that is, both exacerbated by, we've seen that, exposure to air pollution, for example, can exacerbate the effects of COVID, for example. So how do you take into account the fact that the thing that you're studying can also impact the mortality at the same time too? So, even just having little, nuggets, kernels within the TSD or some other documentation that just acknowledges that the agency is thinking about this, I think may also be helpful.
Christopher, please.
I just had a follow-up about the race or the demographic stratification, which is that so I think the issue is that within a county, you'll have variability in your pollution concentrations. And that variability will be usually spatially correlated with race ethnicity. And so if you use the total population mortality rate, that you will you won't be accounting for that spatial correlation, right? So, and then if you do use the race ethnicity stratified ones, then you'll be accounting for the fact that, the certain groups that are being exposed to more air pollution have these higher baseline incident rates. So, but the data suppression is an issue, but I think you can deal with that by using data imputation. So you could assume that, for example, the profile by age doesn't vary among race ethnicities, but the average does or something like that. Right?
Thank you. Okay, so in addition to the 4 who were assigned, and thank you all for your contributions for getting the discussion of charge question 2 going. Anybody else on the panel is now welcome to make comments. Well, we start with Lisa.
There's no unmute button, so now I'm really confused. Sorry, Holly, I don't want you to have to listen to all this stuff when you're 11 hours of tape, but I want to, I'm a little bit worried about getting hung up on the valuation piece for a couple of reasons. And if you look, so my understanding is that our charge is to focus on PM and ozone in a regulatory impact analysis context. And for most of EPA's RIAs, what you find is mortality dominates the benefits estimates. Benefits are much higher than costs, much higher than costs. And uncertainty in the mortality dose response functions or in the VSL doesn't actually change that calculation. There's always, Neil or Peter are going to tell me about some case I don't remember, but I'm not too worried as an economist about getting to the nearest penny on this stuff, because in the end, it's not clear to me how much it's going to matter for mortality. For morbidity, for the non-fatal effects, there's the 2 issues I mentioned earlier, and one is that people care a lot about these effects, even if we think they're small and they're difficult to monetize. So having just a count of cases, even if we can't monetize it, is good. The other thing, though, is that even if we did what I think Mark and I and others might have been suggesting, which is we're able to estimate cases averted rather than just hospitalizations averted and value them, the mortality benefits would still dominate. So which is all sort of a long way of saying, I don't think we need to worry too much about how this all affects valuation. I am worried about the lack of projecting morbidity in the baseline. This is a question for those of you who know more about this than me, but I would think that there are trends in morbidity rates over time that would affect the difference between the world without the regulation, the world with the regulation. That pretending, and I'm assuming that what you mean here, and you guys should correct me, is that if asthma incidence is X in whatever year is our base year, you're just assuming that that would be incidence going forward over the 20 or 30 years, right? And that, I mean, I would imagine there's things going on in the baseline that would mean asthma rates are going up or down or whatever, and that we should try and take that into account because it might affect that incremental difference. Uh-oh, I'm done.
Good, we're getting a nice discussion rolling. How about Jonathan and then Peter, please?
Considering that this question includes race and ethnicity stratified mortality, and also spatial resolution. One question I have is the co-pollutants issue that, for example, we don't have a good handle on sulfur dioxide. We don't have great monitoring of that. And who suffers from sulfur dioxide? It's people that live near power plants. And asthma rates in African Americans are very high. And some of those effects could be from SO2 and not from PM directly. So I'm just wondering about how do we handle that for this question.
Good question, Peter.
Yeah, on this sub question E, should EPA consider projecting all or some morbidity rates? I thought I was about to agree with Lisa, and then you changed tack. Mostly in the spirit of EPA has a lot of things to do and limited bandwidth, and with for better, for worse, a certain amount of the attention goes to the economic valuation, which is dominated by mortality. It seemed like a really time-intensive task that maybe was not a game changer. And I say that actually with a lot of sympathy towards the comments that were made earlier this morning, that like basically saying that morbidity is more important than we usually give it, shrift for, that like it's very prevalent. People care about it more than maybe the valuation, but it just seems like a tough task.
Seems fair. Chris?
Yeah, I would just to add to that, I don't know how one would go about projecting morbidity baseline rates, right? Because how, like you can project the life expectancy because you have good data on that, but how would you project how sick people are going to be?
Want to weigh in there, Neil?
Yeah, I was going to note that it's not easy. There's a small literature looking at approaches for projecting morbidity rates, in particular hospital admissions. And the agency's done a little bit of work to see whether the approaches described in the literature, which have been so far applied in Canada, could be in turn applied to the US.
Thank you. Other thoughts about the question broadly, or any of the specific points that have come up at this stage? Nikolai, please.
Related to question D about race and ethnicity stratified mortality, social sciences emphasize that a lot of the variation in mortality rates across counties and within counties is strongly associated with income. I wonder whether it would make sense to take that income heterogeneity into account in light of the discussion of effect modification in section 6, suggesting that low socioeconomic status is something that's modifying health effects.
Interesting. Lisa.
This may be sort of too far down in the weeds and something that we would want to talk about offline, but I am surprised at the comment about projecting morbidity, because it seems to me that people who work in healthcare need to do these projections all the time, because they need to think about how many pills are they going to produce, how much hospital capacity do they need, all that sort of stuff. So I'm wondering, maybe that's all proprietary data that EPA can't get its hands on. I don't know, but it seems like there's got to be some data out there.
Sorry, it seems like we're talking about a much longer time frame out in the future than hospitals or drug manufacturers would be thinking.
Just thinking about Lisa's point. I mean, in some ways, excuse me, I get both perspectives, but where I think hospitals may be making longer term projections is when they're adding beds to the hospital, right? So they are thinking about how much pharmaceuticals they stock, but if they're thinking about, I'm going to do an expansion here and I'm going to add 100 beds to my hospital, that's a massive investment for a hospital to make. Some of that's just about population changes and demographic changes within that population, but there might be more to it than that, was what you're getting at.
Yeah, I think, this could tying together what you're saying with the comment about not wanting to give EPA a crazy workload for something that ends up not being too important. It seems to me that this is just something that's worth, that's why I'm saying it's down the weeds. It's worth poking around. I mean, I would go, go talk to a few people who work in these areas, who work for pharma, who work for hospitals, and ask the question. And the other thing is that, I'm not, any projection that's going out 30 years is going to have huge uncertainty. I mean, all I need to do is think about what our lives were like 5 years ago to realize that. But it would be good to get at least sort of some sense of the trend line. And maybe not for all of the non-fatal effects, maybe just for those that are most salient in some respect.
I think if you wanted to, there's some things that we know are changing on a sort of on a slow timeline that affect outcomes 20 years from now. An example of that would be the obesity epidemic. Those are, big changes, big population changes, big changes in prevalence that drive these things. And it has implication across a whole range of outcomes. So, if you were going to pick an example, that might be one. And I'm sure there's a literature out there on what the obesity epidemic means for a whole host of disease outcomes, sort of morbidity as well as mortality. So I think that, I know, I don't know how well that fits with BenMaps to do it for a selected series of outcomes, but I think that's sort of a big problem, a big issue, satisfies the criteria that Lisa lays out of, is this going to have an impact on cost that's not at the third decimal point, So I think that might be a useful thing to do. And then I keep coming back to, I keep thinking about the discussion of, BenMaps sort of, there's the discussion about, what you guys need to do with BenMaps. And then there's what BenMaps can do for the research community. And I said to Pete coming into this meeting this morning, I thought, these guys have a big task, a big problem. We shouldn't tell them what else they need to do to make BenMaps useful for us. But I think you could harness the research community. If you make those tools available, you could harness the research community to help you with, it would be an interesting paper to think about what the obesity epidemic is going to do to air pollution related morbidity and mortality, and what the cost would be. That, you don't have a staff to do that, but people around this room could do it. So I would think about how you, instead of thinking of BenMaps as a research tool as a burden on you, think of BenMaps as a research tool that could help you do your job better.
Thanks, Rob. Enid?
Yeah, I would say that there's probably a better kind of exposure than kind of obesity, and that would be tobacco. And that's actually integrated into kind of the consideration of healthcare outcomes in the insurance industry, which ties in my other comment is, I would think that those projections are routinely done, I think, for the health insurance industry, where you have a panel of exposures of possible attributes, et cetera, that are associated with adverse long-term health outcomes. And I don't know if that data is accessible. I mean, obviously the actuarial data we are much more familiar with, but I don't know in terms of whether they actually have morbidity data that might be helpful.
Unrelated to several of these things, but I wonder if, in the spirit of raising questions, I wonder if there's a prioritization between higher spatial resolution versus more demographic information, such as race or socioeconomic status. And part of the reason is, I keep hearing things and seeing papers about how we have all this great information at 1 by 1 kilometer resolution. And I think I work pretty close to where I live, but it's not within a kilometer. I don't spend all my time within 1 kilometer. And so I don't know, is that too detailed? And so I wonder if, we should be considering the balance between, we could go to finer spatial detail, but what you were saying was sometimes that you lose information, right? And maybe the more important information is is not the spatial, but who's there. Just another thought. Chris.
Yeah, so I think a big issue is that there are a lot of things that go on within inside of a city that are important, just in terms of basically things tend to be segregated by where different groups of people live, even in neighborhoods next to each other. Right, where one, neighborhood could be over here that is very, in one way, and then you have another neighborhood that's next to it that is very different in terms of demographics, in terms of air pollution, in terms of services that are available, in terms of health, in terms of all that. So I think for that reason, it makes sense to push towards higher resolution, spatial resolution of everything, right? And so, you can say that if we go to highest spatial resolution with our exposure assessment, well, assuming that everybody stays in their house all the day long, then all of a sudden we're breaking that assumption because, usually a person would work in the same county that they would live in, they're probably, they probably work within the same 36-kilometer grid cell that they work in. They probably don't work in the same 12-kilometer grid cell that they work in. But I think it still makes sense to push the resolution higher in the hope that people that are looking at kind of exposure estimates are also innovating in that area to try to get information or make models about where people are going during the day. The other thing is that people do still spend probably around half or the majority of their time in their house. Right, so it's, I think you're not losing as much information as you might think that you would be. Yeah. And so, and also I think you don't necessarily need to trade off in between, having more, like, because of the privacy reasons that sometimes data are withheld at very fine, spatial resolution, and also like including all this different demographic information. But you can still, use different kind of estimation techniques to, and using, profiles of different things to just make assumptions about what these specific characteristics would be, even if the data are withheld at that granularity.
Can I just clarify one point on that? And maybe Jonathan should. So Jonathan and I did some work together a few years ago, and one thing that shocked me is it's true that Americans spend very little time outside. I was surprised at how little we do, but there's huge infiltration into our houses. So thinking that spending our time inside is protective is probably naive. Is that a true characterization?
Yeah, I wouldn't think being indoors is pretty protective unless you're like HEPA filtered and like sealed off.
So I think that depends on the pollutant. That's true for, it depends on the pollutant, it depends on where you live. So it's true for PM in the Northeast in the wintertime, because your houses are sealed. But for ozone, if you're inside, unless you're sort of running a fan through it, you get almost no exposure to ozone during the time that you're indoors. So I think it depends. I don't know that's useful for sort of what you guys do, but I think it depends that, indoor outdoor relationships very much depend on the pollutant.
Chris.
Just to follow up on that one thing. So if you go back to how all these things are calculated from the epidemiological studies, they all assume that you're spending 24 hours a day in your house, right? So any anything downstream of that should also assume that you're spending 24 hours in your house. And if you don't, then you should be providing some sort of justification for that. And so you can think about, like, if there's a scale mismatch, I think the epi studies usually do like county or something like that. It depends on which one. But so there can be that mismatch, but they're still fundamentally saying that you're in your house or sitting in front of your house 24 hours a day.
Ted, please.
I just say they're not assuming you're sitting in your house or in front of your house. They're just characterizing your exposure to your home. So that includes commuting, because there's going to be a correlation between your home and where you work, even if it's more than a kilometer, 12 kilometers away. So it's using an ambient concentration. So in some ways it takes in, this indoor outdoor penetration and all of that, just in terms of how they're actually developed. So that's something to keep in mind in terms of how we might phrase our discussions.
Thank you. Yeah, that's a good point. There's usually often one monitor, right, for the whole area rather than personal exposure, right?
One other thought on this, and that's that there's a new literature that I don't know well, but estimating from transportation surveys what people's commuting patterns are, not on an individual basis, but on a population basis. And I don't think it's not ready for prime time for BenMap's use, but I think it's something to keep an eye on, because at some point those estimates will be potentially available for the whole country. They're available in localized places now, and then that would give you a good handle on a source of uncertainty that you could use in your if on average people commute within 5 kilometers, then whatever your estimate is at the home is pretty good. Some parts of the country people commute a long way, and they might go from a low pollution area to quite a high pollution area, and that I think that could be quite useful and could have a big impact on your estimates.
We did talk this morning about providing guidance on future direction. So that's
the
very
spirit I
helpful.
intended it in.
I wonder if people have opinions on the idea of, were the agency to incorporate additional projections of something like morbidity, how they would respond to, I think it was Chris, you made this point about there are different stories of the future, right? Which can give you, use of one single projection might not be appropriate. So would this be a suggestion that there be a range of potential projections? Does that seem reasonable? And then Christy also has a hand, I see. So maybe Christy first, and then we can also think in the back of our mind about whether it would be a range.
Yeah, I was actually just going to comment on the last discussion we were having about future directions. I mean, there's also a lot of hyperlocal air quality monitoring that's happening. There's funding within, some of the big funding streams that are coming down too. So as the agency is thinking about, the ways in which to test the projections that are happening, if we started to do some of that downscaling, then I think those would be areas to really be keeping your eyes on and thinking about, especially in urban areas, but it's even expanding beyond that a bit too. So just wanted to flag that.
Thank you. Peter.
I guess on the future projections question, whether it's mortality or morbidity or whatever, one thing that the agency can think about is you can take these things into account without doing, gory detail, spatially resolved year by year, super time intensive. We've done just a little sort of back of the envelope thinking about, okay, if you go 20, 30 years out in the future, how do real incomes change and what does that do to VSL and willingness to pay? How much is population increasing? And so how much does that, and you can, just kind of back of the envelope, say these are like 30, 50, 60% kind of effects. And not have, gory detailed spatially resolved stuff in BenMap like Woods and Pool or whatever they're doing underneath the hood, but just say, we're doing a baseline projection with the current data, but recognizing that these things are changing, probably we would expect that the benefits are going to be 20 to 60% higher, something like that. Just kind of a simple at the end And that gives you the range, we don't know exactly what the future holds. And so it gives you the range without doing 10 shared socioeconomic pathways or whatever might be the most detailed approach.
Thank you. That's very helpful too. Is there am I missing a hand? Okay. So we do have the possibility. The question is all or some morbidity rates, but we are also, of course, free to comment on what level of detail and, maybe a more general projections. It's quite a reasonable approach. Are there other thoughts on any of the detail? Let's see. Right, appropriate spatial and temporal scales, race and ethnicity stratified, and projections and morbidity. I think we've really touched on all of those things, right? So, okay, maybe we should try to get to the stage. Right, there are a bunch of interesting additional comments raised during this discussion too about, for example, use of models and imputation where to deal with missing data and statistical models and such, which I don't see necessarily were obviously raised, but I think are good to include in our response there. Questions about this, the time period used, recent versus longer term. I think these are all very nice to have in there. Okay, so it seems to me we've had some discussion about E, which is largely a distinct topic, which is the projections of morbidity rates, which we talked about a lot. C is a very general one, the assumptions that are made. So I am wondering if it might be possible to group some of these middle components. B is the rates at the appropriate spatial and temporal scale. C, the projections, and D, race and ethnicity stratified. But that's not necessarily applying to the projections. So to my mind, it might make sense to group 2B and 2D together, even though they don't come in order. For simplicity of planning. And then C is projections of mortality, E projections of morbidity, and A is one that I'm always having trouble with because that's getting to the part where I never remember what these codes stand for. Does someone remember what?
Classification.
Yeah, but what are 9 and 10 specifically?
That's just the two most recent versions.
Okay, thank you. That's what I forget when there are codes for specific classes of disease versus the version of the whole classification system. That's what's right. Okay, thank you. So it's the entire system. That's why I was, yes, not making the connection right. Okay, so that's a bit distinct, I would say. But are people on board with the idea of potentially having 2B and 2D together, which is the rates are resolved spatially and temporally and by race and ethnicity? It would require fewer leads is my only thought.
But for the purposes of the report, I think we have to answer these questions sequentially, because when the
Sure.
board reviews the panel's report, they're going to get bent out of shape if it doesn't
Yeah.
follow the sequence.
That seems fine. What I was hoping then was we might have, if we have B and D together with the same lead, then we have the happy occurrence where we have 4 subparts and 4 people, which might make it a nice way to see if Jonathan, Rob, Christy, and Chris would, in any particular order, be willing to take on A, C, E and the BD pair. You four think that's a reasonable approach, Jonathan, Chris?
I was gonna say, I can take on, I'm probably the best suited for B to D just because I've never dealt with projections before.
Sorry, so you said
B
B
The
and
B
D,
and D
great,
pair.
okay, perfect. Thank you, Jonathan.
I hope for not A, I guess.
Not A. Not A.
Okay,
I-
Christy and Rob, there's Rob.
I don't have any particular specific expertise in E, but I'd take it on and,
E, okay.
yeah, I'd
More-
do some, I'll do
morbidity
some work and
projections,
see if I can
thank
come
you.
up with something.
I guess
Christy, are
that
you
leaves me with
interested in
A, right?
A?
Yeah, that's fine. I mean, really, it's just looking at the codes. I feel,
Thank
yeah,
you
I'll
very
take that one.
much.
Yeah, that's fine.
Okay, that's wonderful. So the rates, are the rates matched to each of the health outcomes in this international classification of disease thing? Which leaves you then, Chris, with C, if that's all right. Okay, so appropriate projections for mortality. Great. And I guess this all assumes that maybe I should have been clearer on that before, right? But the general idea, I think this was something you mentioned, Matthew, or asked about this morning, right? What does it mean if you're if you're the lead person, right? So we will get the notes, which will include all of these comments that we just talked about, you know, timescales that are appropriate, what to do about COVID. You know, I don't know exactly where that yeah, that might be in your area, Christy. Then maybe that goes most closely to, are the rates appropriately matched to the outcomes? Yeah, because it's not really a projection and it's not really a spatial or demographic issue. So that might go in A, but we would hopefully get all of the very interesting and useful things that we brought up into the discussion. And then we will, did you want to say, Holly, a little bit about, you know, timing since?
Well, I just pulled up the timeline, which I posted on our SharePoint site. We had said by March, from March 20th to April 3rd, lead discussants will work with the subgroup to prepare a consensus response. Actually, I don't know why I have us waiting till March 20th for that, but.
Well,
Yeah.
and then I think the idea, as I recall, was that the leads would kind of encourage everybody else within their charge question
Right,
to provide input to them.
individual comments, but we'll leave that to your discretion.
Right, but that could be in the next couple, you know, 2 to 3 weeks, everybody contribute to all of the topics in your charge question, and then the leads towards the end of the month assemble that all into one coherent bit.
Right. It will take me a week to 10 days to write the minutes. Also, the YouTube link is available to anyone who wants to listen to that particular section of this discussion.
Is there a particular reason why that April date is then? To me, this sounds tight, but maybe I'm just pessimistic.
Drew?
Was your question, why is it this
Yeah, I was
quick?
wondering whether, so I'm sort of thinking about, you know, we all have other jobs. And first you need to write up your own thing. Then you need to send it to everybody. They're not going to respond as fast as you want them to, even though they all mean to in their hearts. And then there's going to be.
Have you been
know,
involved
questions
in this
back and forth.
before?
It just seems very tight to me, having been through processes like this before. But maybe I'm just being overly pessimistic.
Well, it's, I wouldn't call it a relaxed pace. That's true. Yeah, well, when we first outlined it, it seemed like it was, you know, ambitious, but achievable. I think maybe we could revisit that discussion over dinner or something and see if that seems like it's still a practical pace. Yeah, I don't know that there's a specific, you know, hard deadline
Well, let's ask
from the
EPA.
agency, right? Yes, yeah.
You guys in a hurry?
Seems a little bit like a loaded question. I mean, other things being equal, getting advice sooner rather than later is helpful. But I also, I mean, I speak on behalf of my colleagues and understanding that everyone here is subject to scheduling constraints. So yeah, how about this? We'd like to get a quality product, obviously, and if that means taking a little bit more time to get it, then that would be understandable.
Thank you. Okay, so let's take on board this comment. We will ponder and come back to you with whether there's a revision to the
Christy,
schedule
yeah,
and
Christy on the
Christy.
screen.
Yeah, I just had one question actually for the agency too. So for the ICD 9 and 10 codes, right? So a COVID wasn't included in the ICD 10 code until an update in 2021. So the ICD 10-CM, but I'm assuming from the technical documentation that you were using the ICD 10 codes prior to that. Is that right?
That's correct.
Okay, so then, I mean, yeah, I don't know how I would like, but would you want recommendations about updating it to include, not say would you want it, but is it appropriate, or how to even ask this question, to think about the updated ICD 10 codes? Maybe that's a comment we could put in there or something, but how to think about that. Yeah, okay. All right, cool, thanks.
Terrific. Okay, so we will nevertheless, you know, if we decide it's practical to give everybody a little more time, we'll still follow the same procedure though, right? Where the leads will get input from all of those who are involved in that particular charge question and
And write
address
up the
issues.
consensus response.
Right,
yeah.
and address the issues that will be in the minutes that Holly will produce for us, and then put together a consensus response for each of the individual, you know, subpoints that we're going over. And then we'll merge that into a, you know, a panel report at the end, which everybody will again have a chance to look at, right? So it's not, none of these are final steps, but hopefully they all move us consistently in the same direction.
Right.
Super. Any other comments anybody wants to raise, or anybody online has anything to ask about charge question 2? Okay, it looks like we are making good progress then. Health endpoints, baseline, vulnerability. And after lunch, we will return to discuss population, valuation, and then with luck, uncertainty before the end of the day. So everybody has this sheet for lunch, and we will return here. Hopefully that even though we have to go out, we can get back by 1, which just gives us just a few minutes over an hour. And enjoy your lunch, everyone.
I don't have any sound. I don't know if you have mine. Can you hear me, Drew?
Yeah, I don't hear either. So
Okay.
if I hear you.
Maybe we need microphones on for you to hear us.
Yes.
hear you
Thank
guys.
you.
You hear us all right, Steve?
Yes, now. Okay.
Great.
Thanks.
Okay. Well, all right. It sounds like maybe we have almost everybody back. We've got our online contingent. We've got nearly everybody. Yeah, okay. I think we're all but one. All right, we'll hope we get our full group in a moment, but we can, I think, go ahead and start in the interest of time. We have two topics that we're going to try to cover, questions 3 and 4 in the next 2.5 hours. So although we didn't want to be too prescriptive and give so much specific times, obviously that's roughly an hour and 15 minutes for each one, and we're starting on the order of 15 minutes behind. So we've got just around an hour for each of these two questions. So let's please try to keep that in mind, but unless anybody would request a change in the style from this morning, or has any suggestions, we will continue, okay, with the same method where we first hear from those who were assigned to the specific question. We open it up, we try to discuss a little bit and bring things back to getting us ready for the next steps. So then without further ado, charge question 3 relates to population and demographic data, right? These shorthands on the agenda are very shorthand. There were 5 sub-questions related to specifics about the population projections, including, I think we heard on the, where was that? When we had a call to first discuss this, that
January 13th.
yeah, thank you. Well, like that back in month and a half ago, that the EPA had used Woods and Pool. Is that that was what was available, but it was proprietary, and there were some discussion topics brought up there. So hopefully we can cover that, as well as, the things that are specifically mentioned in our charge questions. So we have Jonathan, Enid, Christy, and Chris are the 4. And maybe since we keep getting those early in the alphabet first, maybe we can go in reverse order for once, if that's all right, which would make us start with Chris, if that's, please. So for charge question 3, thanks.
Okay, so I had a couple of things about these. There's a bunch of different things. But one of them was about the Woods and Pool data. And just by some quick Googling, which other people may have already done at EPA, but it looks like there is a group at Columbia that they're demographers, I think, that have a bunch of different population projection products. And one of them they have for the United States. It's again based on the shared socioeconomic pathways. So that could be something to look into. And so I think just in general, probably a lot of people would feel the same way, that it's something that, as we kind of discussed earlier, that it actually is important to consider. You'd probably be wanting to use something where you can understand how the process that went into creating it, so that there aren't, hidden assumptions that may not be something that that you would normally want to be using. And then the only other thing, as it seems like that you're using population data from the 2010 census, or maybe the 2020 census as it becomes available. And then for any years after that, using the Woods and Pool data to project. So it'd probably be better to use the American Community Survey data from the census rather than the Woods and Pool or whatever projection data, just because the American Community Survey is, it's not it's not as comprehensive as the decennial census, but it's probably better than whatever projection that they might be using, and it is like real data that they take they do real surveys. So that's I think that's right. Another thing is like it seems like there's US Census projections are used in a bunch of different places. So it could make sense, whatever kind of method you use is consistent among all those different places.
Thank you. So next we would turn to the screen, please, to Christy Pullen-Fidnick.
Yeah, no, these are also, again, really wonderful questions. And, I also had some questions about the woods and pool data. So even just, in addition to what Chris was just saying about looking to other places that are not proprietary, because it was difficult to even ascertain some of the methods, within it, right? Because the information available is really limited. There's also an update that they did in 2022. So I don't know, again, if there are resource constraints or anything like that, but, even just and that those projections, I think, go up to 2060 rather than 2050. I don't know if there's a significant benefit that would come from those projections and how they've, looked at, again, COVID and all of those other types of things in terms of their projections. But, even just being able to identify some other sources of data, ideally that aren't proprietary, that you could look into, or if you are utilizing this proprietary source of data, to consider, what the changes might be in that update. And whether or not that's appropriate. Again, we talked about some of that in the last question too, about having that stable baseline. So maybe, utilizing that 2014 data set for some of the other information to make sense to continue to utilize the same woods and pool data set. That was for question B. So for part B, for part A, the demographic information seemed appropriate to me at first glance. It would be good to just, again, be able to dig more into this. The descriptions weren't extremely robust in the TSD. So some of this is caveated by that. For subpart C, the age, race, sex, and ethnicity strata, so there was some information that came later on the document about how you were looking at different Hispanic populations and some of the ethnicity pieces. It was still a little fuzzy to me. I wanted to understand that a little bit more. And also thinking about the substratification of Asian populations. So we know that there can be distinct differences in different, Asian groups, subgroups. And so having them all in one, like aggregated it all into one subcategory didn't necessarily seem appropriate or in keeping with the current, kind of best practices. And then also this was flagged earlier about, multiracial folks as well. For subpart D with poverty status, I wasn't clear about how this was done. And so maybe I just missed it in the documentation, but I didn't see that in my review. So it'd be good to get a little bit more information about that. And then finally, other characteristics that this is in part E, that EPA should report stratified results. I was also, and we talked about this a little in the last question as well, I was curious about pre-existing health conditions. And so, even though these data aren't also perfect, but like the county health rankings, the CDC interactive atlas of heart disease and stroke, or the places data from the CDC. So whether or not any of those additional characteristics could also be brought in to help to think about, again, what a vulnerable and a susceptible population might look like, and how to ensure that your estimates are protecting those that are the most vulnerable as well.
Thank you, Christy. That's very, very helpful. Great. Let's continue, please. We're working backwards up the list, so that would be you. And you.
Yeah, sorry, impatient call. I thought that woods and pool, I totally kind of agreed with the demographic classification, age, sex, race for part A. I think race is always going to be a challenge for much of the demographics that we use, because it depends on how granular we want these designations to be, and whether that type of data is going to be readily accessible to woods and pool or whatever other data set we choose to use. In terms of B, there are alternative sources of projected population data. There's the whole issue of what's proprietary and what's not, and what are the kind of available funds to actually pursue these, even in a pilot effort, such as, compartmentalizing some of the kind of census.gov data. There are others like Situation and Outlook, REMI data, Constrained V3A, CDAC. It's hard to really dive into those without actually being granted access. And so if this is a true exploration, I think we would have to kind of go in and see what is available and whether those are superior to what's available at Woods and Pool. In terms of are the age, sex, race, and ethnicity strata and the population data used to quantify effects appropriately? The demographic data is somewhat detailed, and the problem is mixed race or multiracial population. But another kind of area that's omitted that I think is having emerging resonance is the issue of sex minorities and whether that's a designation that should be included in some of these population studies, because they are known to have very unique susceptibilities to various exposures. And there are a few publications actually showing that they have kind of higher rates of exposure and higher rates of kind of health-related consequences of pollution. D, are the data used to estimate the number of individuals according to poverty status, education, and linguistic isolation appropriate? I think these are nice and relevant variables, and I think they're ones that should be routinely used. And are there other characteristics across which EPA should report these stratified results? And, apart from the ones that were mentioned by others, especially by Christy, which I thought was very resonant in terms of comorbidities and kind of somehow being able to model this idea of susceptibility. I think these other kind of characteristics are appropriate and should be stratified accordingly. And that's it.
Great, thank you. And now, Jonathan Boncourt, please.
Thanks. Yeah, I definitely agree with everything that everybody else has already said. And I think my two biggest additional points would be first that there might be, in the absence of kind of good data from the census to get at sort of specific subpopulations, it might be close to as good to kind of use slices across two different sets of demographic data. So you could look at something by race and by income to get at a specific subpopulation of interest. So if you're missing like high detail data by race and ethnicity or something like that, using a hybrid of two different variables could get to more or less the same story. And I think for the second is on the topic of Woods and Pool, there does exist, there's both a peer-reviewed paper and a data set online that gives population projections by race and ethnicity through 2050 that are rooted in the IPC shared socioeconomic pathways that go through 2050. It's by county. And I mean, using it also comes with it sort of a risk of this becoming an uncertainty question because there's 5 SSPs, so there's 5 scenarios. So so it does a good job of reflecting real uncertainty for population growth, but can probably revisit that when we start talking about uncertainty.
Thank you. Yeah, that's great. We in my group we have tried to use some of those, and they are very interesting. And you'd think that they might line up. Well, there are 5 stories. We'll get 1 through 5, but they don't. Some have immigration, which makes the population younger, and some have shrinking, and they're just very interesting. But there's not one projection by any means. I wonder if it would be useful just to briefly ask back to our EPA colleagues if you have already thought of some of the suggestions that are being made here, like the I think that the Columbia, the season group uses, I think that's the housing for where the SSP projections are located. So if I understand correctly, that's one set of projections, and then the American survey. What's the middle word? Yeah, census, community, that's it. I was from the census, but called community, right?
The ACS isn't, it's not projections, it's just like more updates every several years. So it's like, there'd be an ACS for like 2020, it'd be like 2022 to 2024 or something like that. There'd be, so it's actually, they're doing surveys. Yeah, so they're just trying to get data that's more recent than 10 years, basically.
Okay, but it wouldn't substitute for something. Okay,
No, but it would substitute. So they're currently projecting from 2010 to 2023, right? So instead of doing that, you could just use the 2023 ACS, right?
okay, thank you. So that might actually answer the question of that I was going to pose about that, but the question I guess still might stand for the data that are the projections that are based on the SSPs. Have you already potentially considered those and thought about whether they are fit for purpose?
Yeah, we've done an initial look at that data set as well as a few others. But any advice that SAB has regarding population projection that you think would be most suitable for the types of analyses that we're performing would be welcome. With the proviso that we would need to be able to project population by race, age, strata, ethnicity, and sex, preferably by county as well. So in other words, they need to be at least as resolved as the projections we're now using, but preferably not proprietary.
Okay, and do we know, Jonathan, you were the last to mention those, so I don't mean to pick on you, but I know that they have things like age, but I don't know that they have necessarily race and ethnicity.
Okay, here's the abstract from the paper. Looking at breaking by 18 5-year age groups, male, female, 4 groups by race, for each US county. I think 5-year, can't find the intervals, but it goes up to 2050. And it's by county.
Great. Okay, so it sounds like we have an ideal potential alternative to Woods and Pool that we can assess in response to this charge question and discuss quite quantitatively what's available and how it compares to what you need. That's wonderful. Chris?
I had 2 other things that I forgot to say. So one of them is that there's kind of an increasing emphasis on intersectional identities, which could lead to intersectional exposures. So like looking at crosses in between gender and race, for example. And then there are, the issues with getting the high resolution data, but you can, again, you try to use the imputation or different kind of techniques to try to get that back. So that was one thing. And then the other thing was that I talked to Neil over a previous break and he mentioned that this would be useful to say, which is that, so the EPA for their social cost of carbon recently started including impacts to people outside of the United States. And the EPA is not currently doing that for health impacts. Even though you have people in one side of the border versus the other side of the border, and on the US side they're counted, and then the other side, the sister city or whatever is not. So one question would be in addition to what data for US people should be used, the question would be should data for other countries be included? And obviously there are many issues with that kind of methodologically and political and things like that. But because the EPA has already started to consider people in other countries for other parts of its work, it seems like it's a relevant thing to think about now.
Yeah, good point. Thanks, Chris. Any other So we have heard from the four assigned to question 3, but anybody else either online or in the room have anything to add about question 3? I see Michael online.
Hi, yeah, I wanted to pick up something that Chris mentioned. We haven't really talked a lot about spatial resolution yet, but I do think that that's an important consideration when thinking about the demographic data. A lot of the questions around environmental justice and exposures sort of, revolve or sort of go back to historical housing practices like redlining and things like that, and where neighborhoods sort of have concentrations of certain racial groups for various reasons. And sometimes it can be quite difficult to tease that out with large grid cells for both the exposure fields and for the demographic, to have some sort of appropriately fine resolution on both sides of that equation, your exposure fields and the populations living at those finer spatial resolutions can be really important, especially if you extend that into proximity to roadways and there the spatial resolution even over hundreds of meters can really matter. And so I think that there are important questions that we can't answer unless we acknowledge that we need higher spatial resolution to tackle some of them. So I just wanted to get that on record, I guess. I know that other people have different opinions about it, but.
Thank you, Michael. That's very well noted. Jonathan.
Yeah, along those same lines that Christy started, and just to get this on record, in addition to county health rankings, there's something called Neighborhood Atlas that brings in all these dimensions as far as equity. And I don't know, it's very high resolution, but it's something to just put on record. It exists. How do we deal with it? I don't know.
It's called what?
Neighborhood Atlas.
Great. Other comments, issues? One other thing I would raise then, since I haven't had my microphone on, since I was asking for others' comments, is that there's a little bit of work that I think is emerging on how you induce a mismatch when you look at projections and you have population as an input, and then you calculate how many people are affected by mortality, but that doesn't actually affect the population. So that you have a scenario, with and without the regulation, you have the exact same population in both of those. And I think that's something that probably goes in the future category. But I think that's something that BenMap could relatively easily account for. Only that if you have two scenarios, let's say you have one where current air pollution stays about the same, and you have another one where air pollution drops substantially, as an example, then you would not have the same population in those two scenarios, right? You're killing fewer people from air pollution. And yet when you run these, you have a fixed, an exogenous population, which goes into the model, and then you always get the same answer, right? And so you can, it's not going to dramatically affect your results, but there's, as I said, emerging literature that actually is a difference that you can quantify and account for. Right. Matthew? Then Matthew.
Yeah, I have a quick question. How is migration practices kind of integrated into these projection models? Is it considered to be kind of a fixed kind of factor, or how do you acquire the data? Because there's always that circular issue that if you improve air quality, the cost of housing will actually go up. You'll have the kind of immigration of people who have better jobs, higher income into an area, and you'll have the loss of people possibly because housing costs are up and property taxes are higher out of the area. So it wasn't clear to me, even looking at Woods and Pool, that phenomenon, which is quite important, is somehow integrated in trying to make these projections. I don't know if anyone's thought about it.
So we don't currently integrate those into our system. I mean, they're exogenous projections, and I think we don't know how Woods and Pool would deal with migration.
Jonathan?
I was just gonna say, the population data under the shared socioeconomic pathways does that to an extent. I don't know that they incorporate effects of like home prices going up if air quality increases. But I do know that they, in my brief Google when I was gonna go find this, remember that these population projections, they did get used to look at migration due to sea level rise. So if there was enough information, that kind of projection, it's possible that it could be built if it doesn't exist.
I think that's fair. And even within the SSPs, it's a little complicated because they tend to project one value for a given SSP, but then there's different levels of climate ambition within an SSP. So there are levels that are hard to take into account. And as far as I know, they have international migration is much more clearly estimated than within country. Peter?
Yeah, there's been a little bit of discussion around spatial resolution, but maybe just everybody agrees, but I just want to echo what Mike and Chris had said earlier about really, I think, critically important for lots of the analyses that we want to do around equity to have high spatial resolution. And I, totally agree with the comments made earlier this morning. People move around. They don't always stay in the one kilometer square grid, but I think it was Chris that said, that's something that exposure assessment can kind of catch up on. I think there are good papers sort of pointing at something like 1 kilometer is what you need to get stable estimates of equity disparity issues for a lot of things, at least.
Okay, any other general, kind of grist for the mill on this topic? Online? Okay, it seems to me we are perhaps not finding so much contention here, more, which is good. Sometimes we kind of agree. And so we seem to agree that the demographic information is largely the kind of thing that should be included, which is part A, but that there's some additional probing of the sources to ensure that they are the best available. That we've had a lot of discussion about the Woods and Pool and looking into alternatives for that. And I think C was somewhat like A, and we kind of agreed that the agency was already doing a reasonably good job of looking at the right things, and we might look at the same things but at as high a resolution possible, etc. For D, we didn't really talk about that one as much, did we? Maybe that means everybody was okay with it, or people hadn't focused on that one as much. Did anybody have anything specifically about D, which is the data used to estimate the number of individuals according to poverty status, educational attainment, and linguistic isolation appropriate?
Yeah,
Christy,
yeah,
thanks.
thank you. Maybe others saw this, but I didn't see how the information was utilized. I think that they're the right variables, but I just didn't see them. And so maybe others saw them. So, but if they aren't clearly articulated, then that would be a critique to be able to articulate how you're utilizing those variables.
Okay, great. That's good to know. So it might be that the data used to estimate these numbers are perfectly appropriate, but
Well, I mean, I
what the
assume
heck
that
are you
they were
doing with the
coming,
numbers?
yeah, like I assume they were coming from like the kind of social vulnerability index or something. But again, I just didn't see where, I mean, because there are lots of tools that utilize these metrics. And so I just wasn't sure where they were coming from, how they were being incorporated. Again, I think that they're useful and they should be utilized. I just didn't see the examples in the TSD. So I don't know if folks at EPA have could lead us or point us in the direction of being able to see that, but I just didn't see it in my review of the TSD.
Okay, great. Thank you, Christy. I had misunderstood what you were saying at first. So that sounds like that might be something that where you could follow up directly, and actually maybe Peter, you want to make a comment right at the moment even.
Sure. I mean, if I were to share just FYI, so those have been integrated into the legacy, the desktop version of BenMap. They come from the ACS that's described in briefly in section 4 of the TSD. Just as a matter of queuing software development, they are not yet used in the new cloud version.
Okay, but it's so that there should be some description of them and that they come from the American Community Survey. So that would be answer Christie's question. Okay, and hopefully, Christy, we can hear you.
Yeah, sorry. Yeah, and as the goal to, so if they're in the desktop version, but we're evaluating the cloud-based version. So do we comment on the fact that it's not then utilized in the cloud-based version, or, it'd be good just to get some additional insights in how we can be helpful
Fair
in this way.
question.
Yeah.
Sure. Yeah. So we're asking you to sort of comment on two distinct things, right? One is the analyses as described in the TSD and the data sets and such, and the other is this new piece of software, right, that implements most, but not yet all of those. So we haven't yet implemented some, is absolutely the case. That's something we plan to do.
And then is the methodology described in the TSD? So section 4, I mean, the section 4 is very short, right? So, I mean, maybe I missed it. Maybe it's in an appendix or something. But
Pete, if you could give page numbers.
Yeah, that would be great.
Christy's having a hard time finding it.
Sure. It's labeled page 80 or of the TSD. Is that the TSD or but we don't describe we don't describe it in detail.
Yeah, right. So
there's a paragraph that says we pull it from the ACS.
Okay. Yeah. But again, if we want to be able to determine how you've utilized it, if you've utilized it correctly, having some of that methodological detail would be helpful. Yeah.
Okay. Thank you.
So can I just clarify before, and then Chris, would it be appropriate then to ask for more details to include in our response then? And I mean, our response would then evaluate additional details beyond what's in the TSD, or we should only evaluate whatever it says in the TSD at this point? Like, can Christy ask you to provide her, an additional paragraph that allows her to understand this data a little bit more?
Holly, do we have any regulatory constraints about providing additional information?
No.
Then sure, email us if that's okay, medium, and we'll provide comments.
Okay, great. So it sounds like, yeah, Christy, you could get a little more information, which would prevent us from just saying the answer to 3D is we can't tell, right? Which wouldn't be very useful.
Yeah.
Right. Excellent. Okay, thank you both. Chris?
So I had a kind of a follow-up question on that, which is that I guess it's been a little while since I read a regulatory impact assessment in detail, but I haven't seen one that actually included data that's stratified by race, ethnicity, or kind of reported out separately. So would that be kind of like, would it be more of a perspective thing that we would be suggesting how to use it?
So this is delicate. So what we've been exploring past, we're interested in how we can characterize exposures, right? And to the extent that we think that the relationships between outcomes and exposures or valuations vary by characteristics, that's of interest to us, right? So if using more detailed population measurements by race or ethnicity or income or age, what have you, is a way to get more accurate results, that's something we want to know and we would appreciate guidance on. There's a tightrope, a fine line here, because the other parts of, there's not a strong distinction here between what I just described and analyzing disparities in exposures and such. And the agency has other processes ongoing, exploring how the agency will be doing that.
So it's more like, so I guess it kind of comes back to the question of like, is the evaluation the main endpoints, right? So one question would be like, is including all this stratified data a better way to get a better valuation? And that's sounds like more what you're interested in right now, and less in kind of, can this information be used to calculate other things of social importance, right?
Exactly. If using stratified analyses is a way to do better, to more accurate estimates, then that's of interest to us for the scope of this panel.
Can I just make one clarifying
Please.
comment? There's lots of reasons why having estimates stratified by different measures of disadvantage or whatever, however you want to characterize it, is useful and interesting to the agency, to decision makers, to stakeholders. So it's definitely worth doing. We don't have the valuation research that would allow us, in most cases, to differentiate values. Well, for cost of illness numbers, we might be able to say, you know, the average person in this category who has whatever the disease is, cost is going to vary depending on these different characteristics. But for willingness pay studies, we don't have enough that allows us to come up with distinct estimates for people who vary in terms of those underlying characteristics. So I would not think of the problem that you're talking about now as related to valuation. I would think of it as related to this very important issue, which is understanding how EPA's policies affect people with different characteristics, particularly those related to environmental justice and other issues.
Right. Valuation will be our next charge question. Yeah, so that's definitely distinct here. Great. This may just be me and
Mike Kleeman.
oh, super, good. Michael Kleeman online, please.
Hi, I just wanted to pick up a thread that I think Christy introduced, and maybe the group maybe can appreciate now after talking about all of the utility of being able to stratify by different, characteristics of the population. We had that functionality in the BenMap CE version of the program, but it's not yet incorporated in the online version. And I just want to advocate for, we need to fully support both versions until all of that functionality is fully transferred over to the new version. So I don't think there should be any data gap where somehow now we can't do something because an older version is not supported and it's not yet in the new version. So I just want to advocate for that policy, that we fully support both versions until all of that functionality is transferred over.
Wouldn't that be nice if every time you upgraded your software, something didn't break, right? I like that suggestion, Michael. So this may be just me, is what I was about to say, but when I read the sentence, what's that?
Christy was trying to jump in.
Christy, do you want to say something related to that? Go ahead.
Well, yeah, and I had one more question too that I don't know why I didn't think about it before, but is the agency utilizing EJ Screen or anything like that? I mean, because you can look at, the EJ Screen variables, even at the county level, but even at a finer spatial resolution. And so I was just curious as to whether or not there's any interaction at all between BenMap and EJ Screen variables, which aggregates a lot of this, right? So.
Yeah,
great question.
That is a really good question. The short answer is no.
Okay.
Yeah, in part because the two tools are designed to answer slightly different questions. Yeah.
But do you think that are there barriers to utilizing it? Again, if we're thinking about the ways in which, if we wanted to have relatively simple metrics in some ways to be able to look at some of this variability that's occurring across populations, and we can, look at percentile scores, for entire populations across, 26 or how many variables they have within EJ Screen, are there technical limitations to doing that, or, just how to think about that intersection?
Yeah, I mean, I appreciate the question. I wonder if we might be wandering into an area that the agency is separately considering, which is specifically how best do we characterize the distribution of impacts across populations of different race and ethnicity. So I could speculate, but I don't think that would be especially productive. So we might just want to leave it there. if
Yeah,
that's
and
okay.
I think it's okay to leave it there, but just to put a pin in the fact that, you know, there could be different valuation outcomes, right? If you know that there are populations that are, you know, highly, you know, exposed and, you know, also susceptible to the impacts, for example, of air pollution. And we're trying to get at some of that nuance in terms of, you know, the ways in which these costs and benefits are being, you know, added or taken away from specific populations. And so if there are ways, you know, even as the agency is doing this thinking, right, to again, either put a flag there that this is something that should be considered, to really start to you know, not just assume it doesn't exist and then keep moving forward, but to really think about those pathways for integration, and even just doing pilot testing might be something that would be worthwhile.
That's terrific. And that I think fits nicely with 3E too of these additional characteristics. So we have Rob and then back to Michael online, please.
Yeah, so I'd echo Christy and Mike's comments and Lisa's as well. I think, you know, a great way to think about this is not in terms so much of evaluation or valuation by different different subcategories of population, but as a way of getting at benefits that would redress historical inequities. And I think, you know, that's a priority for the agency. EJ is a priority for this administration broadly. And I think we should, you know, we should try and take advantage of that momentum. And this could, you know, Christie's suggestion could be a way, you know, an opportunity for BenMaps to shine in terms of being able to show EJ benefits to the evaluation that's being done.
We have Michael online and then.
Yeah, I guess the EPA staff have commented a couple times that there's other internal processes that are happening to address this. And so no one's explicitly said it yet, but I'm curious, is there other software? Like, is there a competitor to BenMap that's being created to do this? And somehow we can't go into that turf? Like, I guess I just want to out it. You know, what's going on here? Can you give us the inside scoop?
So we're not aware of or expecting you know, another piece of software, for example, a direct implementation. We are expecting agency-wide guidance on analytically how to measure disparities, what disparities to measure, what comparisons one might make, sort of that level of, we're expecting that level of analytic guidance. Perhaps it will prescribe particular data sources, perhaps it will not. I don't have any details there to share, but we're not expecting a distinct tool. We're expecting analytic guidance that will then perhaps will be implemented inside the BenMap tool, perhaps will be implemented, you know, as part of in series with that tool. We'll have to consider that when that guidance is available.
Thank you.
Does that address your question, Michael? Okay, great. Chris, please.
And I feel like maybe this could be thought about as a question of like the scope of the questions. So for question 3 or whatever question we are, it's like, what population data do we need to include to meet the current endpoints that we're quantifying? Right, but then one of the previous questions asked like, what endpoints should we be quantifying? Right, and it might make sense for the advisory committee to mention that, you know, these disparities among different demographic groups is an important endpoint to quantify as a benefit, right? That, you know, decreases in this disparity, you know, rate as a benefit. It might make sense to specifically mention difference in racial ethnic group exposures are as a benefit, especially in the context that it seems some of the guidance that might be coming down might be just saying not to consider racial ethnic disparities explicitly.
Other comments? I do want to ask one quick question because I've been puzzled. Did you have a hand up? No, okay. Which is, when I read A, which asks a general question about is the demographic information kind of the best available, to paraphrase. And then I read C and D. I don't, to my mind, that's asking about demographic information. I'm not, it's just not clear to me what A is getting at that is distinct from C and D being parts of demographic information. So I don't know if others on the panel have a different idea of how A, C, and D relate to one another. But when I read it, I think A is a general thing about demographics, and then C and D are calling out specific parts of demographics. And so I get a little confused. Any of either the EPA or the staff or the four
Well,
assigned to that?
well, my view is that A is really asking about the science as opposed to actually describing what other demographic detail might ostensibly be helpful and informative in understanding what benefits might be differentially accrued. But and so the best available science may not include all of those elements, all of those attributes. So I think it's very distinct from kind of those other questions that are much more kind of aspirational, if you will, of what you would like to see and what you would like to understand better.
Great, thank you. And that actually helps me a lot, Peter.
I mean, I think I took it how you initially read it, that A is pretty general, but C and D are kind of specific things, but called out for a reason because wanted to make sure that we commented specifically on these points and not overlook them and they get glossed over.
Okay, great. Thank you. I think that at least helps me see what we're being asked to provide as responses. Great. Well, if we don't have any additional comments now, I think we've had a nice discussion. We have a lot of, I have always a tiny subset of Holly's more exhaustive notes, but a lot of material here. And so we could go ahead with our, hopefully choosing people that would be willing to lead the different subsections. And I was trying to think in my head about how these might be organized, but they do seem distinct now that I understand a little bit better. So we had a good deal of discussion about the woods and pool. That might be a nice one to see if somebody is eager to have that be something they would be the lead. What do we call it? Discussant, something?
Lead writer for that.
Lead writer.
I can do that for the, the question that pertains to woods and pool.
Okay, so the 3B to Jonathan. And then we had some very nice points raised also about the additional characteristics, including things like this, the more susceptible or sensitive populations that EPA might want to consider for 3E. And so it seemed to me that if I'm remembering correctly, with all of the discussion we just had, that Christy and Enid both talked about that, but anybody might want to be willing to be lead for additional characteristics that EPA might want to consider.
Well, for D, for sure, I feel like I'd be happy to be the lead.
Great.
I'll reach out to get additional information.
D as in dog.
E
D as in dog.
Oh,
Yeah, D as in dog.
D as in dog.
okay, D as
Yeah.
in dog, perfect.
Yeah.
Thank
Okay.
you. Could, sorry. Thank you, okay. E as in Enid, that's an easy one then. I can remember this. Okay, so then what we have left are A and C. Any, I mean, it's not as if all of these are necessarily very long either. Some might be shorter and some might be much longer. Sorry, Chris, did you?
Can you speak around?
Oh, I think I'm the only one left, so I can do those two.
Are you willing to do, to be lead for both A and C?
Yeah, I mean, they're, as we discussed, they're not the same thing, but
They are related, right? So they, okay, appreciate that.
Thank you.
Chris. Great. So I think we have finished 3. Yay, us. Good. So let's, just, we all know this, but of course, when we pick somebody to lead, right, obviously rely on all of the other people that are making comments. And what I'm seeing here is that there's a lot of active engagement. So, maybe that's partially the beauty of people being in the same room rather than online where they can get distracted more easily. But it does seem to me like you have a nice community of at least, I think for each question, we have at least 4 people. So nobody will really be stuck alone writing the full response to any of these sub questions. Good, that leaves us with a somewhat daunting one, in my opinion. Not necessarily because of the topic, but just because of the number of subparts of question 4, which has A through J. It's a very long question. So we tried to account for that a little bit and assigned more people to 4, for example, than to 3. So we don't have, I guess that's what J is 10th letter, I think, of the alphabet, if I'm counting properly in my head. We have 8. So, it's about the same as last time. We had 4 for 5 and 8 for 10. But we have a lot of different questions here about valuation. And so why don't we push on and see if we can get through the discussion of valuation before we have, do we know if we'll have a coffee at the next break?
I don't think the coffee pot's going to be out there.
All right, so we will have it stopped raining, so everybody can have a quick jog around the building or something to get their blood flowing again after. Anyway, something to look forward to. We will try for a break. 3:30-ish, we're right on schedule. So that gives us, an hour 15 or something to talk about question 4. So we're turning from population to valuation. And I think we could just maybe go back, since we have several new people who haven't been assigned before, to go in alphabetical order. If that's all right. So that put you, Joe, there as our first one for evaluation. Thanks.
Great. Thanks, Drew. And thanks to the EPA staff for all their work on this. There's a lot of questions here, but there's a lot of important issues to tackle. As I noted to Pete over lunch, in my youth, when I was in the master's program just down the road, I spent a summer on the economic staff at OAQPS thinking through the benefits of reducing ozone pollution. So it's nice to have an opportunity to get back to some of this stuff. I'm not going to go through item by item these 8 questions. And in fact, I'm just going to make sort of 3 big comments. The first one I think is cross-cutting. The second is specific to a couple of the letters, and I'll flag that. And the third is specific to the shortest question, although I think perhaps the thorniest on these, which is letter J on the income elasticity on the VSL. The first one gets to this issue about what's the endpoint. So the way this kind of works is we've got this big integrated assessment framework. We work everything out, and then we get these outcomes, and we say, okay, what's the unit value of this health outcome and that health outcome? And I think we end up missing something that's important. And I think it was alluded to by Matt when he mentioned pharmaceuticals earlier. I think it was alluded to by Nick when he talked about socioeconomic status. And it's the fact that we're not actually accounting for the fact that people who have the means, at least, are finding some ways of mitigating their exposure to air pollution, and there are costs associated with that. So they're undertaking this adaptation. It means that they may not be going to the hospital, but by changing their behavior, they're incurring some cost. And that's hard for us to observe, but we have seen in some recent papers and literature where we have some evidence of that. So the Desheen et al. Paper that looked at the NOx budget trading program got proprietary data on pharmaceutical usage and actually saw how reducing NOx pollution through that program dramatically reduced consumption of pharmaceuticals or defensive expenditures. We ought to think about that as something that's beneficial associated with our air quality regulations. That isn't, I think the way this is organized isn't sort of a natural thing you would apply to this. I will admit it's thorny because I think these kinds of defensive expenditures or changes in behavior are cross-cutting across these outcomes. right? So like what I might do to reduce my exposure to air pollution is going to have impacts, whether I'm looking at mortality or lung cancer or maybe asthma, lost work days. And so I think it's messy. I just want to sort of flag this, that I think is something that we ought to be thinking about. Because if you look at like the Desheen et al. Paper, it's a big effect. It's about 40% of their monetized benefits. I would argue with them that it should be smaller than that because I think they're using the wrong VSL, but that's because I work on VSL. We'll hear about that in a moment. But I think also when we look at this in the Carlton et al. Paper on the mortality impacts of heat stress, I think it's close to a third of the benefits are their estimate of what they think are the adaptation cost. What people are doing, whether it's buying and running air conditioners or doing other things to avoid their exposure to heat stress, that is a big part of it, in addition to what is the mortality cost of heat stress. So I think it's something, and I, you know, maybe this gets to what might be my concluding comment, which is like, what's the research agenda? I think there's a research agenda on all these outcomes that we have cost of illness, and we'd really like to have a welfare measure on. But I feel like this is something we've been saying for like a couple of decades at least in this literature. So we can say it again. But I think really trying to think about where we can bring in some of our insights on the cost of adaptation would be really helpful and potentially quite meaningfully significant when we think about what it would mean to bottom line estimate of benefits of an air quality intervention through an EPA rulemaking. Second comment has to deal with sort of lost productivity and lost work days. And I think this is really important. I'm glad we're doing this, but I feel like there's kind of an apples and oranges approach to it on a couple of these different measures here in the analysis. So there's like one place where we're just looking at sort of what's median earnings, and we source it from, I think, the ACS, the median daily wage. That's on page 87 at the top. But then there's, I think on page 93, we're doing it when we're trying to think about if someone's got to take care of a kid who is missing school because of air pollution. We're now looking at a different source of their wage, but also accounting for their fringe benefits and overhead. So I think we're sort of calculating them differently, and I don't think we should be. But I think we also ought to be really thoughtful about what is it from a welfare perspective we think we're capturing here. And I think we want something that looks like the marginal product of labor, which in well-functioning markets, we'd say, I could just look at your total compensation package. Thing is, I think we've got recent literature from our friends in labor economics saying there's actually a lot of monopsony power out there. And so maybe what we're seeing as the wage isn't really fully capturing, there may be a downward, a biased estimate of what is the marginal product of labor. I'm not exactly sure what number I'd want to use and what source, but I think they ought to be the same. But I think it might be valuable to actually be a little bit more explicit why we think this is a welfare measure, what we think should be captured in it, and whether or not we think there's imperfections in labor markets ought to be accounted for and how we do an adjustment for that. I think that's something we're like, I don't know. I look at some of my other economist friends in the room who can think more deeply about this than I can. Maybe they can come up quickly with how we could do that. But I think existing literature, we could draw from that to actually produce a consistent approach to lost productivity or lost work days there. Please comment on the income adjustment factors that EPA uses to value endpoints. So I think there's a few things here. There's a few like minor things where I didn't quite understand the language in here. And when we write up our comments, I'll send that in. But I think there's a big issue here. I know we're not talking about the VSL base level here, but I think we need to take into account this is a very dated pool of studies. So these 26 studies, the most recently published paper is 1991. The average publication date is 1985. In my youth, I read every one of these papers. So one thing is, I think there's a little bit of sort of discomfort, but I realize it's beyond our scope of like, I don't think these papers really meet the standards that we would be applying to what papers ought to be cited in other parts of this document. Okay, I just want to say that. But the big thing here is if we're going to do an income elasticity adjustment, it raises, I think, two questions. I think one is this issue of how we apply the adjustment, and the other is what elasticity we use. So here's on the how and where I think EPA has been doing it wrong. And not that I'm asking Holly to remember a Zoom meeting in 2020, but I made this comment in 2020 when we were doing the economic guidelines. And is in our final report on the economic guidelines in that SAB panel. So the approach that EPA has been doing is to say, we have this estimate of 4.8 million, and I think $1990 that was originally done in part of the 812 process, part of the ozone PM NACS process of 97. And we update it for inflation. So we put it, whether it's $2015 here or whatever base year dollars you're going to use for your RIA. We've not done any income adjustment between 1985 or 1991, or if you want to say this is the Viscusi 92, whatever year you want to be doing an income adjustment from, we haven't done that to today, or whenever we're doing this analysis. But suppose we're doing an analysis of regulation today that's going to have an impact on air quality in 2030 and 2040. We start doing an income adjustment with a projection of changes in per capita income between now and 2030 and 2040. Now, if you're doing this in 1997 for the 812 report, that's not a big deal. If you want to say what's per capita income in the US in 1985, although 5 of the 26 studies weren't US based, but setting that aside, take it 1985 income, compare it to today's per capita income or 2022's per capita income, it's a change of 80%. Right. So like if you want to use an income elasticity of 0.4, which is what's in the document, that would suggest that we would just to get to today, not just doing the inflation adjustment, but doing an income adjustment from when these studies were done to today is a 32% increase in the VSL. That's kind of big. If I wanted to use an income elasticity, a different income elasticity, throw it out there for purposes of argument, because I think we're going to talk about it. An income elasticity of 1. That's now talking about a change in the VSL of 80%. So that's a lot. And I don't, there's going to be some discussion about how we do the income elasticity as well, of like, are we just doing it over time, which has been the practice in the past at EPA? Do we do it across space, which gets very politically fraught, as your friends in another part of the agency are finding out in the social cost of carbon work, where they are adjusting the VSL across the world by income, using an income elasticity of 1. But I think, if we're going to be doing it over time, I think we ought to be doing it from when these studies were done to today, and then keep doing it forward. If we don't do that, what we end up with is this kind of weird thing where like whatever start year I had, I could look at multiple regulations having an impact on air quality in 2035. But if when I did the analysis occurred at different points in time in the past, and that's when I started doing income adjustments, I actually end up with a different VSL applied to a change in mortality risk in the same year. And I don't think that's something you want to do. So on the question of the choice of the elasticity, I think 0.4 is low. I think, there's in the late 90s, early aughts, there were a number of meta-analyses looking at the income elasticity. None of them were as low as this. In the review that Kip Viscusi and I did, we replicated 4 other meta-analyses. We produced our own. Those were all in sort of the 0.5 to 0.6 range. There have been more meta-analyses since then that suggest that for the US, it might be like, I think one of the more recent ones Kip has done with one of his former students was like 0.5 to 0.7 for the US. There's others that suggest when we look globally, it's maybe closer to 1. What is being used by EPA and the social cost of carbon is an income elasticity of 1. What the IMF is using in their work is an income elasticity of 0.8. I think we can do like a really thorough job reviewing the literature. Thanks to Nick and Lisa for actually pulling together some of these papers in our I'll call it Dropbox. I don't know. What's it called, Holly? What are we using? The SharePoint. Yeah, our SharePoint. Thank you. So I think we can do this and have a better sense of sort of where the literature is, but 0.4 strikes me as a bit low. And the last thing I would just say is, as an economist who wants to think about what are the welfare impacts of reducing air pollution, the fact that so many of our non-mortality impacts we're still using cost of illness is kind of frustrating. Maybe this is a question for Mark about the CV literature. I mean, I kind of thought that like this is what Trudy and JR were trying to tackle with their work, and maybe it's just not quite on point, and maybe it's not specific enough to these results. But I just wonder whether or not we've got anything from contingent valuation, from stated preference studies that might allow us to say something a little bit more than just using the cost of illness. But since I'm the first of 8, I talked too long, so I'll stop now. Thank you, Drew.
Thanks, Joe. Yeah, this is very, very useful. Well, you just mentioned the cost of illness question, and maybe Mark would have comments on that. And it looks like, Mark, you are next on the list anyway. So please, valuation.
Okay, valuation. So you might hear this 8 times, but yeah, the cost of illness, if you want to do those health endpoint, health occurrence, non-fatal effects better, it's going to have to be, there needs to be a strategy to get out of the cost of illness game. Because a better cost of illness study is not necessarily a better estimate of benefit than a bad cost of illness study. So if you take your lung cancer medical cost study that puts the cost at like $35,000 or something, if you just stipulate that's the greatest study ever, and then imagine some other study that's very poorly done and it's so shoddy it overestimates the medical cost by a factor of 10, that's probably closer to the willingness to pay. So I think investing resources in improving cost of illness or looking for a better cost of illness study, it's not necessarily helpful because it's just as likely to go the wrong direction as the right direction in terms of getting closer to the real number. Now, that's easy to say because there aren't too many alternatives in the literature, and the CV literature has not provided these. But part of that is because of what EPA funds. I realize you don't make funding decisions, but so there's a little bit of circularity here. But I think if you want to do those endpoints better, it's got to be something besides cost of illness.
Mark, can you sit a little closer to the mic or pull it
Yeah.
towards you? You have a soft voice.
Yeah. So the cost of illness. I mean, it's just there's been really no movement on that in 25 years. And what was in there were when chronic bronchitis got kicked out of likely causal, then and we often talk about how it's all mortality benefits. And of course, that'll probably always be dominant. But one reason it's all mortality benefits is that's willingness to pay. And nothing else is until you get to like day symptoms. So you have like a cough for a day or something, and that's willingness to pay estimate. But everything in between, which some of which are very severe, so I think just getting this rounded out beyond just mortality benefits is going to be important to do cost of illness. So I think I might, skip to H and I as other sub questions here. And H maybe, how might you do effects where there's no valuation estimates? And I'll sort of toss this over maybe to Lisa as well, that perhaps an alternative to these cost of illness estimates or to filling in gaps where you have a causality determination that works, but no valuation, would be to consider, can you use monetized qualities in some way? Is there a legitimate way to monetize qualities? Which is something I've always frankly been against doing, because there's all kind of problems with that. But if the alternative is cost of illness, I mean, it can't be worse. It's got to be. So I don't know. So that might be worth thinking about as well. And then on the causal uncertainty thing, so that I have thought about a bit. I think there's a way, and so Steve Newbold and I and others have a working paper on this topic about how it might be possible, or we think it is possible, to use below likely causal and to adjust the effect estimates according to a numerical estimate of the probability of causality. If somebody is willing to, state what that is, which the IPCC does in several of its, in some sections of, they'll tell you what does likely mean, what does very likely mean. And I think if that could be done even with ranges, as Steve suggested today, like if you said likely means more than 50% or something like that, it means 50 to 90 or whatever it is. There's a very simple way that's, there's a way to use that information that's consistent with economic theory, and there's a really simple approximation that we think is pretty accurate. So that might be something to consider as well. But it isn't peer reviewed, it's a working paper. And I'll leave it there.
That's great. Thank you very much. And I just will have to kind of keep in mind that obviously what you're just talking about, Mark, with this part about endpoints that are below potentially the sufficient to establish causality will relate back to our response to question 1, right? Because if we're not evaluating those endpoints, then it doesn't really make sense to, well, it wouldn't make sense to have the recommendation for question 1 say, don't look at these, and the recommendation for 5 say, let's put a price on them. We want to ensure consistency once we get to that point. So Nikolai, please.
So I agree with the comments made by Joe and Mark, and I'll try not to be too redundant and just repeat them and comment on a few other things. The first thing that caught my eye was the proposed transition from a 20-year segmented lag to a 5-year lag. And I just found myself struggling to follow the basis for that transition. From looking at the Krauss et al. Study and the others cited, they seem to be finding effects out to at least 8 years and then not looking beyond that. And so this could just be my own lack of expertise in this literature, but I think that the basis for that transition could be better articulated. I'm not trying to defend 20 years. I'm just saying I didn't follow the rationale for the change being proposed. Coming back to the issue of cost of illness, while I certainly agree that willingness to pay would be a preferable measure, there may be some low-hanging fruit to improve some of the existing measures, particularly in the case of neurological health effects, where I think inpatient hospital visits are likely to substantially understate the financial cost of illness. And some of the sensitivity analysis done in Section 6, that they include additional measures of drug costs, outpatient costs. I would have thought that that table would be a more appropriate basis for the baseline cost measure because it's more comprehensive. But even medical costs that are direct are going to understate indirect medical costs from family caregiving. The Alzheimer's Association does back of the envelope calculations for this, and they suggest that it's roughly the same size as direct medical costs. And so that would inflate estimates further. And of course, that's going to leave out the effect of cognitive decline on decision-making ability. There's a rapidly growing part of the economics literature showing that cognitive decline is affecting how people balance their financial portfolios, risk-taking behavior, financial mistakes in markets for healthcare and retirement savings, makes them more vulnerable to fraud. It may be hard to find evidence on nationally representative financial effects of cognitive decline, but this may be a place where it would be good to have a placeholder given the rapid evolution of the literature. And of course, all of that would still understate what people are likely willing to pay to avoid cognitive decline from Alzheimer's and Parkinson's. Moving on to a separate point on the morbidity cost of illness attached to school loss days. I thought it was a sensible move to include lifetime earnings reductions from school loss days, adapting work from Raj Chetty and co-authors. But I noted that when that was done, it focused exclusively on middle school and high school students' lost school days. And in the education literature, there's evidence that directly parallels the middle school estimates currently being used for elementary school students. And that would also align with Chetty's work that starts in 3rd grade. And so I think you could extend it to elementary school there. And then another point, earlier this morning, Matt brought up the issue of subclinical reductions in labor productivity and human capital formation. From cognitive impairments from pollution. And as I read through the valuation section and looked at the treatment of minor respiratory restricted activity days, it struck me that it might be appropriate to consider adding something like minor cognitive restricted activity days that would take into account the effect of pollution exposure on reductions in learning and on-the-job performance and manual and cognitive tasks. This is another area where the literature is rapidly growing and Matt would be the expert. And finally, just to reiterate what Joe said about the income elasticity, that the current estimate certainly seems quite small. And I think it's important to have internal consistency between the VSL measures being used in the report, and then the definition of the income elasticity being used, and then the empirical studies that are drawn upon to calibrate that particular income elasticity. So I'll stop there and turn it over to the next person.
Thank you. That might have been the first case of somebody, trying to assign something to somebody else who's not even on. No, I think you are on this anyway. Okay, so I'm looking at the wrong list. Rob, please.
So a lot of economists on this charge question. I'm going to restrict my comments to just a few items that I know a little bit about. Starting with the approach to estimating neurologic health effects using a cost of illness measure for hospital visits, as well as the second part of it, whether it's appropriate to assume that first hospital visit indicates disease onset. And I think that's an important question. And I'm sure it varies by the outcome. So most people think of stroke as a neurologic disease. The onset of stroke is acute. It's very clear, and people always go to the hospital for it. So I think it's clear for that. I think for Alzheimer's disease and Parkinson's disease, that's a slow neurodegenerative process, and people don't end up going to a hospital until fairly late in the disease. I don't know exactly how you would get a handle on that, but I think that's an important issue. So it goes along with the comments that were just made. Yeah, there's going to be a lot of benefit from reducing that early portion, and it may be a research agenda. Maybe there's already literature out there. I suspect there is, that would allow you to be able to do that. I can look into that if you want. The second question I wanted to comment on is cost of illness approach for respiratory symptoms in children. Sub-question E. There are some other things in there as well, but for respiratory illness in children, a big part of that is asthma. You get a huge benefit for preventing cases of asthma, and then there's the exacerbation of asthma that's part of the same package, but also separate. It's a separate calculation. So there's a paper that Nino Kunzli wrote maybe 15 years ago, looking at the impact of preventing a case of asthma on asthma exacerbation. And then I was involved in a couple of papers that took Nino's insight to a health impact assessment. And the insight that he had was that if you prevent asthma, then when you look at the benefit associated with some asthma complications, for example, bronchitis or medication use, you ordinarily we use a concentration response function from air pollution studies related to use of medication. But if you prevent asthma, then it's not just the impact of air pollution on those outcomes, but it's the impact. Any exacerbation of asthma among people who you prevent asthma is then attributable to air pollution. That was Nino's insight, and it has really big implications for the cost of taking account of that. Has really big implications for the cost of other complications of asthma. And I haven't seen that in national estimates. I don't know if you've thought about that, but I think it's something that could be, there's a template out there. It's something that could be implemented relatively easily. And, at least in our experience, it about doubles the cost or doubles the benefit that you get from reducing air pollution and its impact on respiratory symptoms in children. So that's sort of one thought. The second comment that I wanted to make was about, or the third comment was just about, well, I don't know, maybe it's already been said, there's labor productivity and human capital formation. And, I think, school absences is a really important endpoint. And I know it's used commonly. One of the implications of a school absence is that an adult stays home as well. So I can't remember whether that's something that's included in the BenMaps, but I think that's I've seen that drives the cost benefit in a big way. I'll stop there.
Great. There's so much content in these. I can't really keep up with the notes, but on to you, Matt, please.
All right, thanks. Yeah, I'd certainly echo a lot of what's been said. It feels like a lot of the valuation that's going to come from this is really just a lower bound of what the true impacts on society are. I think a lot of people have said good points on that front. I'll try to add a few comments that are maybe not repeating things that are maybe a little different. I have like some very specific comments, and I'll wait whoever's the lead on the questions. I'll give like specific things like, some answers to some of the specific questions. But, I think that there are a few things. So one is echoing a point Mark had raised about thinking about incorporating qualities in here. And I actually have the same thought. And what's interesting is that we may not like qualities as an outcome, but quality weights, one of the inputs into qualities, is something that might be very useful. Because one of the things we can do is if we have willingness to pay, let's say we want to estimate willingness to pay for allergic rhinitis, but we don't have willingness to pay. We only have cost of illness, but we have willingness to pay for asthma. Let's say we have that, but then we have quality weights for for allergy rhinitis, and we have a quality weight for asthma. We can use those to scale the willingness to pay from asthma to something like allergic rhinitis, right? So the quality weights are just like a rank order of things. And we know that all of our methods to elicit quality weights, we get very different scores, but the rank order always tends to stay the same. So if we tend to rank, asthma as twice as bad as allergic rhinitis, then we could say the willingness to pay for rhinitis is half of the willingness to pay for asthma. Just like one thought of a way to incorporate it. Because I agree, we only have willingness to pay for a few things. So let's figure out how to use it. And another thing along those lines is like, willingness to pay over cost. Sometimes for certain illnesses, we have a willingness to pay and we have a cost of illness. So we can get like a WTP to COI ratio and use that to adjust in other cases. So we do these scalings all the time. I think, just our population projections are scaling, our cost to charge ratios are scaling. It seems like this is another case where we can just do those same kind of scaling. And I don't think it's inconsistent with general approaches for thinking about valuation. Some people might disagree, but I would imagine it's okay. So that's kind of one thought, which is in line with Mark's comment. I think another thing is that also has been pointed out is that a lot of valuing of these impacts have been done in fields outside of maybe environmental economics. So we're often like looking to environmental economists for valuation, but a lot of valuation has been done in like health and labor economics. It might be really useful to bring in here. So I was just thinking about this, the comment on like AMIs and labor market changes. And I think there's like a 3-year period that's used, but there's this study done, Steffens and Tui, it's just a pure labor study on the impacts of AMI on labor outcomes. And they're finding effects out to 6 or 7 years. I forget exactly what it is in terms of the impact on people's earnings. So somebody who has a heart attack 6 years later, they still have lower earnings. So there might be a lot that we can get just from like the health and labor literature that's useful for thinking about valuing some of these impacts, where maybe environmental economists haven't used it, but those would be good places to go. For latent effect, for thinking about the 20 years, I wasn't sure exactly where this would fit, but this led me to think about a lot of research that we've seen in the past decade or so on latent effects, and in particular thinking about like fetal development, so early exposure and kind of sort of fetal exposure the first couple of years of life, and then we're seeing impacts 20, 30, 40, 50, 60 years later, where people have lower labor market earnings, outcomes like that. And the question is, where do we think about fitting that in? I mean, obviously those studies are going to be looking at different pollutants, but that's just by the nature of the study. If we want to study the latent effects from early exposure to PM 2.5, we have to wait another 10 or 20 years before we can do those studies if we want to see the effects when they're 50, because we've only been measuring PM 2.5 for 25 years. So I think that, I don't know that quite fits in with this question, because I think that question was about mortality, but I'm going to use this opportunity to just kind of put that in there, that there's other kind of long time periods that are worth thinking about as well. And then the last thing, Nick said this on kind of productivity and human capital. I mean, obviously I'd give a resounding yes, we should include it. It's a good way to think about subclinical impacts, because sometimes, when we just think about lost labor earnings from being in the hospital for the day, I mean, there's all the impacts where maybe you didn't go to the hospital, but people, suffered as well. There were welfare consequences. So I think productivity and test scores are good ways of trying to capture those things. So I'd obviously be a big fan of that. And then, like I said, I have some very narrow specific comments that I assume is better to just share when we write it out.
Super. Okay, we have 3 more. Next would be Enid, please.
Yeah, I'm not an economist, so I will concede the gross inadequacies of cost of illness and willingness to pay. But I think some of the challenges that are embedded kind of in the whole concept of segmented lag, and especially for long-term exposures as opposed to short-term exposures, which can be more easily modeled, is really the question of the nature of the exposures. And I wasn't clear on the first kind of sub-question, whether there was a differentiation between kind of PM 2.5 exposures and ozone exposures in terms of the nature of the term. And I think that needs to be clarified, because how one views the types of data that you would need and how that would be interpreted is very much dependent on the nature of those exposures. And so that wasn't clear to me, because part of the question, which included a sensitivity analysis for ozone, as opposed to for PM 2.5, suggested that there might be differences in how we could view those. I was concerned about some of the clinical terms, because I thought that they were imprecise in a way that was very unhelpful for looking at health impacts. For example, with neurologic health effects, using hospital visits, and someone mentioned that is really kind of a very crude and I think not incredibly helpful measure of disease impact, disease severity. And I don't know if there's a way of integrating kind of outpatient encounters as a metric that might be more useful, and might actually define kind of earlier stages in disease kind of evolution. And neurologic health effects, I don't know whether that's all dementia. If that's all dementia, then it's not all Alzheimer's, because all dementia is not all Alzheimer's, and vascular dementia would have a connection with AMI and other vascular morbidities that are attached to exposure. So it's complicated, and I wanted to see some kind of stratification or detailing of exactly what we're talking about when we say neurologic health effects. Lung cancer latency, which is kind of totally in my space, I think it's a problem the way that it's being done, because the exposures that we know and we have the most data on, and I can provide some of those publications that are considered the most stringent, are with asbestos, with uranium, and with radiation exposure, obviously, and of course with tobacco. And the question is whether we can use some of the rigor of those studies in trying to conceive of how we can look at air pollution, specifically of 2.5 and ozone. And it's not clear to me that that's being done kind of in at least an organized way with this particular kind of analysis. The only other issues I had was allergic rhinitis, and I just can't imagine that allergic rhinitis is on a scale with asthma. And I was trying to kind of envision how allergic rhinitis is attached to some of the most concerning outcomes, such as school lost days, work lost days, et cetera. It was hard for me to kind of imagine that that would be a very kind of concerning relationship, but I don't know that data as well as I would like to know that data. But what I can say about asthma is that the whole diagnosis of asthma suggests that asthma now is not what asthma was when this was first kind of assessed in terms of these exposures. And unless we're willing to kind of subphenotype asthma and relate it to some of the associations that are in place for allergic rhinitis, we really should kind of describe some of these subphenotypes that have totally different natural histories, different susceptibilities, and different responses actually to the drugs that are being followed here, such as albuterol. And in terms of causality, I mean, as kind of a basic scientist, I guess I'm always concerned about causality being established with correlation as opposed to with, interventions and with kind of very crisp data. And so I think that that metric probably has to be evaluated on a very, very deep level to establish causal uncertainty, because I think that's an incredibly important metric, and it's one that I would want to dive deep into. But my concerns really had a great deal to do with the disease kind of specification and not being kind of on the level that we currently perceive these disorders to be right now, and whether that kind of rigor can be integrated into these health effects and outcomes.
Peter? Thanks. Just one language clarification. In part B, when we referred to neurological health effects, we specifically meant Alzheimer's and Parkinson's. Those are the only ones that are currently quantified.
So other types of dementia are not considered relevant, just Alzheimer's and Parkinson's related dementia, I guess.
That others are not currently quantified. No.
Thank you. Very useful. Steve, online.
Hi. I think most of the big picture things I want to mention have already been mentioned, so I'll just piggyback on a few of those more quickly than otherwise. I do, on the issue of cost of illness estimates, I concur that they're less than ideal. I do think they're better than nothing in cases where we don't have anything else. There's a strong presumption that they'll underestimate willingness to pay. So some underestimate is better than zero, I think. So better than excluding those endpoints. And then following on that, both Mark and Matt are kind of building up to another thing I wanted to suggest, which is some kind of, as a way to fill some of the gaps where we don't have value estimates. Some form of what is sometimes called, or used to be called, preference calibration or structural benefit transfer that might be able to combine information we have from QALYs and from cost of illness and other information to impute willingness to pay estimates that are kind of internally consistent with the information we have on those other metrics, to get willingness to pay estimates for some of these missing health endpoints. So what I heard Matt saying was kind of a proto description of such an approach. So I would see if we couldn't carry that even further. Another comment is on the VSL income adjustment. I was very interested to hear Joe's remarks on this about the inconsistency with adjusting for inflation, but not income growth over time for older estimates. I happen to know that a previous EPA effort involving trying to update the agency's VSL estimates tried to do both of those, but that particular science advisory board panel recommended strongly against the real income adjustments for those in that case, which I think is contradictory to what Joe suggested. I have a personal opinion on which one of those makes more sense. I'll be interested to find out how we resolve that in this case. So just to put that out there, but there's other.
I think the statute of limitations is passed on the previous SAB report.
Okay, so we can discount that entirely.
Yeah.
All right, fair enough. I'm not unhappy with that resolution. Anyway, but I guess the last thing I'll say is another thing Joe just mentioned in passing. I think that EPA adjusts for income differences, mostly growth over time, but not over space. It's not clear to me what the, I think all the reasons to adjust over time would apply over space as well. So there's a tension there that I think should be resolved if only by an explicit statement by the agency that they're making a policy choice to do that. I guess that's all I want to say at the moment.
Thank you. Appreciate that, Stephen. And last but not least, Lisa.
Yeah, I was hoping I could just say ditto all the above, we're done, but I don't think I'm there yet. Sorry, guys. So some of what I want to say builds on things that other people have said, and some I think is new. One thing that was, I don't know what the right term is, surprising, I guess, is I think there's, so the title of this section is valuation, but there's clearly questions in here that are for the health scientists and epidemiologists rather than for me as an economist. For example, it's very clear to me that if there's a lag, we should adjust for it. If there's latency, we should adjust for it. But I don't feel like I'm the right person to answer the question of what the lag should be or how long the latency should be. And what puzzles me the most is if you're doing an epi study that you're using to predict cases of lung cancer, isn't there some assumption about latency in there? And shouldn't we be using that in our economic estimates? So that's one question. For the other, I think I have 5 questions for the health science types. A second one gets back to Joe's point about averting behavior. We've talked about this in some of the things that I've written. If people engage in averting behavior, it's going to be picked up in EPI studies. So if we think that by improving air quality, people are going to stop doing things to protect themselves from air pollution, we need to think both about the economics piece and about the epidemiological, I can say that word, epidemiological estimates, because it's in both pieces. It's not just an economics issue. The same thing goes for the indoor-outdoor exposures issue that we talked about earlier in the work that Jonathan and I were involved in. I was reminding him, Jim Hammond, who was working with us, did some back of the envelope calculations to see if you used our infiltration estimates, how much it would change the effects measures from EPI studies. And I think we need to think some more about that. We need to think some more about how some of the things that we've learned from economics play into the epidemiological estimates. So I talked about lag and latency really being issues for the health science folks. I think this other question about other endpoints to some extent is too. And then I said this earlier, but to me, one of the most important things is trying to get at incidence as an endpoint rather than hospital visits, because that's where that's what we really care about. One thing that I thought somebody was going to mention was there are a couple of studies, I meant to find them and I forgot, but there's 3 or 4 places where we are relying on EPI studies and economic estimates that are 20, 30, 40 years old. I think we need a sunset provision. There is absolutely no way that people's behavior 30 or 40 years ago is a good predictor of what their behavior is going to be over the period of time when these rules are implemented. And I think that it's sort of maybe it's loss aversion, but we do need some sort of decision criteria for starting to draft things that are too old, which might include the VSL estimates, but that's a different story, I guess. Well, that's a different story because of the fact it's out of it's not in our hands, not because I disagree with it, but that's also a long conversation. But I do think we need to think seriously about whether those studies and those estimates are still meaningful. One of the many things that surprised me about this is that EPA does now have value of time guidance that looks at both leisure and labor time losses. It builds on a paper that we wrote for the Department of Health and Human Services. They only disagreed with us on one thing. And it is an attempt to try and get closer to a welfare measure, although there's all kinds of issues there. And I think what was puzzling me was it's referenced here. I think it's a 2020 paper, but it's not used throughout all the estimates. It seems like every place you're valuing time, whether it's caregiver time, work time, you should be using a consistent approach. And since EPA has guidance, why not use their guidance, even though it's a little different than what we recommended. There also is a literature on in the health literature on I can't say this, presentism. Basically means when you go to work, but you're not as productive as you would normally be. And I was wondering, this issue came up of restricted activity days, and I'm wondering whether it's worth taking a look at that literature and seeing if we can use that as another way of thinking about how air pollution affects productivity. Willingness to pay, qualities, benefits transfer, all this sort of stuff. First of all, I disagree with Matt. I've looked a lot at trying to compare willingness to pay studies to COI studies. And I think you can't really do it because different populations, different definition of the health effects, they count different things, they might treat, less time differently. So by the time you start thinking about how do I get 2 studies that compare apples and apples, there's very few that are useful. I think all we can really be sure of is that the cost of illness estimates certainly understate willingness to pay, with one qualification, which is most medical costs are covered by insurance. It's not entirely clear that any of us would be willing to pay that full amount. You've seen lots of articles on end-of-life care. If we had to pay for that out of our own pockets, we wouldn't be able to do it, much less willing to do it. So I think we need to be a little bit careful on that comparison. There are a lot of willingness to pay reviews out there, and many of which address air pollution. I think doing a good job of synthesizing the willingness to pay literature for non-fatal effects would be terrific, and also thinking very carefully about this issue of can I transfer a value from one health effect to another health effect where I don't currently have a willingness to pay study. This may be a question for Neil, but the Belova study that's cited in here I thought they'd looked at more health effects, and that's a newer it's a newer review of that literature. Can we just ask Neil for copies of these things? I should tell you, I asked Brian Henderson for a copy of this, but I never got it. But if that's something that's public now that you could give us, that'd be great. So I think that we can do a lot more with willingness to pay. It's just a question of doing a very careful review of the literature and thinking about how it matches up with what's with the endpoints we're looking at here. Qualities. I have been advocating using monetized qualities when we don't have willingness to pay estimates for a while. I get myself in trouble with all my environmental economics friends because of this issue of cost of illness estimates understating willingness to pay, or thinking that they understate willingness to pay. And we recommended in the HHS guidance. It's what HHS and the Food and Drug Administration have been doing for a while. However, with some co-authors, we just did a review for COVID where what we were trying to do was look at estimates for endpoints that are similar to COVID. So we were looking for quality estimates for flu, some other respiratory illnesses. And the quality literature turned out to be less helpful than I thought, even as somebody who's been looking at that literature for 20 or 30 years, because so many of those studies they're small samples. They're only really bad cases. So I think that thinking about qualities as a way, or monetized qualities as a way of getting what's missing from cost of illness estimates, maybe in sensitivity analysis, is a useful idea. But it's not as robust of a literature for this purpose as I thought it would be. Income elasticity. I think this is the same thing that Steve Newbold was just talking about. Jim Hammond and I wrote a paper for Neil that was supposed to be to update the income elasticity estimates in BenMap, assuming that the VSL estimates would still be the 26 studies. That paper got sent to the SAB as part of SAB's consideration of also updating the VSL estimates. And the SAB very wisely, in my view, said, if you're going to update the VSL estimates, you should also update the income elasticity estimates because the two need to go together. I still think that's true. So if our charge for this committee is that we should be looking at income elasticity estimates for the 26 studies, it's fairly easy for me to update what we did in that paper to represent. There have been some studies that weren't taken into account there. If EPA is ends up updating its VSL estimate separately from what we're doing, then I think we need to go back and revisit how we're doing income elasticity. Because if you think about the pieces, there's the base VSL, which, like Joe says, should be adjusted for both income and inflation from the year of the studies, not from 1990, which is what was in the 812 reports. But there's also the income measure. Most of the income elasticity estimates we have are based on some measure of earnings or household income. And so we need to think, if we're going to use an income elasticity measure that comes from that sort of study, we also need to be projecting income using the same measure, not GDP, not GNI. And then the formulas, if you're going to assume that elasticity is constant over the range, you need an exponential formula, and I think they're still using a linear formula. I think that's it. Is that it? That's it. I'm done.
And here I was thinking there's so much room for discussion and changing in the health endpoints. And now we get to the economics, and somehow it makes the health endpoints look neatly defined to me. But maybe that's just because I'm not an economist.
Well, but we just gave you guys some more work on the health endpoints.
I think so, yes. Great. So thanks, everybody, on the valuation for clearly having thought about these beforehand and coming to the meeting with a nice, well thought out list of suggestions and questions. So given that there are a lot of questions raised and such, how about we open the floor to the rest of the committee, including online or in the room, for any comments from others? Peter.
Yeah, I mean, this is really a scope question. There was a bunch of discussion about the lag models used between exposure and then disease incidence, and then, which goes into the discounting. How the discounting itself is done, is that at all in scope here? Or there's probably other EPA guidance that
There's
is
other
binding.
guidance that will
Yeah.
follow.
I thought that was the answer.
Thank you.
And Chris.
So as a non-economist, I'm kind of speaking at my peril here, but my my understanding is a lot of these, especially like the cost of illness, but some of the other ones where you have extra, economic transactions happening, which is maybe all of them. It's these are costs in some sense, but in a broader sense, they're economic transactions, right? You have a lot of economic transactions. It's like a transfer of wealth, right? And so, the transfer of wealth can go in all kinds of different directions. If you have somebody that, owns their own house, is installing a whole house filtration system, that's, maybe kind of trickle down economics, right? Where it's, you're helping this company that's, whatever. But if you're someone that's like living next to a power plant in a trailer park or whatever, and having to buy inhalers, then that's kind of adding to a cumulative burden, right? And so I guess if you kind of step back to maybe a previous question about what endpoints should we be considering, one endpoint could be like, who is, which direction is the wealth transfer happening when we have these burdens? Maybe like a way to operationalize that a little bit more is to like compare the willingness to pay for these things to the ability to pay, I guess.
Can I just clarify that, so willingness to pay is constrained by your ability to pay. The question that we're trying to answer is how much of my own money am I willing to exchange for a change in my own health? So ability to pay, when we're talking about willingness to pay, it's constrained by income or wealth.
Yeah, I was just trying to make it like a little bit pithy, but the idea would be that, who is paying, right? Is the question.
Yeah.
And I think that raises some pretty interesting points when people have talked about things like, you take adaptive measures and you don't have to spend as much on pharmaceuticals. Like, okay, that's great. And I picture, CEO from some pharmaceutical company in the next room in a different meeting, hearing this through the wall and going like, that's not so great. I'm losing profits, right? It's great for somebody, but not great for everybody. Other input from the panel. Sorry, Jonathan.
Yeah, this just a question that comes back to COVID. If we're shifting vulnerability, you've seen studies that air pollution increases risk of dying if you get COVID by 15%, give or take, depending where you are. So shifting vulnerability, if COVID becomes a chronic situation, is that something we need to factor in for willingness to pay? And I'm not an economist.
I guess I have a separate question. Again, not an economist, so I have absolutely no idea how to deal with this, but it sounded like if there's a series of different treatment options or something, and people have you can like measure a willingness to pay that's kind of capped by their ability to pay. Does that then mean that there's more benefit than you're actually measuring from them not having that incidence? So I guess like, if somebody has an asthma attack, there's like a $10 treatment that works okay and like $1,000 treatment that works great. If you don't have $1,000, like, is that an unmeasured benefit that's not being captured in the willingness to pay studies?
I feel like we should give our little introduction to benefit cost analysis class. We have one coming up, Society of Benefit Cost Analysis, April, by the two people who wrote the text. But benefit cost analysis is, and they allude to this, I think, in the beginning of the TSD, is based on a very specific normative framework. And I think that's one of the reasons why, and there's some good things about that framework and there's some limitations. I don't want to get into this too much because we'll get off of the topic of the panel, but I'd be happy to share lots and lots of things, including some things that are very introductory for people. And it's in the EPA guidance, if you read their guidelines for economic analysis. But there are many things that we care about that are not within that framework. And that's part of why this whole issue of non-quantified effects talking about things that we can't even quantify numerically, much less value, why all this stuff is so important is that we don't want, at least I don't want decision makers to be making decisions only on the estimates, the monetized estimates of benefits and costs, because there's a lot more going on that's not captured.
Lisa, I have a question, well, for the economist. So when you're thinking about the willingness to pay, I mean, I use the example like to my trainees that when you're very well insured, you have a totally delusional concept of what you're willing to pay because you're not actually paying. But if you are confronted with the actual costs of various items, that threshold becomes very crisp and clear. And I was wondering, how do you separate out the populations for which they have that kind of shield from actually knowing kind of what they actually have to pay from those who have to go and pay because they're not insured or they're underinsured, poorly insured, all of that.
So how far, I can answer these questions, or I could dump some of them on some of my fellow economists here, but
are you comfortable with how that is integrated in the willingness to pay metric?
Yeah, I think what I'm worried about is that I'm going to sidetrack us, but go ahead. Yeah.
One thing that I think may help, but if it just doesn't help, then when we come up with a willingness to pay estimate, it's an average willingness to pay estimate that's applied across the population, right? So it's not like we're applying different willingness to pays for different people. So one of the things that, and also I hear us talking about wanting to understand the distribution of impacts and how they're felt differently across populations. One thing that gets really tricky is we don't want to start estimating different willingness to pays for different parts of the population, right? Because we don't want to start saying different VSLs for different groups based on their income. We use one VSL, we use one willingness to pay. And yes, it all has problems, but most people in the US have a good amount of insurance, right? Certainly a good chunk don't have enough insurance. So, but then there's, that we think it's a good estimate. At the same time, we know there's moral hazard where a lot of people aren't paying the full amount of the healthcare costs. So maybe that ends up, we're overstating what willingness to pay could be. But I think we get this average number that smooths out some of these issues.
So,
but I think that's addresses the point that I think it was Steve raised was, why do we do income adjustment over time, but not over space? And because space gets into all these things that I think we
I think
don't want to
so.
get
Why
into.
don't I can send some sort of primer level stuff to whoever feels up to reading it, but I don't think that's quite right because the reason we use averages is not because economists think that's the right way to do it. It's because EPA gets beat up if they assign different VSLs, for example, to people who are different ages, different income levels. And if I was somebody working at EPA where my charge is to improve environmental quality, and all of a sudden I'm spending all my time talking to reporters about why using income differentiated VSLs, I get really frustrated. I say, I'm going to go back to using averages. I don't care what the economists say. But I think a more straightforward answer to your question is that we use market prices for valuation when we can. The reason why we're talking now about these issues is that health effects and environmental outcomes need non-market valuation methods. So what we do is one of two things. We do surveys where we ask people how much they're willing to pay. And then we try and explain all those things that you're finding your students are confused about. Or we do are usually called revealed preference studies, where we take a market good that has whatever it is we're trying to value as part of the market good, and we use that to estimate value. The most popular use of it in environmental economics are the sort of wage risk studies that Joe's worked on with Kip Viscusi, where you know something about individuals' earnings, you know something about their risk on the job, you try and control for all the other things that affect their earnings and come up with an estimate of how much their earnings reflect their willingness to pay for change of risk. And I'll stop. But I can send something to people who are interested.
Right, well, I think the main point here, though, was that regardless of whether it's a revealed preference or willingness stated,
Stated
we're not, yeah, stated preference or revealed, we're not going to differentiate the way we were on the previous questions about who is actually affected, because that gets into ethically challenging areas. And I don't think we want to revisit that. Chris?
If I can maybe reword a little bit what I think Dr. Neptune might have been asking is, the question is, these studies, there may be some concern that they're not representative of the full population, right? And so the question would be like, does that merit review? Right, or are there certain parts of the population that are underserved compared to other ones in the scientific literature and banking and in the economy?
But we were reminded, I think, at the beginning that what the VSL should be for the average American was not within our charge. So I think you're right that there are very legitimate questions about whether it's the right number, but they're not a question for us, as far as I understand it. Right? I do think if we were to, say, adopt the comment that came up in the last question, which was about, the social cost of carbon values benefits outside our borders, and so maybe we should do that for air pollution too, then that raises this whole issue of, the income elasticity with space is varied and when we do other things, and right, and if our pollution goes across into Mexico, it probably doesn't make sense to use the American VSL anymore. So we have to keep in mind, I guess, if not earlier, then at least when Holly and I try to merge these things, that we might have to come back to any individual charge question if there's some inconsistency or overlap with the others. Joe.
So a few comments on a couple of the questions or comments raised in the conversation. First, Jonathan, to your question of if COVID increases the likelihood that people exposed to air pollution will die prematurely, I'm not sure that matters from my perspective as an economist. Whatever approach I would take to monetizing a mortality risk, I'm just applying it to a larger population of people who I think there will be some percentage of them will pass prematurely because of air pollution exposure if that population has had a higher prevalence of COVID exposure in the past. So for me, it's kind of like that's what's in the machinery in the integrated assessment model that then comes to what am I going to apply this unit value, a value statistical life. We can argue about what it's going to be, but that would get applied in kind of the same way. It's just, I think it would be sort of mechanically the same as you saying, what happens if I had a larger change in exposure to air pollution in the EPI model? On the question of discount rates, I suspect that Neil and Peter are well aware of this. I'd soften some of the language around 3 and 7% because it's probably going to change before your report may even change. But in general, just the guidance for how we think about it from OMB, et cetera, et cetera. To another, Jonathan, your comment about willingness to pay, and if it looks like it's really expensive, this healthcare, would I be able to do with it? I think part of this is when we think about willingness to pay, most of our empirical methods have looked at not what happens when I am identified having been affected by an adverse condition and what does it cost to remedy that. It's more of how much would I be willing to pay to change what is the relatively small probability that I contract this condition or I die prematurely. And so in this case, we're talking about income or resources that may be quite meaningful for people, but because it's not ex post identified health condition or identified mortality, it's something different. We're trying to think about this sort of how much you're willing to pay for a small change in risk across the population. And we can talk about what's the appropriate population, who's covered in the studies. I think a lot of the VSL studies have typically focused on effectively the working age population. So we think that's pretty comprehensive around 18 to 65-year-olds. But it's going to leave out certain parts of the population as well. But I think that's one thing about sort of, where the willingness to pay typically gets calculated in the sort of health context. We're thinking about how much you're willing to pay for what are small changes in mortality risk that you and those in your population would face.
Thank you. I'm away from the university for the day and still learning some good stuff here. So very nice. Further comments before we try to sort of come to some agreement amongst the valuation group on next steps? I see online.
Hi, this is Lin.
hello.
I'm very intrigued by the discussion of willingness to pay. I want us to step back, at least to me, like the reason we want to add them from an economic perspective, the reason we want to value the damage is because like economics, when you talk about abatement costs, you need to come up with like a marginal abatement cost equal to marginal damage, right? So you have to put the marginal damage, which is the health effect on a dollar basis. That's, to me, that's the reason why as an economist, you want to value the health effects. And I very much agree with the other panelists that you need to think about like what's the population you're looking at, especially like for individual studies, because that's, to me, abatement cost is also very population or receptor specific. Like it depends on abating what like air quality in which region, right? So so willingness to pay would be related to that. Like if you confine your receptor region to a certain population residence area, they are probably only willing to pay to the extent that the air quality is improved in their own region and not care so much about their neighbors, downwind neighbors. But if we expand like at a national scale, like most of the, for example, ozone is a regional pollutant. We probably want to think of like a spillover effects, and that's gonna impact the valuation and the region we considered. So that's, I don't know if that makes sense, but to me, you need to first define like what you want to abate, like in what receptor area you want to improve the air quality in order to define that abatement cost. And for the same geographic area, you define your willingness to pay to evaluate the health benefits. So the two needs to be consistent because it's fundamental to why we're doing this.
Thank you, Dr. Jin. I think as far as most of our discussion goes, if this is, the definition is anywhere within the United States at present, but that's something that came up earlier as well. Should that be the definition going forward? So what I might suggest at this point is that I think there was an interesting point Lisa made here about the lag that was appropriate and how that was probably, I thought it was very fair to say that that was much more a function of what was in the underlying epidemiology rather than an economics question. So I wonder if we might slightly, separate that one and think about that one first. Sorry?
There's a question about latency and there's a question about lagging.
There's a latency. Yes, you're right. Sorry, letter C. Yes, thank you. Yeah, A and C together are both more epi, right? Epicentered rather than econ-centered, perhaps. So maybe somebody who feels a little more comfortable with that portion of the literature would like to take on A and C from the team, and then we can go into the other 8 topics, which are very much econ-centric. Any
Rob is our
right? Is that Rob over there?
Yes.
Okay. Did you say C or A or both or? A and C? Okay.
Great.
Wonderful.
Great.
We can do A and C together.
Wonderful.
Okay, thank you both. That's great. Okay, so we have A and C kind of assigned and off the table for the moment, and then
So on all these ones, the question about cost of illness, it seems like one way of handling this is diverging from what Holly was saying about as a sort of an umbrella piece that needs to be read in here.
Turn your mic on.
yes, thanks.
Sorry about that. It seems to me that all these questions that have to do with the cost of illness and lost time, maybe we need a sort of umbrella, a couple of paragraphs that go somewhere at the top of the charge questions that talk about willingness to pay versus cost of illness versus and valuing time, you know, sort of qualities, you know, all the big picture issues that cut across all of these questions asked about cost of illness, and then have separately answering the questions, you know, like D asks specifically about AMIs. So maybe somebody also wants to take on the AMI literature, but it seems like a lot of what we've said about the cost of illness measures cuts across all of the questions. It's not just AMIs or just allergies.
Right. I think we have to, well, judging from comment Holly made to me before when I was trying to be efficient and combine things, we need to reply point by point, but we could before B, D, and E, or perhaps within B, since that's the first one, have this overarching discussion about cost of illness, like some of the points you guys all, well, not all, but at least many of you raised about the need to maybe move away from cost of illness to better things. The first time that that comes up, and then use that and refer back to it for, as far as I am following this, B, D, and E are all very much focused on whether the cost of illness is the right thing to use for.
Yeah, what I've seen previous SABs do is, you know, they write this sort of general thing at the beginning, and then they get to question E or whatever it is and say C or
Right.
answer to B or whatever the.
Right.
Is that okay?
Yeah.
That sounds reasonable. So then B, yeah, B is the first one. But maybe we could have the same, those people who are interested, I mean, several of you talked about cost of illness and
Rick, volunteer for 4B?
Yeah, I'd be happy to take the direct part of B and work with others on the broader umbrella piece.
wonderful.
Why
Okay.
don't I feel like I should, since I've been talking about so much, why don't I take a first crack at the broader umbrella piece? But you deal with the Alzheimer's piece, or what is it, Alzheimer's and Parkinson's. And then, but then for the other ones, I think we need somebody who knows something about the AMI literature, somebody who knows something. So I think for each of these, we need somebody who knows something about the specific health endpoints, which is not me, and I lost my pen.
Anybody know a fair bit about heart attacks, heart attack literature, I should say?
I have a different question about what they're doing is that if you're weighing into the cost of illness questions, can you be very clear about what the alternatives are? Because you're very explicit about why these are suboptimal and why you don't like them, but that's not particularly helpful if there are no alternatives. So
Yeah, I mean, the deep non-secret here is that I've written what I'm proposing to write a few times before, so I will do that. And I can send you longer versions than what I would write here if you're interested.
So do we need somebody else for neurological
That's
health?
neurological.
Or you're okay. So the general overview discussion of COI, but also the specific application to neurological health for you, the general.
General's Lisa.
With Lisa, but you know,
Neurological is Nick.
everybody obviously contributing to this, Mark and Joe
yeah, I mean,
made lots
throughout,
of
I mean,
comments, right, Matt?
Then we need somebody for
Um,
D, somebody for E.
Yeah, for D and E then, if there
Somebody for F, I guess.
I'll take E.
E,
Yeah,
thank
if
you, Mark.
nobody else wants it.
Okay, and
You said E is an.
E
egg?
is in egg, elephant. Yeah.
And D is, yes, the AMI application of the COI discussion to use a lot of acronyms in one sentence.
Do we have somebody for D?
I don't think so.
I'm wondering if we should combine some of these because we have more
Right.
categories than people.
We
right?
do. Yes, good point.
But maybe D becomes something where, at least for the initial draft, we say, see the general discussion, because we don't have anything special to say about AMIs that's different from the sort of more general piece about cost. I mean, what I would be saying in the more general discussion is, review the willingness to pay literature, and it may be that we can't, and here's some other things you could do. It may be that for AMIs, we can't go any further than that, because you've done some new work on neurological effects in Alzheimer's, so that's why
Okay.
there's more to say there.
So is anyone aware of additional AMI related results that are in the literature beyond what is already included in the TSD? Anybody online or in the room?
Actually, can I ask a question? What do you think the chances are, those of you who are working on the health endpoints, that instead of AMI being our endpoint, you'd be able to come up with a way of having having heart disease be an endpoint, because that changes the response to this question. If all you're trying to value is one heart attack,
Right.
that's very different than saying, I'm trying to value an averted case of cardiac coronary disease.
Anyone from the health endpoint group, which is in actually substantial overlap between this group, but also some other people have a thought about that possibility that might change?
I'm not suggesting that you guys would be able to come up with the answer. I was thinking more that of recommendations, like you should look at this Markov model of.
Who should look at which model?
A lot of the disease, there's some disease models that are Markov models. They have events and probabilities, and see, I don't know enough about this to be very smart about it, but you could see where first AMI or where AMIs come within that model, and see if we could come up with some probability that having had an AMI is indicative of a longer term.
Yeah, I'm not sure if that would fit with the standard methodology of looking at the epi studies that have.
I don't think this is an epi
Right.
issue. I think this is probably for other health scientists. So.
Right. So it is, when we talked about health endpoints, that most of our questions were about, refinements to the methodology of using, pooled versus single and preferred versus minimally acceptable. So maybe we are unlikely, would be my guess, to get to what the kind of thing you're talking about, which would change the endpoint. So why don't we kind of make a note of that, and that we will, keep an eye on the development of our response to charge question 1, and see if there are any effects that would trickle back here to charge question 4. But at the moment, I think you might be right, Lisa, that our response to 4D might largely be, see the more general response about limitations of COI in 4B, but we don't necessarily have any specific recommendations for improvements, which is okay. I mean, some things, they've done the best that can be done already. Okay, so that would get us through, if I'm Rob, yeah.
Just a question about one question about charge questions. Did they come from you guys, or did they come from? Did you have something specific?
Can you activate your mic, Rob?
Turn your mic on.
For the online folks too, yeah.
Is there more to that question that would help us assign somebody to it or think about how to approach it?
Yeah, it's a fair question, Rob. So it's been a little while since we drafted these, but my recollection was that we wanted to focus in particular on MI because it accounted for, or does now account for, the second largest dollar value of any endpoint next to mortality. And if I recall correctly, the current approach we're using assumes a lag, at least on the valuation side. And so it would be helpful essentially to revisit the approach that we're doing, that we're following to quantifying the value of that endpoint. I think it's, if it's something that you're able to pursue, then yeah, we would be grateful for it.
You know, it seems to me that where we're headed is saying something here in the, whatever letter we're on now, under D, that says, see general discussion of cost of illness versus willingness to pay versus qualities. And by the way, if there was a way to look to the health literature to figure out whether there's a way to expand this endpoint to include the likelihood of disease, all this sort of stuff, then we should do it. But that's a future. I'm sorry, I'm getting inarticulate. It's staying too late in the day. But the it seems to me that we could just say what we're all trying to say here more articulately as part of the response to this question, sort of a longer term research agenda thing that we know EPA can't do now, and we're not the right people to do, but might be an interesting thing to pursue.
Okay, I think we should look at continue down this list. And so the next one would be F, which is improving the other morbidity willingness to pay approaches, which apply to asthma and minor restricted activity days. So we did have some interesting comments, which, well, actually many of the comments relate to G, which is similar, but is expanding the list of morbidity. So I'm not quite sure where things like the points that came up about the school lost days could, potentially be expanded to earlier grades, and the minor restricted activity days, this intriguing idea to add minor restricted cognitive activity days. These are interesting. I'm not sure whether maybe those belong a little more under G than F, because F is maybe more, should there be any changes to the existing morbidity willingness to pay?
I was going to say, I could take a lead on G.
On G.
No, no.
G like George?
G like George.
Perfect. Okay, thank you, Matt. And that one is then, so it does say including but not limited to labor productivity. So that could be a good place to include like the school and cognitive things I just mentioned. There might have been others that I'm not remembering too along with all these.
I can take F.
Who said that?
I can.
Okay. Thank you. For F.
Mark. Okay, thank
So
you.
you have E and F, Mark.
Okay. So we are up to H. And HIJ, all right, we got close. Okay, in some cases, right. Okay, bounding approaches to better characterize presently unquantifiable health endpoints. The kind where we have confidence, I guess relating back to say the ISA of causal effects, and then I is a sort of related question where we don't necessarily have the same causal confidence from the ISA process, but we might still want to include some valuation. So H and I will of course have to, well, not so much I, but H is the things that will automatically be included in charge question 1, which are the health endpoints, because that's everything already that's in the ISA is those top 2 rankings. I will have to interact with our response to charge question 1 about the possibility of going beyond what's given those top 2 rankings in the ISA. So, right, I'm trying to, okay, and yeah, interesting. I'm wondering also, about some of the things that now that we get to towards the end of this long list, some of these things about, defensive expenses that you raised, Joe, and things like somebody was talking about the indirect care costs associated with Alzheimer's that could be much larger than, the cost of the disease itself. Those, it might be at first glance that those are also things that should go into G. So people should maybe be in touch with Matt about those. But it might be that there's another place where those also fit.
Caregiver costs are actually included in some of the cost of wellness estimates.
Right,
So,
right.
I think as we walk through 4 or 5 cost of wellness questions, we'll get at that because cost of wellness is usually direct and indirect effects. Cost of indirect pain.
Right. Okay. Yeah, my notes are incomplete. But I think somebody was making the point that maybe it was about the Alzheimer's actually starting as a long, slow degenerative process. So there were a lot of things that were missed before the onset was identified. But I think there are a few issues about indirect as well. And I see Steve's hand online, I think. Yes?
I didn't have a hand up, but I am willing to cover.
That was tricky.
H or I feel like I was thinking I would be a strong support person for those, but if no one is going to lead them, I could be the point person on either one of those.
Wonderful. I mean, we do really expect these to be group effort. So the lead is only nominally different than the others. And you have a light colored background like over your right shoulder. So the hand is also light colored. So that's why I figured it was you, but lucky for me that I called. Okay, great. So did we say H or I? I forgot. Did you say H or I? H? Okay, so H is the economic effects of ones that are definitely in scope. And then I is similarly some discussion about economic effects of endpoints rather, that we have some strong indications, say suggestive that these are related to PM and ozone. Anybody we haven't really picked on yet? I think pretty much everybody's been good about volunteering.
I was going to volunteer for J.
I thought you were going to volunteer for J. Right?
Yes, I should have spoken up at the beginning because they go ahead and put me on J.
But you clearly had strong opinions about the income adjustment factors.
Thank you.
So I is the only one. And then what was this?
I thought Steve volunteered for HNI.
I said
my friend Steve.
I said I could do either, but I can do both. I'm gonna, do a lot of delegation, but that's fine. I can do both.
That would be great.
Yeah, we really appreciate that, Steve. Thank you very much. So now you're wishing you'd had technical troubles right now in the last 10 minutes. I could have got out of this. Now, everybody, this is a nice, big and clearly engaged team on valuation. So I think you will get a lot of, well, you should ask for, and I expect you will receive a lot of input from your colleagues.
I'd like to endorse Lisa's suggestion that we think about some of these issues. You have like a bullet list of 4 that really cross both disciplines, and think about, we've got the leads, but we should think about working on those together.
Yeah.
My understanding is that in the end, we're going to work on everything together, right? This is all you're assigning now is the first passer. The first passer?
Yeah, I mean, we're really just assigning somebody to take the bits that the team puts together and put them into, one coherent thing, so that we don't have input from every person on every question, which is incomprehensible, right? So if people have 2 different opposing points of view, then you might have an interesting discussion with your little sub team on that particular charge question about what to do.
So what I've seen people do in previous SAB reports is say, most members of the committee believe X, however, two believe Y. I mean, I'm assuming that's not so helpful to you guys.
no.
You would rather that we all agree. But
that- I think that's
we
excessive.
strive to get to the,
Maybe
consensus.
trying, okay.
But however, it's not uncommon once in a while for multiple opinions to be voiced in a report. And just putting it out there, the concept of having a preamble around this particular charge question makes a lot of sense.
Great.
Another issue is that for kind of literature that's not included in the TSD that a panelist considers very kind of important and drives a particular perspective, it would be nice to put that in SharePoint. Or where can we put it? Is there?
Sure.
We can.
You got to click on the links though and get access first. I sent you 2 more invitations.
I'm okay.
Okay.
It works. It finally worked.
All right, thank you. Thank you. In certain rare occasions, a panelist has written a minority report. That happens like once every 5 years in the SAB. Somebody's just so vehemently opposed to what was said in the report, they issue a minority report. So just, okay, thank you. But it is an option.
Yeah, I'm not really envisioning the lead, trying to get everybody to have the same opinion, but more the lead saying, oh, this study, said that it worked this way, and then somebody else saying, this study says that it works a different way. And like, well, both of those are probably not right. And somebody was remembering a different study, and, just kind of putting things together into one a little bit more coherent narrative. So hopefully it's all a group effort. Somebody has to, be the final person to send it on to the next stage, though. Otherwise it doesn't work. So great. I think we have earned a short break. So we are just 15 minutes behind, which is not too bad, I would say. And so since it's about 3:45, how about if we come back at 4 and we will talk about the tiny little topic of uncertainty in our last hour.
Ms. Sasser's here. We want to give her a couple minutes.
terrific.
to Say hello.
Yeah, for everybody online, we're just reconvening here for back in the room. And we're going to have our last of the day session, all right? All right, so I think we are, before we get into question 5 on uncertainty, we are going to have a brief hello here from Dr. Erica Sasser, who we're happy to have join us this afternoon. To you, Erica.
Thanks, Drew. Thank you all. And I just wanted to say how much I appreciate you all being here. I'm sorry I wasn't here earlier. I always like to hear what the panels have to say in their deliberations. I am Erica Sasser. I'm the director of the division that houses the benefits team. And so I'm very, very interested in your advice and the outcomes of this meeting. And we had, I was teasing Tom because we had a couple of other meetings today, including one that his team scheduled with the Ozone CASAC. So that's where I've been. And I'm sorry I wasn't able to be here, but I do look forward to hearing from the team about all the discussions. And I just wanted to take a minute to say thank you for being here. And thank you to Drew for all the work that goes into chairing a meeting like this. I know that's a lot. And thank you for the work that you will do in drafting your responses. We look forward to hearing that. So thank you all.
Great, nice to see you again. So let us continue with question 5.
Drew.
That's funny, it's not posed as a question right at the beginning. Oh, thank you, Peter. Steve.
Hi. Yeah, I have a conflicting meeting partway through this, so I wonder if I could go out of order and say just a few things first, since I'm on this question as well.
That would be fine, Steve. Why don't you kick us off then on question 5, please?
Okay, and I want to address all of these. I just had a few things that popped out at me that I'll throw out there. The first one is part A. I'm not actually sure if I fully understood the question, but as I understood it, my first response would be to use, do something like we do when we do meta-analyses, use standard errors to characterize sampling uncertainty, conditional and study designs and functional forms used in each study, and then use the variation of the central point estimates across the studies. In this case, assuming those are point estimates of the same dose response coefficients across.
Well,
the
can you
studies.
turn up Steve Newbold's volume, please? And Steve, if you could turn it up too. I don't know, we're having trouble hearing you.
Okay, sorry. I don't know if it's just my voice going up and down, or I can do something else.
That's
here.
a little better.
Okay, it's really loud for me now. Okay. Standard errors for sampling variation, and then heterogeneity of the estimates for non-sampling variations, which is basic sort of random effects meta-analysis concepts. I would think those would apply here as well. So that's my first reaction to part A. Part B asks about one part asks, should EPA assume a distribution when they don't have one? And my first reaction to that is I would endorse assuming a distribution in those cases, or at least there's some reasonable basis for, like by analogy to other similar pollutants or health endpoints that we think have similar sources of uncertainty, some kind of transfer of summary statistics from those to impute uncertainty distributions in cases where we don't have them. There's got to be some threshold for how similar those things are, and I don't know how to set that threshold. I'd have to leave that to the agency. But on other methods for characterizing uncertainty, I'm just sort of superficially aware of a few of these. A lot of them use some kind of bounding analysis. Charles Mansky has a big line of work on partial identification that involves what amount to bounding, sort of deriving bounding assumptions that might be useful in this context. And then think the last one is on part D. I wanted to say anything about. Part D is about how to account for uncertainties associated with the slope of the concentration response function below the lowest concentration observed in the studies. This seems really important to me, but very difficult to pin down. This has been an issue for a long time. My understanding is that the relevant data at very low concentrations are sparse enough that it's hard to pin down this relationship. And I think a common finding is that we usually can't reject a linear assumption at those low concentrations. So that's often the default assumption, I think. What I don't know is whether the existing data are sufficient to rule out other shapes. If linear was not the default and something else was the default, would that be ruled out by the data? I don't know if that's so. And some of the earlier remarks suggest, nonlinearities at higher levels. I think maybe it was Rob and Chris that said the slope is gentler at higher concentrations, so steeper at lower levels. So if that kind of concave shape is common, and if it extends all the way down to ever lower concentrations, that would have big implications for the marginal benefits of reducing pollution to ever lower levels. We economists often assume that marginal benefit curves slope down. This would be an opposite case. So that would have big implications. So since this is such an important issue, I think, I don't know, a variety of at least biologically plausible, whatever those are, low concentration dose response relationships should be considered and possibly used as a basis for some kind of sensitivity analysis or bounding exercises on this point. And those are all the comments I had.
Thanks very much. So if you have to leave early, naturally, once you sign off, we'll assign you A, B, and D, since you mentioned all three. Right. All right. Thank you, Steve. Well, following that, I think we can just go in order through the group. Why not? So should we start? Why don't we do, since we're near the end, why don't we do backwards again? So we'll spare Peter and Joe. So thank you, Steve. And why don't we turn to Ted, please?
First, yeoman's effort, there's a lot of information here. And so that was good. I mean, I was very pleased to see all the information. I was a little bit, wondering, sometimes I don't think went as far as possible in characterizing uncertainties and how they might be utilized. Just sort of going through the different letters of the questions. On B, actually, you use Monte Carlo simulation. It would be good if that was brought out a little bit more exactly how it was used. And, in some cases I was wondering, couldn't it just be done analytically for what's been done so far? Which I think would be somewhat cleaner and it wouldn't take quite as much discussion maybe. And, it's when I was reading the document, it said you use the Monte Carlo analysis to link the concentration responses with economic evaluation. I didn't see that in this document, but I take it that's further down. So not seeing that it just isn't here, but that is the intent for further analysis, is how you link those two. And again, that might be able to be done analytically, but maybe it's easiest done in BenMap. And then we get the question of how you might run BenMap, an online BenMap using Monte Carlo very efficiently. So discussion for tomorrow. So that was that. And in terms of the uncertainty associated with the estimate of willing to pay, the discussion this morning, I think, really pulls out the answer is no. I don't think it's all been characterized. I mean, in that there's this willingness to pay sort of estimate, and it doesn't really even say where the uncertainties, all of the uncertainties are quantified. I was just looking more characterization and quantification there in a number of ways. D, with the comment on account for uncertainties associated with the shape of the concentration response function. This is, we've talked about using nonlinear, non-zero threshold estimates. I think this is the point where you really want to address that. And I would actually recommend having sort of a box that sort of looks at least for mortality, the various major models, and essentially have that box characterize what that might mean graphically, or just something to give the user some sort of a characterization of the uncertainty that could be associated with that. And that's where the GEM model might come in. And again, this might be a discussion for tomorrow, but this is certainly, even if you don't use GEM here in your analyses, it probably should be in BenMap. I don't think it currently is it? It's in the desktop, but it should be in the online. And a lot of this is the online version because that's what we've been tasked with evaluating. And let's see. Those are my major comments at this point, more in sort of some of the details.
Thanks, Ted. Can I just briefly ask, when you were talking about a box, you mean in the technical support document?
In the technical support document,
Okay.
just
great,
so they can better characterize it, so the reader can see what's happening and what the uncertainties really are.
Thank you. Perfect. I was jumping ahead mentally to BenMap, like a box associated with BenMap, but yes, the TSD. That makes perfect sense. Thank you, Ted. So let's turn to Lisa, please.
I was hoping you're going to go in the other order. No, seriously, I feel like reading, I'm now not sure where some of the things that I care about belong, whether they belong in this section or in the previous section, like the willingness to pay issues that Ted was just talking about. I don't think I have much more to say. I think that it's more that when we work on writing this up, we're going to have to think some about what goes under charge for the economics, what goes under charge section, charge question 5, and what, or charge question 4, I'm sorry, and what is here, or whether we just reference back to charge question, to the previous charge question for the willingness to pay issues. But I mean, I think my feeling in general is that we are doing the public, the nation, a disservice if we don't characterize uncertainty, because we don't want to pretend that these decisions are easier or more straightforward than they actually are. But I think there's a lot of people around the table who have a lot more expertise in exactly how to do that, particularly for the health impact functions, than I do.
Thank you. I think that raises actually a very good point about the broad overlap between uncertainty and number 1, number 4, and in particular those two. I think because several of these questions relate to the uncertainty in the EPI studies that go into the health endpoints and to the economics, not so much into population and vulnerability. So we will have to keep track of the overlap between 1, 4, and 5. Let us continue up the list. Would be Matt next, please.
Yeah, I'm in a similar position to Lisa. I was hoping to go late. I don't have probably a ton to say here. So I was hoping to say, well, everyone said what I was thinking. Everyone will say what you're thinking. Yeah, there you go. I didn't quite understand in A, and I think this is kind of what Steve was getting at. So it's given that epidemiological studies report associations, how should they characterize the source of uncertainty? And it seemed to me that the standard errors are what calculate the source of uncertainty, but I don't, if you want to clarify.
Yeah, if this is the appropriate time to do so, I was rereading that question and I can understand why it's as confusing as it is. And the operative term is historical. And so what the question's getting at is, what are these sources of uncertainty associated with taking the results of an epidemiologic study, which is obviously by design, looking at associations between historical changes in air quality and one or more outcomes, and then applying that in a health impact assessment where we're quantifying future cases of ozone or PM related deaths. What are the additional uncertainties associated with doing that? That's essentially what we're trying to get at.
Got it. Yeah, thanks for clarifying. Yeah, I'd have to think a little bit more about what to do. Yeah, not sure anything will jump out to me. I didn't really have much to say on points B, C, and D, but on E, I had thoughts about a couple of the specific ones that were here. So one was on 656, different long-term exposure windows. And it's saying, most latency effects, they think about just being a few years. And maybe this is where my comment about latent effects and thinking about kind of early childhood exposure and the impacts down the road would fit in, because it seems like that's a case where those exposure windows, and it's different because it's not thinking about 3 years of consecutive exposure or 5 years of consecutive exposure, but thinking about an exposure and then 20 years later, what are the effects? So that was a place where I thought that could be useful to think about. In 658 is about statistical estimates of willingness to pay. And I think we've talked about a couple of things there, and, like somehow bringing qualities in to think about some aspect of qualities or quality weights, bringing that in to think about applying WTPs where we don't have them. On 659, it said, the question was, how do we quantitatively assess uncertainty due to confounding? And there are a couple of studies that have come out probably the last 5 years or so. Altanji, Elder, and Tabor, Emily Oster, Jonah Gelbach, that have tried to do something to try to characterize uncertainty that might be arising, saying we see this much bias due to the variables that we do include. What does that mean about what can we use to say about the variables that we don't include? So there might be some ways to use their methods to characterize some of that uncertainty due to confounding. Of course, it's going to depend on what estimates the studies report for you. The best case scenario is that the study reports kind of the unadjusted estimate and then the estimate adjusted for all factors. And then you can use something about how much it changes to say, something about thinking about bounding what the impacts might be from further concerns with confounding. That's all I have.
Terrific. Thank you. And thanks, Neil, also for that clarification on 5A. That is very helpful. To Rob McConnell, please.
So I think the clarification on 5A maybe goes back to an earlier discussion about sources of PM and whether all PM really is the same. And I don't know that if that's where you're going with this, it's not clear to me. It seems like that's a decision sort of at the ISA level before you get to BenMaps about what the uncertainty is.
It's a little bit broader than that. So we're thinking about all of the assumptions that are inherent in each EPI study and the extent to which those assumptions can hold into the future. So everything, not just including differential toxicity, but time activity patterns, which we've talked about, indoor, outdoor time, air conditioning prevalence, levels of copollutants, levels of stressors. All of those are embedded in that hazard ratio or that odds ratio. And the question then is, how confident are we when we apply that to a future scenario? Or what special uncertainties should we be aware of when we do that?
If the concentration response function is nonlinear, that's another thing, right? Is
levels of PM itself change.
Yeah. So I mean, I was going to comment in E. I think you're getting at some of the things in E maybe as well when you add sort of what are other things that we haven't thought of. Yeah, I think the sources are probably not a huge different, the different toxicity of PM in different places. That's a little probably down in the weeds, It may vary, but it probably doesn't vary that much. I think of, time activity and infiltration and commuting patterns as uncertainties that might make a big difference in what the benefits are. So, and I think of, we talked a little bit about that earlier. I think of those, the one thing that you could begin to get a handle on pretty soon is commuting patterns, and these new studies that use data from transportation studies across the country that I think are pretty good. They're pretty good quality. They're available in all the big metropolitan areas, and a lot of resources has gone into them because planners need, people care about their commute and getting tied up in traffic. So I would think of that as a source of uncertainty that you'll be able to get a handle on pretty soon. It's probably not tomorrow, but pretty soon you might have that, and that could have a big effect on how you think about these estimates. I mean, the other thing that I thought you were asking about in A is, if you look at the EPI studies, there's uncertainty around the estimate of the outcome. People do very little around the estimate of the uncertainty of the exposure that goes into that. So I don't know how that fits into BenMaps, but that's certainly an important research question and something that the EPI community should be looking more closely at. And then finally, people have made comments on whether it's linear or not. I don't know how that. I think there's pretty good evidence that across the whole range of PM, it's not linear. That the effects are steeper at the low end. Maybe they're linear over the range of effects that the range of exposure that we see in the US and Canada. But as we get more data, we'll get a better handle on the effects at quite low exposure. I think there's increasing evidence that at the lower end, there are significant effects. They may even be, the slope may be larger. And there's certainly a lot of precedent. 20 years ago, people were saying there was a threshold for air pollution. And that was the industry line. That's clearly not the case, I think. And whether you get a threshold at 8 or 6 or levels like 4 that are getting to what it was prehistorically, I think that's an open question. But I think the weight of the evidence now is that the effect is bigger at lower levels. And there's a lot of precedent for it. There's good evidence now that lead effects on cognitive function in children, the steepest levels are sort of at the lowest end of the exposure spectrum. So those are my comments.
Thank you. Nikolai, please.
Okay, on part A, as I thought about how the association between pollution and mortality might evolve in the future, I found myself wondering how it has evolved in the past. And just as a framing exercise to help crystallize our thinking on this, I wondered whether it could be useful to go back to the the tables that Pete showed us at the start of the day, showing number of deaths and benefit measures and benefit cost ratios, and repeat those calculations using the concentration response parameters that EPA would have used 10 years ago, 20 years ago, as far back as you can go, because the evolution of those parameters is reflecting all kinds of things that are changing over time, advances in modeling, changes in medical technology, the health stock, maybe the composition of pollution. And by looking at how much past changes in our knowledge of the pollution mortality relationship affects current benefit cost ratios, that might at least frame how we think about uncertainty in the future. On B, the Monte Carlo simulation question, it seemed to me that the exercise was mixing different sources of uncertainty, that when it came to the beta parameters, that they're the source of uncertainty, statistical imprecision in the hazard ratio estimates. Whereas with the VSL base value, there's that Weibull distribution, and there it's uncertainty associated with choice of one of those 26 studies. So in principle, you could do it, I think, in an internally consistent way that would take into account statistical imprecision of each of the estimates from those 26 studies. Take the standard errors from those 26 studies and use a Monte Carlo distribution to simulate over them exactly the same way as you do for the beta parameters. And that would at least treat uncertainty about the VSL in a way that's consistent with uncertainty in the concentration response function. On C and E, I had a couple, I took advantage of the open-ended nature of those questions. I wondered about measurement error, or what was described this morning as exposure misclassification bias and its impact on the beta parameters. So while techniques for predicting pollution exposure have improved dramatically, there are always going to be these challenges we've already talked about that come from people moving around during the course of a day, differences in the quality of home ceiling, and what people are doing at a point in space and time, whether they're outdoor exercising or working at a computer, since it affects respiratory activity. And the economic studies that have tried to adjust for the biases that come up from those kinds of misclassifications seem to suggest that it attenuates concentration response parameters. And I didn't see that treated in a systematic way anywhere in the TSD. And I thought that that measurement error issue would be worth addressing directly and thinking about how it might systematically affect estimates. A second overarching issue with sources of uncertainty and willingness to pay. Well, I realize that base value of the VSL is out of scope. I wonder whether it could be useful to go back and, as a part of the sensitivity analysis, calculate benefit measures using a value of statistical life year. And I'm motivated here by circular A4 and its guidance that when there's a big divergence between the age range of the population that from which the VSL is constructed and the vulnerable group that's affected by a regulation, that VSLY would be a useful measure to consider. And then, let's see. On D, thinking about locations where pollution levels are below the lower bound of concentrations observed in the data. I wonder whether it could be useful to look at daily spikes in pollution exposure in those locations. So we're not currently using evidence on short-term pollution exposure and health outcomes, but locations that have low annual average concentrations may still have daily spikes during the course of the year. And this could be an opportunity to use evidence on how those daily spikes are affecting health outcomes to at least get a lower bound on mortality and morbidity effects. And that was it for me.
Thank you. Some interesting things to think about, like if a different measure like VSLY belongs under uncertainty or under valuation. Very interesting ideas. So unfortunately, Davin is not able to join us because his school is having graduate students visit, and he's graduate student director. So we're going to jump to Mark, please.
So I am in the position of being able to say that everybody has said most everything. I'm gonna say. Since we're going reverse alphabetical, I have that advantage now. So I had I think the only thing slightly different for me was it really echoes what Nick was saying, that the treatment of uncertainty, there's so much uncertainty, and the standard errors in an epi model, of course, are just, they capture the sampling error, but there's a host of uncertainties there too. And then in other spots, there's different types of uncertainty. And so it seems that I don't know how you put all this together in a consistent way when there's so many different types of uncertainty. But I like that idea on just the WTP, and the epi studies could be treated maybe more consistently. So that's really all I have. It hasn't been previously said.
Great, thank you. Let's move up to Jonathan Bonacor, please.
Thanks. Yeah, so I had a surprising number of things here. I think a lot of what I wanted to say has already been covered, but I think and I also say, like, whenever I think about model uncertainty, I always think about uncertainty and like whether it introduces a bias or not. So a lot of this kind of discusses both of those things. But somebody, I think it was maybe Ted, had mentioned this earlier, something about using the kind of more IPCC style mention of describing this causal uncertainty. I was thinking that might be a good idea to at least investigate, and it would provide a different venue to kind of say whether some of these health effects that might be like suggestive or not quite causal, that might be a good way to kind of incorporate them into the assessment, even if they don't make it to like a final valuation number or something. And so that's it on that. I think for some of the concentration response functions, it might be a good idea to go through what's in BenMap now, and just kind of make this part of the evaluation for whether a study enters the kind of BenMap library, is just assess whether the study adjusts for these other co-pollutants we've been worried about, whether it's like NO2, ultrafines, temperature, the other stressors, and just the degree of exposure misclassification based on how they did the exposure assessment. That's more on the IPCC. Oh, and the other thing I was kind of alluded to this earlier when we were talking about baseline, but it'd be nice to see, like, just going through the TSD documentation itself, there's a lot of space taken up by assessment of uncertainty for the CRFs. There's a lot of space taken up by uncertainty for VSL and the other evaluation parameters. And there's, I think, maybe a page or two on the baseline of all the disease incidence rates. So, and like, I realize, like, it's probably out of EPA's scope to go and do primary disease surveillance, but there's some like certain states may have done it, some cities may have done it. It may not be a bad exercise, like what Nicola was talking about, to kind of go through, and on top of recreating certain results based on historically what BenMap used, if you kind of swapped in, like, there's like if New York has county level asthma, I know New York City has like really high resolution, like neighborhood level asthma, just kind of swap those in and just see what happens. And then use that to kind of get a sense of the degree of uncertainty that sits underneath some of these outcomes, especially the ones where the studies came out in like 2001. And also assess whether the use of these national outcomes introduces a bias, since in some cases, like a lot of the populations that have high prevalence might also be in high pollution areas. So if those two things coincide, there's a good chance that your results are being underestimated. And I think that's all the big ones I have.
Thank you. Joe Aldi, please.
So I'll be very quick and make just two brief comments, given what has come before. First, I would just note that in the discussion of the sort of lower and upper bounds for sensitivity analysis for the VSL income elasticity, I think this is something that'll get rewritten based on some of what we'll end up saying for chapter 5. You know, if we're going to have a much higher central value, it doesn't make sense. You know, potentially even an income elasticity of 1, you can't also have an upper bound of 1. Right. So I think some of that, how we go about interpreting that, and part of the question of sort of how we come out with that literature. Do we find like, here's the best study, and we can actually think about the bounds as a function of the estimated standard errors around the income elasticity in that study. Maybe that serves as the basis for the bounds, but it depends on how some of that plays out. So I would actually suggest jumping ahead, Drew, like if there's on this narrow point, I'd be happy to sort of talk about how we think about the uncertainty of this as part of what we'll be doing for the previous chapter on the VSL income elasticity question. So that was what, Jay? Just so we'd also think about the bounding on there on J, because we actually have table 31 and table 55 are basically the same, showing the mean value or the primary value in the upper and lower bound in both valuation and uncertainty. The second thing is I would say, and this echoes something that Nick said, and I enthusiastically endorse what Nick said. And that is when we're thinking about a qualitative discussion of the uncertainties, you know, with the VSL, we're doing benefits transfer. And we're doing benefits transfer from 26 studies where 21 of them are prime age working adults. So they're healthy enough to be full-time workers. And by definition of those samples, they're almost all between 18 and 65. And then we have 5 other studies that are contingent evaluation surveys, which are very likely more or less the same population. The vast majority of the premature mortalities that we find from the studies here, when we think about the impacts of air pollution, they were on the over 64 population. So we know we're doing this benefits transfer. We ought to be explicit about that. I think there's another world where we'd be a lot more explicit, and we'd actually look at the literature that suggests how the value statistic life varies over the life cycle. That's beyond scope. I'll stop myself and not go there. But I just think we need to be candid that like this is a benefits transfer. It's something that we've done in this context. We do this in other contexts, so like when FDA does regulations too. Like this is the norm of how we take literature that's basically from looking at labor markets, maybe a few product markets, some hypothetical markets and contingent evaluation, apply it to these contexts. And you know, where we're mapping on sort of similar risk magnitude. So we think quantitative risk magnitude, so we think it's okay. There's also some people who think that there are qualitative characteristics of the risk that differ that might make us want to think about this. There have been previous discussions at EPA and actually with the SAB on like, should there be a cancer premium for cancer-related mortality, et cetera. You don't have to go way into this, but I think just note this is the economic environment in which these estimates are produced, or from which these estimates are produced, and we're applying them in a related, but with some key differences context in our policy evaluation. Thank you.
Thank you, Joe. Lastly, Peter, please.
Yeah, so I guess I want to start with what Lisa said. It's just, you know, super important to do uncertainty well. And you know, I had a little bit of a struggle as I was reading through this section of really trying to get the full picture. There were a lot of like really good discussion around specific issues that were kind of building blocks. And each one of those sort of individually I liked. But I had a hard time kind of getting a big sense. So using Monte Carlo as an example, and I think this is right what along the lines with what Ted was saying, you know, one of the charge questions was, are there other things that, you know, where we should be doing, you know, PDFs and Monte Carlo and stuff like that. And I didn't know how to answer it because I wasn't 100% clear exactly what parameters were getting the Monte Carlo treatment and with what distributions. And maybe it was Nikolai that said, you know, there's standard error, but you know, standard error of one study isn't really the best measure of our overall uncertainty on like the betas of PM and mortality. So I think I would just like a much more overarching discussion of kind of a more consistent framework for dealing with uncertainty on a lot of things. At a minimum, the beta parameters in the VSL, I would say that air quality modeling is probably not the biggest uncertainty, but usually you do regulatory impact assessment with one CTM, as if any CTM can convert emissions into PM concentrations perfectly. We know that's not true. There's probably not a PDF you can assume for that, but I think with expert judgment, it's probably somewhere in the ballpark of 30% or something like that. So I think there's probably a bunch of other things that could probably go into the Monte Carlo framework if you're willing to put some of them in with sort of expert judgment and sort of looser probability density functions of maybe uniform or triangular or something like that. Another spot here where I guess I'm not sure why discounting shows up in my notes right now. But it gets a lot of discussion in certain places and not in others. And I think I just wanted an overarching, I know that's determined by other guidance documents, but like a 1 or 2 paragraph sort of summary of this is how all discounting is done. I think that's been talked about. Yeah, so I'll throw one question out, which is, we can all go to gory detail on uncertainty analysis, and Monte Carlo is very alluring for a lot of things. Not everybody wants a PDF on the output, and I think a question I had is sort of what's really useful to the administrator when they're looking at making a decision. Probably doesn't want a full PDF, but central estimate and confidence interval or something like that.
Thank you to everybody for chiming in there on uncertainty. Do we have others who are not assigned to question 5 but would like to contribute to this conversation online as well? I had a couple of thoughts myself while reading this, and I'm happy to say that Rob and Peter just talked about one of them, which was, it seems to me like you give something like BenMap your PM field for with and without regulations, and it assumes that's perfect and then goes into great detail, right, about all of the other sources of uncertainty. So I hadn't really thought of how to address it, but I like the point you just made, Peter, about, you could assume some PDF, and there are a bunch of CTMs out there. So we do have an ability to characterize the uncertainty associated with the exposure itself, which what you were pointing out, Rob. It's not just the exposure response, but the actual exposure. When I was looking at the historical changes, I was trying to separate in my mind, and I don't feel like I fully managed to do so, how if you had a given exposure response function, that was from the past and conditions changed in the future, if you had fewer non-communicable diseases, for example, or more, higher prevalence of non-communicable disease, well, we kind of include that in the baseline vulnerability projection. So it wasn't clear to me like how you determine what's already accounted for, because of people's underlying vulnerability is changing over time, and how, so maybe it's not as big of an issue. But people did raise interesting points, like Jonathan this morning, about COVID has changed susceptibility. That's not the same as it was in the historical time when all these data and epi studies come from. So I do think there's a lot of really interesting stuff here. There is also a lot of overlap, as Joe and Lisa and others pointed out, with the discussion of the topics themselves that we're talking about, the uncertainty about what's the right exposure response function to use in question 1, and what's the right willingness to pay to use in question 4, right? Those kind of unavoidably also address the uncertainty associated there. So lots of interesting comments about the shape of the curve as well. So I think we had comments really on all 5 of these, which is great. We are in the atypical situation of having fewer sub charge questions than people. So that's good. We don't have to like try to encourage people to take more than one this time. But we do still need to try to come up with people willing to lead our response on these.
How do you want to handle the fact that a lot of the economics uncertainty in economic values is going to come up in the previous charge question, so we may end up just referring back to that section.
I think that is totally acceptable and appropriate. And if we,
It's to be encouraged, in
Yes.
fact. So
There's
that
no-
we're consistent across sections. It helps when the SAB reviews our report. Yeah, I would encourage that.
But I guess part of what I'm thinking is that means there's a lower workload for this section because we're taking some of it on.
that's right. Hopefully that's really the case. Yeah.
My not so secret agenda is to suggest that I not take on anything in here because I'll write some of the uncertainty stuff. in there. So if I do other things, but-
You earned it. I mean, I was looking at the charge questions. I know there's not a lot of them, but even B and C overlap quite a bit, and that there's some discussion of, are there other things that need to be given uncertainty treatment, other input parameters that should get the Monte Carlo treatment, or their other sources of uncertainty that warrant identification and evaluation. I mean, I'd be willing to take a crack at B and or C.
You have a preference, B or C? Monte Carlo.
I don't know if it matters too much. I think they're gonna,
Okay.
whether I'm the point or not, I'll be commenting in.
Say again?
I said whether I'm the point or not, I mean. I think
Okay,
I'll
you're
be-
going to contribute to both. Thank you, Peter. Appreciate that. Why don't, how about just to move ahead, why don't you lead B?
Okay. fair enough.
Okay, so then we need somebody who's willing to collate, put together the question about the historical use of historical epi studies, especially. I mean, I think that one's really just primarily related to the epi studies, right? And not so much the valuation. If I'm reading correctly, yeah. So it seems like that's related to how valid are the epi studies taken under historical conditions for future conditions. Any of our charge question 5 more epi folks feel up to that one? Gets late in the day, people don't. Let's see.
Talking about 5A.
Yeah. I feel like I should just pick somebody, but then I shouldn't just pick somebody who's already done, has a leading a bunch of others, but I don't remember who, now that we've gone through so many questions, what the workload is across these. Maybe we could think about the shape of the concentration response function, which was D, because several people commented on that. So I feel that that's probably of interest to several of you. Anybody?
I'm
Ted?
game, Drew, or Rob,
Ted or Rob? You have
or both.
preference?
Yeah.
Okay,
5D.
D,
D.
yes. D like dog. David, whatever. Okay, so we've got B and D. E is quite general, right? C and E, right? Okay, if maybe one of you on the economic side, which I guess includes. Thank you. So maybe, are you willing to, are you volunteering for C and D or just one? Okay, I think that Lisa is actually correct that this will be largely, though this will primarily draw on the material that goes into charge question 4. So let us know if it ends up being too much and we'll try to rope somebody else in.
So all of these pieces and the evaluation piece.
Well, some of these seem focused on one or the other. My impression of this is that 5C, for example, is really focused on the economic piece and not really the EPI piece, but the EPI piece is earlier, B,
So Nikolai, I'm sorry, you're volunteering for,
C,
Thank you.
C and E. Yeah. And part of the EPI piece is, includes the shape, which Ted is gonna lead that bit, although obviously that's not the only uncertainty associated with the EPI is not just the shape. But so yeah, there's overlap. Okay, we had, right, Peter was taking on B, Ted D, Nick C and E, so it's just A. We are very close. And right, A is again the historical, when we take that and apply a historical EPI study to future conditions.
It seems to me that means pulling together projections of baseline without the regulation, health status or mortality, as well as the effects measure and population changes. Sort of it's pulling together all the different pieces of the health impact function, isn't it? And thinking about how they project into the future. It's not just, so the EPI studies give you an effects measure, right? But then you're applying it to the population affected by the regulation. Maybe I'm misunderstanding that, but it seems like that sort of covers the whole waterfront.
My understanding of this is it's specifically related to the exposure response relationship. I'm talking about the odds or relative risk or hazard ratio of an outcome, which is distinct from, the number of people or their baseline susceptibility or evaluation or any of the other issues. So then that might be well directed at one of our EPI people. Like, if we haven't overcommitted you, Rob, I don't know if you're, since you were almost volunteering yourself for D. Maybe you could do A instead.
I like your comments, Nick. I wonder if we could maybe talk a little bit more about it. I'll lead it.
Thank you.
I'm gonna look to you.
Perfect. That's exactly what we want, is a lead of a team rather than, somebody going solo on this. Well, a long day. So I would just end, I think we all have to thank David, who was I think the only one in the room here who was not assigned to one of the first day questions, so has sat here and not been like committed to do anything, but yet you came and spent the whole day with us. So I hope it was useful. And we're looking forward to engaging more strongly tomorrow. And we'll return tomorrow.
well,
for
let me just
BenMap,
ask,
right?
I did see a list of departure times tomorrow. The earliest I saw was 2:15. I don't know if that person is in here.
That's me, right?
That's you.
Yeah,
You know.
2:15.
So what time do you want to leave the hotel tomorrow? 12, 12:15, 12:30. I think that the shuttle leaves on the hour and the half hour. So depending on how risk averse you are.
12:30 is fine.
Okay,
I'm not.
Joe.
I'm risk averse.
Okay.
And so I've changed my flight. Where the current forecast shows 11 inches of snow tomorrow evening in Boston, which will be fun for the kids this weekend
Yeah.
and for me to shovel. But so I've moved up my flight.
To
So
what-
it's now a 10:45 a.m. departure.
Okay.
So that means I'm not going to be part of much of the conversation in the morning. I
All
apologize.
right, can we just take just a minute then to talk about the next steps while you're still here, Joe?
That'd be
And
great.
before we start losing people, if we start talking about this at 12:15 tomorrow, it might be too late. So I pulled up the draft timeline. We've got today's assignments, charge questions 1 through 5. And taking your request into consideration, Lisa, we looked again at this and we think it's doable. Ted reminded us that in previous KSAC meetings, we wrote the letter to the administrator at night after the meeting. But we're not going to ask that. So what we want is for everybody who was assigned to a charge question or who cares about a charge question, send your comments to the lead writer. And I will send out a list of lead writers after this meeting. I've kept them all. Send your comments, your individual written comments to the lead writer and copy me on that email. Drew may prefer not to be copied. Is that your preference?
Well, I don't mind. Actually.
Okay.
Yeah.
Feel free to copy Drew, but please copy me. That's by March 20th. And then by April 3rd, I want the lead writers to send me your consensus response, taking into account what others have sent you and your own thoughts. You're welcome to give preference to your, give primacy to your own thoughts, because this is going to go through multiple iterations and people will have a crack at what you write. And then Drew and I will have a lot of work to do, putting all these pieces together into a coherent report, making it speak with one voice, putting it in our SAB format, drafting a letter to the administrator that summarizes the major recommendations and all that good stuff. So March 20th is your first deadline. Send your individual written comments to the lead writer. April 3rd, excuse me, is your second deadline for lead writers. And I'll send out the list of lead writers. That's all I had, Joe. I just wanted to get that in before tomorrow's rush.
Just as a question. So we're not going to have sort of our own individual reviews that go into detail, some other comments.
No, it's not. We're
on
not
this.
using the KSAC model where we
Okay.
append individual comments. We just want one consensus draft report. Yeah, the SAB's always done it this way. Only KSAC has the individual written comments appended.
Any questions about that part?
Yeah, if you go to, when I send out the list of lead writers, you can use that group list, which I'm expanding with 3 people had to give me a second email so they could get on SharePoint. So it's a larger list. So I'm just going to use like a list of 24 emails. Some people will get duplicates. Yeah, I'm not sure I can keep
Yeah, I was
track of 2
gonna-
different group lists.
I was gonna second that because if someone just sends it to my secondary one. I'm
Okay, we'll
never
go
gonna
back. We'll
see
go
it.
back. I'll go back to the original group of emails. But if and when we decide to use SharePoint to write the report, which I think I'm going to try to do that because it solves all version control problems, then I'll need to use your second emails. But I'll go back to the original group list.
Can I, and I think you said this is okay, but can we create the document using something else like Google Drive, which I imagine the government can't use, but can we create it with Google Drive, but then when we give the final version to you, we give it on SharePoint?
I'm actually not asking for your individual contributions on SharePoint yet. I mean, what I envision for SharePoint is once I have a consensus full document in SAB format, then I could post it on SharePoint and you could offer any track changes on that. And then we solve the version control problem. Just sort of at the last step. And it's really nice because I've set it up so it sends me alerts. So if somebody posts something or changes something, I automatically get an email and it's got a nice subject line. It's wonderfully organized.
But maybe I'm asking Matt's question again. In this March 20th to April 3rd, when we've got a subgroup just working on a specific piece, the lead discussant has drafted, I took all your comments. And
Oh, you can use whatever you want to.
Okay, all right. It doesn't have to be by.
Although I
email.
can't read anything if it's on Dropbox because EPA employees aren't allowed to use Dropbox.
Okay. So
Maybe-
does that violate any rules? Because you're not.
Yeah, I
CC'd?
need to, unfortunately, I have to keep a record of everything. So
I think.
I can't read. If you send me a Dropbox link, I can't open it.
I can maybe clarify that SharePoint is like Microsoft's competitor to Google Drive. So
Yeah.
they're similar products.
Yeah.
So there's like a Google Doc equivalent that we could use.
That's what SharePoint's supposed to be.
Okay. If it works, I'm happy to use it.
Yeah. You need your mic. True. I think you can use SharePoint in the way you would use Dropbox. I think I've given everybody editorial rights. You can post a file there and ask people to comment on it.
So we could make,
So you could.
folders for each of the.
That's true.
charge
That's true. Feel
questions.
free.
Right, and we could all
It's-
use that since.
But
now
then we
we're
have
all
to use the
able get that.
expanded email list of 24.
Right.
Oh, yeah, there's an upload button. That's about all you need to know. Okay, thank you.
Good. All right, well, I think we, again, thanks for all the EPA team, all the support, and I think we are done for the day.
Yes, we're adjourned. See you
So-
tomorrow.
Yep, done.
Yes, thank you.
No, good. So long online, folks. See you tomorrow.
Thank you.